things function in the cath lab. A lot of the basic things will be covered in this whole session, which will go until 3 p.m. Yeah, and then you have a hands-on simulation training way back in the manual. So having said that, I'm Dr. Kinney, Director of the Cath Lab here at Mount Sinai Main Hospital, and I will be the Director of the Interventional Fellowship, Structural Fellowship also. So I'll be talking very basic anatomy, physiology and imaging, what we do in the Cath Lab. So going to the anatomy, this is a very important part since we are starting in geography. All you need to know. So left side coronary artery comes from the left sinus, okay, usually mid portion anterior. It divides into two, circumflex that goes to the back of the heart and LAD comes to the front. Now why you need to know this also is 10% of the time left vein is absent, okay, it has separate origin. When circ and LAD comes separately, LAD is slightly higher and anterior takeoff, and LAD and the circ will be posterior inferior takeoff. Why do you need to know that? Is your catheter is different size. Since it is anterior takeoff and slightly shorter, if your catheter of 4O means left side, which is Judkins 4O, gets into LAD, you will need a longer catheter to get into the circ. Very important for when you're doing just regular cath as well as PCI. And that could be a question, that length of the left main. Length of the left main could be anywhere between 0 to 10 millimeter. That question is always asked. 0 means no left main. It's an anatomical variation, not an anomaly. And what can happen, the separate origin. So when the left main is longer than 10, and when you see that first, that means there is often anomalous circumflex that's coming from the left side. That is anomalous, and that's the commonest anomaly, and that's the question also asked. The commonest anomaly is the circumflex that is originating from the left sinus, right sinus, and it goes posterior to reach the posterior part of the heart. So having said that, let's go here. Most of the things are spoken. Once it comes out, the branches are septal as well as diagonal. So diagonals usually originate from the LAD. Many times there is a vessel that comes here in between, that is the ramus. Okay, it's called ramus intermedius. It comes between left main and LAD. So why this is important? Because in syntax core, there is what's called as a trifurcation. Okay, that's only important when you're doing procedures, that you could be distal left main, ostial LAD, ostial circumflex, all involved, and if the third one is originating, then becomes trifurcation. Your syntax core really goes up. Now knowing that diagonal, which we always concern about D1, D2, and D1, D2 originates and supplies the lateral wall. More important, if somebody is coming with the lateral ST elevation MI and you don't see anything, look for a occluded diagonal, often occluded ramus. Okay, so that is that part of the thing. Now septal, not that important, but they can ask you, because septal often, it goes through the interventricular septum and meets with the interventricular septum of the PDA. You understand? This is important for collateral formation. And two, if you want to become a CTO operator, you want to do retrograde. That's how you traverse the septal. So you have to know this and that. Other important, if people who want to do structural, it is rare, but since mavacamtum has come into picture, we don't do that many septal ablation. But if we are going to do septal ablation, you got to know the origin of the septal vessel. So you see it originating from the LAD. So it can originate from the ramus, originate from the left main. It could be just originating from the right coronary, just at the ostium, and coming on to the left side. Very rarely from the circumflex. So you got to know all this origin, often required to do septal ablation. So that part is the LAD. So then going back to the circumflex is not a lot, goes posterior, and the branches are OM. So right side, why right side is important? you have to know if you are dealing with the right coronary artery infarction. So as soon as the right comes out, which is often from the right side and just at the center, many times it's a little bit anterior takeoff. So why this is important? When you're trying to engage and you are rotating the catheter clockwise, it stops because it's already engaged in the right coronary artery. That's anterior takeoff and goes down. These are all anatomical variation. They are not anomalous. So branches of the right side, you have to know. Conus is the first branch that comes out. This is another question they ask, separate origin of the conus in 10% of the time. And in that case, many times it's slightly higher, and when you're engaging the right, it gets into the conus and you'll see ventricularized damped pressure. Try not to inject because it can give you ventricular fibrillation. So 10% of the time, separate origin, that's the question that can come. The conus that's coming up the right side can go anterior like this. So this is the pulmonary artery and gets into the septal. And that is the circle of Vuesens, and that question always asked. Okay, they can show you an angiogram, show that collateral and ask what is it, or they can ask you just like that, what is circle of Vuesens? You have to know how it is made. So it is a conus from the right side to the septal of the LAD, and that's how it is formed. The first branch is RV branch, very important. If RCA occluded before that, you will have RV anterior ST elevation, and patient can go into RV failure shock. That is just for the clinical reason, but they can show you EKG and ask where is occlusion of the right side. Then is acute marginal. Then it goes all the way down to the crux. Crux is the meeting of the interatrial septum with the interventricular septum, goes down all the way to the apex. So this is the, like I mentioned, septal come up, septal of the RCA and the septal of the LAD. So that's where we are. So we are done most of the time. So if you see here, left main bifurcation, which is key, okay, which you'll understand. So I went through this, all this I have gone through. So Judkins catheter will find left side by itself unless you manipulate. So manipulation is only required to engage the right side. So if it is watch for damping, separate origin, separate catheters, I said larger for circumflex. Now these things will be given to you, so you go through that. Every single line, every single point could be a question, so you know that. So clock goes posterior, counterclock anterior, they will ask that question because somebody is trying to engage LAD, cannot engage, what are the movements that you need to do. So you understand. Optimal views are often asked, okay? So distal left main is caudal view, okay? Not ostial left main. You can miss ostial left main. So distal left main is caudal view. Of course, you can see cranial or straight AP or AP caudal. That gives you that. I went through these branches already. First septal. So first septal, origin of the LAD to first septal is proximal. Many times, rarely people do say diagonal, so keep it in mind, that question may come. Then, from the first septal origin to where the vessel starts going down and out is the mid LAD, from there is the distal LAD. So the good view for LAD is cranial, okay? So circumflex is always the caudal view. This question can be asked, what percent may not reach? Then supplies 45 to 55% of the left ventricle. The views, remember the views, cranial views for LAD, which is either aleocranial, apicranial. So most often we don't go to aleocranial because again, a lot of radiation, you'll have more lecture on that, but radiation, how to decrease radiation, there will be at least 5 to 6 questions, okay? Movement of your cameras, movement of the table, how to decrease the radiation. They're only worried about the patient's radiation, so it's a little different compared to operator's radiation. I like to teach about operator radiation because we are in this field for years and years. Patient comes for a couple of times and goes, okay? So we got to be taking care of ourselves. Then we went through this left main, circumflex prox till the origin of OM, then becomes distal circ. First branch is called the OM, down and out. LPL is the straight vessel that goes down. So for the circ is a straight RAO or sometimes caudal. Okay, so that is how you get that. AP caudal, LAO caudal. And right, I already went through. One branch that I did not discuss is so first branch is conus, remember that. They can ask that, and 10% of the time separate origin. Second branch is sinoatrial. Sinoatrial gives rise to the sinus node and comes down to the atria. That atrial branch then forms arborates with the AV continuation sickle cell branch, and that is the Kugel's artery. And that also question can come. Many times this can be AV nodal coming from the circumflex also, but that question is often asked, so remember this. These are all easy questions. You know it, boom, you get your answer, move on. So you finish it. So circle of Vucens, I already told you, like I mentioned, if you see this, okay. So often what happens is LAD is occluded when you do the left picture, and then in your LV gram anterior wall is functioning. So how is the LAD filling? You don't see it, right? So when you do the right, you can see the circle of Vucens that's filling the LAD. That's number one. Many times you don't see it. There's no circle of Vucens. Why? Because the conus is a separate origin. So look for that conus, okay? Nowadays, I don't know, it's important because everybody gets a CT first. So I have yet to see anybody mentioning this collateral on the CT scan, but maybe they'll start looking for that. But this is a very easy question for you. You'll be like, get through it. Other thing they do ask, or they'll put it in the question. It'll be a long question, but what they're trying to ask is it a type C lesion, B2 lesion? So very simple things for you to understand. We published this in 2006, way before the complex guidelines have come. So if you have intermediate lesion, remember anything 50% and above we call is significant. Definitely 70% is good. When it is intermediate, you have to do physiological assessment. That's the key. So it is now all over the guidelines. So they can say that patient had angiogram, left main is about 50%, and then everything else is okay. Imaging could not be done. So if you have to do the physiological testing. Now, you have to know what is type A, B1, B2, but if you can't remember all of it, just go to understand what is a C lesion. So less than 10, discrete is type A, right? Understand, no calcium. When there is moderate to heavy calcium, here where they can get you, they'll say moderate to heavy calcium, it is B lesion, because people think moderate to heavy calcium is C. It is not C, B. 10 to 20 is B. Anything more than 20 millimeter long, 2 centimeter becomes C. So this used to be once upon a time before all the technology changed, the success rate. Success rate is different. So angulation and all that we can talk, but important is more than 2 and total occlusion. Definition for total occlusion is important. Occluded vessel for more than 3 months with no distal flow, no TIMI flow, okay, occlusion, and degenerated vein graft. So osteal lesion, bifurcation lesion, all that comes into B. So these kind of important differences, make sure you learn, read. That's the only way you'll remember. Keep reading these things, yeah. So this we have gone through. You can tell me, what is it? If LMC is absent, right? What catheter would you use to selectively engage the LAD in this setting? Everything is true except, do you need a larger catheter to engage LAD? It will be a smaller catheter, right? So that is not the right answer. Larger catheter is for circumflex, remember that, right? And clock is for circumflex, counter is for LAD. So what is Vucens? Yeah, good. At least I did mention this. This comes in cardiology boards also. So anomalous circumflex that comes from the right side goes posterior. So that looks like a nipple. You see that? They will just show you an angiogram and they will show you this. So you have to get this. 100% question. So moving on to physiology now. There'll be, I think, more physiology done by anybody else. I'm not sure, probably not. Because physiology is coming into equation a lot, and more AI-guided physiology is coming in. This is the true physiology. So if you see here, epicardial vessel is about 5%, but majority of the cardiac thing that you're seeing is arteriolar 60%, and about pre-arteriolar is about 20%, and then you have way further down certain capillaries. So you need to understand right from the origin up to the capillaries, because many times what we are seeing in angiography is right here. We don't see this and this. If there's any abnormality here, we don't know. We say, okay, normal coronaries, no obstruction, but patient continues to have angina. So that's the time you need to do IMR, CMR, microvascular testing, which is now becoming a routine and very important. So now going back to epicardial assessment is what? You have to do FFR, IFR, RFR, and there are other technologies that's coming out while we are imaging. Not approved by FDA, but it will be out soon. So numbers are very important, because once upon a time used to be a different number, but right now FFR, remember this number 0.80. They'll put a question, they'll show an intermediate lesion, and then they'll give you some numbers. So FFR, very simple. There is a stenosis here, so you're getting a pressure gradient from distal to proximal. Okay, proximal has to be aorta, so very important. Make sure the guide is disengaged, not inside the vessel. You could be dampening, and this measurement could be wrong. Outside, after you cross the vessel, and this pressure transducer is at least 15-20 millimeter distal. Okay, so you have to get a pressure proximal, distal, and the gradient that is coming is a blood pressure difference across the coronary stenosis to determine if a stenosis is physiologically significant, which can impede oxygen delivery to the heart muscle. So that is FFR. So to do FFR, also what you need to do is you got to give a hyperemic situation. That this becomes exaggerated when you cause hyperemia here, which means you take into account that the endothelium is functioning normal. You take into account, and then when you give adenosine, this dilates, and the stenosis exaggerates. That's why you need hyperemia. But more and more people are going away from it. You see 10-15% of the patient cannot take adenosine. They have reaction. If they already are on, they have asthma and on inhalers, you cannot give adenosine. They get exacerbation of their bronchial spasm. So then there is what is called as instantaneous flow reserve. Okay, you just take that wire, go across the lesion. So in an instantaneous flow reserve, which is what we say is, this is how it happens, right? The blood pressure goes up, then there is a dicrotic notch, and this wave comes down. So instantaneous is a wave, diastolic wave-free period. You're just taking this part, and that is 0.89. So FFR is 0.80. Okay, remember that. So anything less than that, which is 0.79, 0.78, then it becomes positive. You have to give adenosine. So for here, you don't need, it is just resting phase. Okay, so the difference, diastolic. So what is happening is, this is aortic pressure. Okay, this is the distal pressure. So not in the systole, diastole, when the vessel is, coronary vessels are getting the flow, you have to see if there is a gradient, and that's what it is, and that's what that you're doing it. Now, if you see here, dicrotic notch, PA, this is what we explained, wave-free period, very important. Okay, this question can be asked, the difference between the two. This physiological difference, you have to know. They can ask you a little bit deeper down question. This is a pitfall, and all that is for you as a fellow when you start doing procedure, that before doing RFR, have intracoronary nitrate administered, okay, so that your vasomotor tone is good. Make sure there's no bubble in any of these lines, otherwise it interferes. Remove the introducer, otherwise again interference, and you need to equalize the pressure before you go in, so that the aortic pressure and the distal tip pressure. So this is not the here, the transducer is somewhere there. They got to look okay, and then there's two things. So when you see a true gradient, you see how you see this gradient, diastolic also go down. This is a true gradient. They will show you a picture like this. Means they will they will not show this, they often show this, and then they give you a number and they'll ask, should the intervention be done or no? So this is not normal, it's a drift because there is some issue with your transducer. That's why you have to make sure your transducer equalizes before you go, and you're going into the artery. If you think it is positive, right, you have to pull back, slow pull back, and when you come to the proximal part, whether it's the right side or into the left main, it has to go back to 1. If there's a difference, that means your transducers were not right. So your drift, you have to differentiate what is a true gradient. Look at how this diastolic goes down versus diastolic doesn't go down. That a same morphology, parallel shift, dicrotic notch, well visible. That is the key. Here dicrotic notch disappears, here it does not disappear. So this can be shown. They can ask you this kind of questions, some basics of the physiology. So right now, left main, non-left main, it's class 1, okay? Physiology. Not so much anatomy. Anatomy more for understanding the expansion. This may be asked, may not be asked, that if there is a focal lesion, okay, not tight, less than 10 millimeter, focal 15, you see a nice abrupt change. Often you don't see this kind of lesions. What you often see is diffuse or tandem, right? LAD proximal, mid, distal. So when that kind of thing happens, you see this abrupt change. So these kind of things you need to be just watching for, and usually IFR, RFR are a better measurement rather than adenosine being given. So diffuse is, you see that distal is positive, often seen in diabetic patients, and then as you're pulling back, it goes up. Now there is no true disease. You don't know how you're going to take care of this because it is diffuse atherosclerosis and concentric lesion. So it's not difficult to understand. So it's a lesion-specific physiological assessment may be challenging if it is there is tandem lesion and diffuse lesion because you don't know how to take care of the patient. Now going to distal microvasculature, which is again subject by itself, okay? But they will ask you a little question on CFR and IMR. So right now, there are nice new catheters and wires that are available can do that, which is wire-based thermodilution where you can get your IMR. So you know where you're checking the IMR. So IMR is real true microvascular, and CFR is slightly the whole thing, which is the vessel as well as the distal microvascular. So CFR number you need to know is about 20 and IMR is 25. Now these things are very easy to do. You use the wire, you think normal coronaries, but you want to understand microvascular, you take the wire, go all the way down, do your measurement, and the machine automatically calculates everything. So you need to learn how to do it. Resting CFR, then 3cc saline injection, induce hyperemia, again injection, and the result comes on the machine. So these steps, you got to do it right. Okay, everything has to be done right. And once you do that, those numbers are given. Your job is to know the numbers because they're not going to ask you these steps, but they will ask you the number. They'll give you a question and try to ask you the number so you know the number. So in persistently symptomatic patient, and what will happen is these guidelines, the key portion of the guidelines in everything you need to know, you need to memorize that because these guidelines are often asked, for whatever reasons they are. So in persistently symptomatic patient is class 1A, that if you have suspected anginal symptoms that you want to do microvascular training. So now this is where we are. Which of the following FFR value does not indicate an ischemia producing lesion? Huh? Good. You know the number. So why we are saying is FAME is the one that made it. Okay, that question can come because they like to ask certain important trials And people, there are somebody who is going to discuss all the trials also. So threshold became 0.80 after FAME trial. Before that was differ, and that was points of which you don't even know, but now it's 0.85. Two discrete intermediate lesion in the RCA. Which strategy gives you more specific lesion information? Yeah, I told you IFR pullback is better. So tandem lesion assessment. 60-year-old male, 6 weeks after transmural infarction, having akinesis inferior wall on the echocardiogram, 85% residual stenosis in proximal part of the dominant RCA. FFR, there's 85.88 and CFR is 1.2. What is CFR normal, abnormal? Abnormal. No, 2 is the normal number. So what's the reason we have abnormal CFR? Yeah, which one? C or D? D, right? Because it is falsely positive because of your microvascular is destroyed, the muscle hasn't recovered, so don't go and stent that proximal area right now. Quickly, we are going to go through intravascular imaging, which is, so there are two intravascular, which is IVUS and OCT. They can give you pictures, okay, they'll show you all of this. So try to, now we have the app, right? People have downloaded those apps. We have Octade and IVUS. Download the app, we have so many images because you need to understand the images. Images can be shown. So the good strength of ultrasound is that good for ioto-osteal lesion, and if you're doing for these things. So pullback is used to be very slow, 0.5 to 1 millimeter, but now newer ones are coming up to 8 millimeter. So if you see the depth is a lot. So it penetrates, so you can understand the EL, means the external elastic lamina better, other than OCT does not give you. So this uses light, this uses ultrasound. So more important is the depth is not a lot. You see that? But what happens is since depth is not a lot, the resolution is much better. It's 10 to 15 micron, means you can see better. Like you can see, it's nice, beautiful pictures. This is black and white TV, this color TV, you see the difference. It looks beautiful. This speed actually has become faster with the newer techniques that are, the newer ones that have come. So what happens is, this is just come into market this month. It was 36 or 18, now it is 72. Within a matter of 2 seconds, the whole pullback is done. So it becomes faster and you are able to understand. Know this, they can ask you these questions. You see that? Adventitia, media, intima. 3 layers, very important. Same thing with IVUS. But you are able to see that depth better. These pictures, just memorize them. Fibrous, you see that? This is when it's soft and low acoustic signal, it looks dark, could be lipid. Calcium, what you see is very thick and you don't see anything behind. So remember that, same thing here. Here you can see a nice demarcated calcium. This is high attenuation, lipid, fibrous cap. You see that this is thick and fibrous. So one good thing is now there is AI in the IVUS. So once you use it, it gives you automatic lumen, automatic EL, gives you the length you need to understand from where to where. So always this is available now, okay, taking the human equation out, AI is doing all the measurements that can be helpful. So 2023 IVUS versus angio-guided PCI, and then Renovate versus, which said that imaging guided PCI had a better outcome. Same with the complex lesions, which was October 2023, which showed that. And then the other one was iLumen, which only did OCT, which also showed that was equal, OCT and angio-guided. But if you take complex lesion subset, definitely the OCT guided outcome was better. So all these trials made it to the guidelines that in ESC and so in stable lesions, right, IVUS OCT for anatomically complex lesion, especially left main, true bifurcation, long lesion. Try to use imaging to understand the lesion morphology and post-procedure optimization. And in USA, they made it for acute coronary syndrome and some complex lesion that try to use it, made it number 1. For you guys, if they're trying to say, but what happened is this year in ACC, 2 trials came out with just a neutral findings saying that you don't need to use imaging. Without imaging, you are able to get the same outcome. The 2 neutral trials were optimal, and IVUS CHIP highlighted the importance. But what the issues were that if you're doing it, do it right. That you use it for pre-assessment, lesion, proper lesion preparation, and then the post. So if you want to do one time, then apparently post is very important to do that. Whereas important is how to get your diameter, right? I don't know if these questions can come, but if they can come, EL to EL, which is the outermost, then you downsize. If you're using the lumen diameter, then you upsize a little bit when you're doing the stenting size. For the final result, you are important to make sure there is distal edge dissection. There is no malopposition. They can show you this picture, okay? And they can ask you these numbers, right? So when do you say you have done a good PCI? Your proximal left main more than 8 and distal left main more than 7, and LAD circ is 5 or 5.5. So you can remember as that way. So 8, 7, 5, 6. That are the numbers you have to remember for the thing. Detection of calcium is important, right? You can do angiography detection. You see that? Tramp track calcium just on angiogram. This is intracoronary IVUS calcium, and this is the thickness of the OCT. This score, they may or may not ask, OCT score. So when you have at least, it's considered the whole one circle, 360 degree. If it is half, it is, it's considered 0.5, right? 50% of the arc. That gives you 2 points. The thickness is 1 point, and the length, which is 5 millimeter, is 1 point. So that is how they calculate, if that's there, to give us, and we have several publications related to that. What I would say is download this app. You see, we have quiz there. Instead of me giving questions, you go through all those quizzes, and then the images. So the images definitely are being shown. Download those things, and of course, every other month we are doing imaging live cases. We have done it for 1 year. Kiyusuke. There's Kiyusuke right there, our imaging guy. So this one has just been approved. We were the first one to use this on Monday, first in human, first in the world. Tarumo, you will see during our live cases tomorrow. And SpectraWave has come, Deep OCT, which can understand OCT and NIRS together. And this is the Ultron 3.0. It's just a software which is now including lipid detection also. Usually in the OCT used to be calcium, but now there's lipid detection. So what's the question here? That's the lipid, right? A to A. Then becomes fibrocalcific, right? And then becomes the thick fibrous. When you say vulnerable plaque, what is a vulnerable plaque? Thin cap, right? Is there a vulnerable plaque here? That is the one. 60 anything less than 65 micron makes it vulnerable, thin cap fibro, okay? This is very thick cap there, so you don't need to worry. Then which of the following not measured to report the extent of coronary? Yes. TAV, percent atheroma volume, lumen cross-sectional area, minimum fibrous cap thickness. Not measured to report the extent of coronary using IVUS. Which one? D, right? To understand the cap thickness, you need the OCT. You can't do it with IVUS. Which of the following OCT images is most likely to correlate with this case? Substernal chest pain. So young patient, Electrocardiogram. So what is likely happening in this patient? Is it plaque rupture or erosion? I think it will be B, erosion. Plaque rupture or erosion, but most often in a young male is likely a erosion. Erosion means there is degeneration of the endothelium. So these are all the other new app that is out is the hemodynamic app, that one that I discussed today, all the FFR, CFR, that is there, and a lot of quiz in there. So I would say download it and go through all those cases, because many cases and we are showing the thing. Let's go to the next slide. We're going to go there. So I'm going to talk on two things only, which will be aortic valve, mitral valve, okay. So when we say, when we were, or once upon a time, used to be severe aortic stenosis and patient had to have symptoms. From there, they have gone to only asymptomatic severe, okay. So asymptomatic severe aortic stenosis also getting treatment. So there is a movement towards that. And moderate severity where patients have mild to moderate but asymptomatic, this is right now in the trial, but asymptomatic severe definitely should be considered for anything. So what you need to know is these trials, they can ask you any of these trials, okay. It started from 2010 where we started with prohibitive risk, then came to high risk, partner A, right, then came to 2016 intermediate risk, then became low risk. And then that was for the balloon expandable valve, and for self-expandable valve it started 2014 up to 2019. So all these trials, they can ask you not when they were done, but outcomes. But essentially what they first showed is that it was, what was the finding is safe, effective in treating as all STS scores. And STS score questions can be asked, so you have to download or understand what those STS score, there is a website, and understand that. With outcomes compared to SAVR, death and stroke. Now the question comes is, it's not who should get TAVR, question is who should actually get the SAVR, which is surgical AVR. Then what is happening is who should get it and what's the age. So at that time you have to consider the life expectancy of the patient. So decision making is very important. So this is important even for a clinical practice. So what are the important factors that you need to consider while considering anybody for TAVR is age, surgical risk, frailty, valve morphology, which is patient is tri-leaflet or bi-leaflet, femoral access, means 95% have to be done femoral. Alternate access should not be considered at all. If there is concomitant other valve disease, okay, then try to send them for surgery. And of course, if there is extensive coronary artery disease on top of aortic stenosis, consider AVR plus CABG, and other factors like you have endocarditis, you have a septal hypertrophy, you want to do myectomy and surgical AVR, that kind of things. But age is very important. 65, anybody less than 65, actually it's becoming 60 there. Used to be 70, became 65, now it's becoming 60. But anybody 65 and lower, consider surgery. Anybody above that can go for 80 and above, definitely should go for TAVR. So this is something that you need to know. So low risk, intermediate risk, high risk, understand the CT, STS risk score there. So 65, 80. So this is the cutoff of age and above. So a question may come with a certain age. They can give you the CT scan morphology showing bicuspid, complex anatomy of the valve. So when those kind of things, you have to know whether you have to consider. And taking into account why this age is important, if you are doing a TAVR in a 68-year-old, usually these valves now last between 8 to 10 years. And after 10 years, what are we going to do on that valve? So what's the issue with this? Because surgical valve, They remove the native valve and then place the surgical valve. Here, the native valve stays, then you do a tower valve. Then when they're coming second time, then you're placing another tower valve, so the space gets limited, so it becomes smaller and smaller, so you have to take that into account. But most often what happens nowadays, people do not want, because recovery is if somebody is 65, he's in that part of the life, they don't want to be taking 2 months off from their work or something. They'll say, I will do tower now, later on maybe I get surgery. So everything is heart team discussion. That many time, any of this complex question comes, which is related to coronary artery disease, tower, when you see heart team or multidisciplinary discussion, that's the answer. You pick that, okay? It is a combination of mostly interventional cardiologists and surgeon. And when I go to mitral, you have to include the heart failure doctor. So the heart team discussion is a key. So when the initial trials were only balloon expanding and self-expanding, then subsequently became this another new valve that came out, FDA approved, which is also a self-expanding valve. So these are the 3 valves FDA approved available here in the United States, but outside there are many more valves. So if you see the number of cases we are doing, way beyond, more than that. Like we said, femoral access is the key. Try not to do other alternate access. When it first came out, it was apical. Then in rare situation, we do carotid, subclavian, or direct aortic. These things are not done. Rarely we do carotid. The 2 things, when you do femoral, if you can't get percutaneous access, then sometime we get vascular surgeon to do that. So that's the thing. Then what are the complications? These questions can come, which is more often is 8 to 10% risk of 2 to 3% risk of stroke, and need for the pacemaker is around 7 to 8% now with these valves. But bleeding, AKI, and more important, PVL. Now the reason why they get PVL, you need to know, and we will talk about that. What's the reason for PVL? So this is why a CT scan is important. So the valve size is based on the aortic annulus, okay? And then look at the calcium. This kind of calcium, severe annular calcium, and this kind of calcium at the annulus and the leaflet will not allow expansion of the tower valve and give rise to paravalvular leak. So if you see this kind of anatomy, again, if it's an 80, 90-year-old patient, you got to make sure the patient and the family knows that even we do tower, there could be slight leakage. So you say this question beforehand. Another important thing is the measurement of the left main. Now this should be more than 10. When it is lower, we discussed the left main and RCA, the height. When the valve is placed, there is a risk of coronary obstruction. Risk of this is very low, 0.5, very low, but still can happen. So these are various, valves. You see that are. This is the same valve, but what I meant is out valves available, or they are 1 or 2 valves are currently being still evaluated. Okay, but question comes is rarely they can probably ask is a balloon expandable or a self-expanding valve is better. So for a younger age, patients with coronary artery disease, balloon expandable is better because of the shorter height. Your coronary access is better if the patient has CAD. And the risk of pacemaker actually has gone down in both. But if there is a risk of pacemaker because it's underlying bundle branch block before you start the procedure, and then when you place the valve, this what happens is the base of the valve goes and interferes into the interventricular conduction. If you think the risk is there based on the EKG at basement, try to go for the balloon expandable valve to begin with. Then in the last 2 years, early tower, asymptomatic early tower. So asymptomatic means your gradient is really high. Normal is what? 4 meters per second. If it's anything above, especially above 5, even if they are asymptomatic, something has to be done, because the first symptom could be death on that patient. So 2 small randomized trial, if you see that recovery trial done in Korea, this was done in Serbia, which is showing that asymptomatic clinical surveillance versus surgery, early surgery was better. You understand? Asymptomatic severe AS, just don't let them be, because so early tower, 901 patient done here in the USA. They presented in TCT that came out in last year, which showed compared to clinical surveillance, tower did better, all of that. So what important was, if you delayed the AVR, they presented with the acute valve syndrome, means they came with heart failure and required emergent procedure. So what we are trying to say is, don't do that. Then this is often asked question, may come, what is the data? Because it came out only in, for the last 15 years. So 10-year data, and what is the 10-year data is telling us? Yes, compared to SAVR and tower is comparable with the 10-year follow-up, that the tower valve is way better compared to SAVR valve in many reasons, in certain important conditions. So yes, 8 to 10 years. If somebody asks you, say 8 years for definite, maybe 10 years, okay? Then aortic regurgitation, this was recently approved. They're not going to ask you, align AVR, but this is just for you, that this is a different kind of a valve, because they have an anchor, because in true aortic regurgitation patient, there's no calcium, okay? So you needed this special, and finally got FDA approved for us. So if you have concomitant coronary artery disease, like I said, depending if the age is young, send them for surgery, but there's a trial that's ongoing, that after you do tower, you randomize them to medical therapy versus PCI, and then you see median follow-up 3.5 years. This trial is still ongoing. Once you have tower, engaging coronary artery is not easy. I always say it's another fellowship by itself. So if that is the situation, we have another app where you will download this also, understand how you need to engage coronary arteries through the tower valve. So this is what we are. So which of the following is true about the BEV, that means balloon expandable versus the self-expandable valve? Is it self-expanding have a higher rate or balloon expandable? Yes, though I did not highlight that. Good. Then comes 75-year-old female presented with the progressive shortness of breath. Transthoracic echo revealed significant aortic valve calcification with a peak gradient 4.2, no AR, normal left ventricular function. Cardiac cath shows no obstruction, STS risk score 2.4. Now, do you know the STS risk score, what is low and what is intermediate? Anything 3 and less is low. 3 to 7 is for intermediate. Anything above 7, 8 is high risk. Remember that. And like I mentioned, what are the criteria? You got to go to the website and learn that. Which of the following statements are true regarding tower in patient with low risk for surgery? Repeat hospitalization was lower in tower versus SAVR? Probably, right? Risk of disabling stroke is higher with tower compared to SAVR, yes. Durability of tower valve is superior to surgical valve. You cannot say it is superior, okay, it's equal. Result from randomized controlled trials of tower in patient at low risk for surgery after 1 year have not yet been reported. Wrong, it has been reported for low risk also. So the only thing is repeat hospitalization was lower in tower versus SAVR. Partner 3. Then which of the following statement true regarding the incidence of stroke related to the tower? One thing that I did not discuss is the embolic protection device, because it's rarely used at this time now, right? Embolic protection devices have been shown to reduce the overall incidence of clinical stroke? No. Dual antiplatelet therapy has been shown to reduce the incidence of clinical stroke? No. Oral anticoagulation has been shown to reduce the incidence of clinical stroke related to tower? No. Actually, other way around, it was stopped the trial was stopped. Rate of disabling stroke with the current generation tower devices. Of the four, that probably is the best answer. What do you think? Yes. Let us quickly go to mitral regurgitation. Everybody better know primary, secondary. So secondary is more common than primary, right? So primary is what? Valve problem. Secondary is muscle problem. Muscle problem dilates and becomes functional. So is there a treatment for this thing? So when you are talking evaluation for surgical interventional risk, same thing, right? Like I mentioned, for patients with valvular heart disease, intervention is contemplated. Individual risk should be calculated for specific surgical transcatheter procedure. Essentially, what are they trying to tell you is heart team discussion. And then risk assessment for surgical valve procedure, STS risk of death. 3, right? And then anything more than 8 is high risk. So these numbers, they may ask you, so learn this number. Another thing is frailty. We never take into account frailty, and surgeons always do. So what important things they included in frailty? Feeding, bathing, dressing. So when the patient is coming to you in your clinic, and then he is already on a wheelchair, not able to move from bed to, we already know it's frail. So once it's frail, the surgeons don't go into touch. So that's why risk of assessment for surgical valve procedure, STS risk and frailty index. So this is becoming very important for surgeons and even for us, because if the patient is mentally okay and the family wants something done, frailty index is key. And like I mentioned, in your big quiz, it will be this long question, this, that, this, and then if there is a multidisciplinary heart team, MDT, that is the answer, okay? Just pick that. Because every case of the valve, your heart team discussion is the key in this patients. So, if there are two, right, primary and secondary. So, primary, often the treatment is, there's not a lot of medical treatment. Often, it is something pathological problem, and surgery is the treatment. But if the patient is prohibitive risk, high risk, FDA approved CLIP in 2013. Okay, so that is a very important thing, that they may show you some echo, and you should understand the pathology, and then if it's primary, you can use that. If it's degenerative or functional, fantastic 4. You better know all these 4 medication. So we got to make sure they are on this fantastic 4. So EF less than 50, functional, they got to be on medication, and there is minimum moderate to severe MR. What we see is as soon as you put them in any of this fantastic 4 medication, moderate to severe becomes mild, especially this SGLT2, ARNIs, they are so good. Patients feel much better, symptoms disappear. In that case, there's not an indication. So the difference is very simple. For primary, you can directly go for either surgery or for percutaneous procedure. But when it's functional, these medications have to be added. GDMT is important. And that GDMT, you can do it, but more important, in that heart team, they'll ask for a CHF doctor. So this is just an 2 kips deployed, TE and a fluoroscopy. Okay, what happened to the hemodynamics? Blank. And you could see that after. Some of the important trials that were required for functional was MITRA FR, COAPT. MITRA FR was done in England. No difference between medical therapy versus thing. COAPT was the first time that shows that death decreased, heart failure readmission decreased in this patient. Okay, that when you do it. The biggest difference between the two, if they can ask you, MITRA FR, they started therapy after the CLIP. In COAPT, like I said, fantastic 4 first. After the therapy was given, if they still had MR, then they went. Means the LV was not too dilated. Then they went and had their CLIP. So they did better. Another important is you do not change your medication. Okay, you did the CLIP, that doesn't mean you stop the medications. You continue the medications. Then this was again done in Europe, Reshape, which was equivocal. Recurrent heart failure and CV death definitely decreased. Okay, but they now did heart failure, moderate to severe mitral regurgitation after the treatment. So if you see here, MITRA FR and here, that kind of LV, look at this LVEDP and ML, which means these were really dilated end stage cases compared to when in COAPT, they did it way before it reached end stage. So that is why the EROA and proportionate and disproportionate MR comes into equation. Disproportionate MR means your LV has not dilated, but there is mitral regurgitation. When it is severely dilated and severe mitral regurgitation, your clip will not work at all. So that's where we are. And so this is indication is MV surgery is recommended in patient in severe ventricular SMR. Okay, but if you can give treatment, you can consider therapy otherwise. Now, are there devices? Clip is one thing. The devices, if you see here, several of the devices are there. They are still under investigation. Nothing has been approved yet. The number of devices, the reason the number of devices you see it because mitral anatomy is very complex. Look, the valve compared to aorta, trileaflet circular. This is oval and not able. Even if you place a valve, you can create a new LVOT and create gradient across. It's not that easy to find the right shape. That's why that has not been successful yet. So which of the following is true for co-op trial up to 5-year follow-up? Mortality was higher in the device group. Was it? CVA was higher in the device group. No. So control group patient who received mitral clip after 2 years had similar outcome for the device group. Which of the following factor is not included in co-op risk score of the TEER outcome? Residual mitral gradient. So when you are doing the clip, very important is your gradient is important. So your gradient has to be less than 7. If it's more than that, you are causing mitral stenosis and then it can actually get worse. So if your other thing is, if you need to know more about this for your own learning, we do live cases every month, second Tuesday. You can watch more of these cases on the website. And of course, our live cases, you have ccclivecases.org, coronary, structural, peripheral, and then imaging and microvascular. So, there's a lot of discussion. So the next structural one is in February of 2027, okay? We don't have anything in December of this year. Okay, thank you guys. So we have Dr. Pedro Moreno here who's going to talk on coronary atherosclerosis. Right here. Let's change the slides, right? Okay, Pedro Moreno.
Okay, so welcome back. It's good to see you guys. We're going to have a little fun today, some questions and answers. Let's start here. 64-year-old class 3 chronic stable angina. She had a mid-LAD stent for a 90% stenosis, and then they have a 30% proximal lesion by OCT. Which of these statements is the false statement? Imaging are suspicious for thin cap fibroateroma. The lesion is lipid-rich. Significant calcification is observed. A and C are the true statement, or all of the above. So which of these statements is the true? Is it a TICFA? Is it a lipid-rich? Is it a significant calcific? TICFA with calcium, or all of the above are true? B, huh? B like boy?
No, C.
The A and C. Very good guess. But there is no tikva. And I'll tell you why.
You said C like a cat. So.
Oh, you said C as in cat. I apologize. We need to speak louder. C as in cat is the right answer. You don't see any lipid behind. All of this is calcium. Very deep, more than 5 millimeters. So this lesion may need actually ablation to be properly treated.
What's the star in the picture?
Say that again?
Is a wire shadow that star in the picture?
This one?
Yes.
That's the guide. The guide, yeah. The guide wire will not allow the near-infrared light that OCT use to penetrate. Sometimes you see this, and it's a side branch, but you see the structures, you know. Very good question. Let's go again. So the lesion observed is a OCT image shows a thin cap fibroateroma. Will reflect 180 to 200 degree shadow on IVUS. Is predominantly lipid rich. 1 year MACE of death can be 6 and 19% post PCI. MACE, actually death will be 6% and MACE 19% post PCI. A and C are correct, B and D are correct.
B like boy.
B like boy, very good. Anybody else? Let's see. Okay, I'll show you why in a little bit. We'll review calcium. We already talked about it. The key is it's a Sharpie delineated border signal. Sharpie delineated border signal. When you have lipid, the lipid absorb the light and induce kind of a diffuse reflection. It's not as sharply delineated like it is calcium. The calcific plaque that you properly said will be 180 degrees because on ultrasound, calcium does not penetrate the calcium. And this is the answer for the D. This is the 1 year ischemic outcomes on lesions based on calcification. Severe calcium is death is 6%, and MACE is 19%. Why did I bring this? Because you need to be good when you are going to do severely calcified lesions. What does it mean? It means you need to do a very good stent deployment. No malapposition, no incomplete expansion, no dissections proximal and distal. And the minimal luminal area or minimal stent area should be at least 90% of your reference diameter. Ideally 95, but at least 90%. So don't deploy the stent until you see that your pre-work, whatever you do, you know, could be shockwave, could be rota, orbital, is really expanded. This is important. Okay, question?
These trials are pre-imaging, right? The 19% MACE 1 year post that's before IVUS and OCT.
Yeah.
Yes, okay.
Yeah, this data is not that recent, but in 2014 we were doing rota. We started in 1990, so severe calcifications, we were not doing shockwave. I have to say that shockwave has simplified a lot the treatment of these lesions. And if you see the data of shockwave, the 1 year data, is better. Is better, but there's no randomized data, okay? Very good. Let's gonna go to the basics of atherosclerosis. This is the most important part of my talk. According to the American Heart Association classification, which of the following lesions are considered early plaques? Remember, the AHA classified between early and advanced. We're not talking about angiography. We're talking about pure histology. Okay? Early and advanced plaques. Which of these are the early plaques? The fatty streak, the atheroma, the pre-atheroma, A and C, or all of the above? I'm going to go fast. A and C. Why am I bringing you these? Because you need to understand atherosclerosis the same way the GI doctors, the surgeons, the breast doctors understand cancer. You need to understand the disease histologically. If you don't understand the disease histologically or morphologically, you're just an operator. You're just somebody that is doing this because of algorithms. And that's not the brain that you have. You have a big brain, a fantastic brain that brought you here. So now, before you finish your training, be good on understanding what is the first thing of understanding is a classification. That's what America is famous for. American medicine classify things. It gives you stage 1, stage 2. If you learn to classify something, you will be, in the New England Journal, because it simplifies. When you classify, your brain works much better because you don't have these, doubts. Okay, so calcium depth is better quantified by IVUS, virtual histology, near infrared, OCT, or all of the above. Calcium depth. Excellent, excellent. What does near infrared does? Near infrared only give you the lipid core burden index, how much lipid the plaque has, and it doesn't give you percent atheroma volume, nothing like that. It just gives you a score, a score from 0 to 1,000. That's near infrared spectroscopy. What that IVUS does, IVUS give you plaque burden, remodeling, give you percent atheroma volume, but it really doesn't classify or quantify calcium because, as we discussed, it doesn't penetrate. It's only OCT. Early plaques. The type 1 is not a disease. It's because of the Laplace law. When the kid gets out of the womb, the blood pressure goes up, and the thickness of the vessel wall has to counteract the pressure that is involved, the stress, the wall stress. So it gets thickened. So you develop an intima. The intima, it should be a virtual space between the endothelium and the internal elastic lamina. That's what it is. Now, because we develop collagen to counteract the wall stress, we have an intima, okay? Then that intima get contaminated by macrophages because they're going to clean the oxidized LDL and the free cholesterol that is there. That's the purpose of the macrophages with the scavenging receptors to clean it, give it to the HDL in the reverse cholesterol transport. And the type 3 is the preatheroma when the macrophages has died and the lipid that is intracellular becomes extracellular. Everybody following? The difference between the foam cell type 2 and the preatheroma is where the macrophage dies and the free cholesterol that the macrophage has becomes a lipid pools, some lipid pools, not a necrotic core yet. Advanced lesions, the atheroma, who has a necrotic core now, the fibroatheroma, and then the complex plaque. Early and advanced plaques. This is the early lesion. I was telling you, the collagen is there, counteracting the Laplace law. You have protoglycans there. There's like goalkeepers now that we're in the World Cup. The protoglycans, hirudin, all these are hyaluronic acid. They're goalkeepers to get the oxidized LDL and not let going into the subendothelium. But they fail when there are too many of those. Now we have the fatty streak. In the fatty streak, you have macrophages. And you can see them here. They are huge. They also call them giant cells. And you can see with the light microscopy, with the trichrome stain, you can see it there. The diameter could be up to 40 microns, so it's a huge cell. And if you do electron microscopy, you see that the cell is full of lipid droplets. Lipid droplets. What are the macrophages doing? Here's the macrophage. Here's the macrophage. They esterify the cholesterol and get the free cholesterol through the cassettes to be given to the ApoA1, pre-beta HDL, that will bring it to the liver for the reverse cholesterol transport. So the macrophage is the cell that will be responsible for plaque regression. a healthy macrophage, okay? Not like we call the type 2 macrophage, the M2. The M1 is a macrophage that is now into the pro-inflammatory cascade and pro-atherosclerotic cascade. That will be in the boards because it's now very established, known. M1, pro-inflammatory, pro-atherosclerotic. M2, anti-inflammatory and anti-atherosclerotic. Here we go. What is this? A type 3. What happened here? The macrophage died. The lipid is now extracellular. And why is mostly in this area here? This is the tunica media, this is the internal elastic lamina, this is the endothelium. Why is it deep into the base of the plaque? Because that's where the lowest content of oxygen is. The pressure of oxygen there is as low as 18 to 20 millimeters of mercury. Who can live with that kind of, PO2? Macrophage is an aerobic cell, needs oxygen, and therefore it dies. Also, they go through apoptosis. And now you have here these lipid pools, but there's no cholesterol crystals, there's no cholesterol esters, there's no triglycerides, there's no water, so there's no necrotic core, just a pool of lipid. Question. The reverse cholesterol transport is mediated by macrophages, providing the HDL with minimally oxidized LDL particles, cholesterol crystals, LDL particles, or free cholesterol. Yeah, thank you for paying attention. Appreciate that. All of the following statements regarding early atherosclerosis are true except, which is the wrong statement here. The type 1 lesion is protoglycan rich and is prone to develop athero. The type 2 lesion is characterized by foam cell infiltration and may regress. The type 3 lesion is characterized by pools of intracellular lipid and collagen. And the early lesions are flat, always asymptomatic, and do not obstruct the lumen.
Type 3. Let's see.
Excellent, excellent. And why? Why is this wrong?
Extracellular.
Very good. Extracellular. We start to lose the battle. See, we're understanding progression of atherogenesis. We're not really in the advanced plaques yet. We're understanding how the disease goes. These are the advanced lesions. Now, you can see this. It's a very ugly necrotic core with a little intraplaque hemorrhage there, cholesterol crystals, cholesterol esters, triglycerides. And then there is a separation between the core and the lumen. How is it called? The fibrous cap. The fibrous cap. The Achilles heel. It is composed by smooth muscle cells and collagen, which are the soldiers of atherosclerosis. The defense army is the collagen and the smooth muscle cells. The smooth muscle cells produce the collagen. The collagen is a three-dimensional structure that is very difficult to kill. That's why our Achilles tendon is composed by. But they are suitable for destruction by collagenolalysis with metalloproteinases. Remember that. When you see metalloproteinases in the board, that's plaque rupture, that's macrophages, that's tissue factor secretion, that's thrombosis, that's plaque rupture. Okay, type 4, atheroma. You see it here, all these microvessels, angiogenesis with clotting. The thin cap. Now what happened? See, this atheroma that I was talking to you is a living entity. They used to call it the cemetery of macrophages. But if you stain these with CD68, which is a specific staining, a monoclonal antibody to identify macrophages, and you attach it to a chromogen, whatever, red or blue, you will see under the microscope that all these macrophage membranes are in the border. There are few inside, but most of them are in the border. The membranes, they're not really cells anymore. But why they are in the border? Because that's where they are, in the process of apoptosis, 6 hours, they express these collagenolases enzymes, streptomycin, metalloproteinases. And what do? Destroy the collagen. So that's why they call it a living entity. It's an editorial by Michael Davis, who wrote it and told us, you can tell a plaque when it has a 30%, necrotic core area, and then all of a sudden it ruptures and it's 50% or 70% because it expanded. It expands towards the bottom, in the back, Glagovian phenomena, remodeling, so doesn't obstruct the lumen. But if it expands into the lumen, then only a thin cap is protecting the plaque. If it ruptures, then the necrotic core will be exposed to the flowing blood. And the necrotic core has tissue factor, which is the most important activator or thrombin generation in humans in the arterial thrombosis. Tissue factor is the extrinsic pathway. Tissue factor and factor 7A. Very good. So now we are into the thin cap fibroateroma. We have calcific plaque. This is a type 5B. Microcalcification that you can see even on CTAs these days. And you can see dense core calcification up to 1 millimeter in diameter. That will need some ablation. The fibrotic plaque has no lipid, no calcium. And the type C, rupture, erosion, and intraplaque hemorrhage. So we went through early plaques, advanced plaques. Early plaques, non-specific intimal thickening, fatty streak, and pre-atheroma. Advanced plaques, atheroma, fibroateroma, could be calcific, could be fibrotic, or could be thin cap fibroateroma. And finally, the complex plaques. All right, so let's talk about calcium a little bit. Calcium in the coronary arteries was as found by serendipity. The same way Dr. Mason Sones doing an aortogram with a multi-purpose catheter, which was the catheter, they used to be called the Sones catheter, he invented it. He was doing with the Sones, used to dissect the brachial artery going. He was doing an aortogram. And the catheter jumped into the coronary and injected the dye into the right coronary. Serendipity. The same way right heart catheterization was invented. It was at the Brigham, 1954. The director of the cath lab was doing a right catheterization, which included going into the right ventricle only, and the catheter jumped into the pulmonary artery. So he thought he perforated the heart. So he jumped on the patient, says, "Are you okay?" And the patient says, "I am, but you're not, doctor." So by serendipity, we find a lot of things in medicine, which is the beauty. This guy, Dr. Blackenhorn, he was working in the 1960s, late 50s, at the Cook County Hospital in LA, and he says, "I'm going to find Monkeberg disease in the heart." Monkeberg's calcification of the tunica media in the elastic arteries in the legs. And what he found, 0 cases of Monkeberg. All the calcium by histology was in the intima. So you guys know that calcium means disease. And does it mean early disease or advanced disease? Who will say early? Who will say advanced? Yeah, advanced disease. The thing is that it's not about 50%. In the era of EBCT and calcium scores, where we were developing that, was a very interesting era. We use angiography as the gold standard angiography. EBCT or CTA or calcium scores, how many of those severe calcifications over 300 and sometimes over 1,000 will be obstructive? Guess how many? 50%. Not all of them. Why? Because calcification is a predictor of atrophy of the tunica media. Tunica media, atrophy. So the plaque goes backwards and it doesn't obstruct the lumen. You will be fascinating if you study the pathophysiology of dystrophic calcification, which is the process where calcium is away from the bones, in tissue. So calcium in my kidney with a stone, calcium in my coronary artery, and that's the pathophysiology, the formation of calcium, bone, osteoblast, and the resorption of calcium, PTH. Which pathology is characterized by a very high PTH, parathormone, level in blood, will give you severe calcification. And you see this every week. Yes, patients on dialysis. Yeah. We have to do, in the very old days, we have to do these theses. You didn't graduate without a good trial done by yourself. These days, we are much leisure with the fellows. But my thesis was that we could, using a medication, we could maybe antagonize parathormone in these patients with renal failure. So we measured parathormone, and many of them were over 1,000 millimoles per deciliter, over 1,000 parathormone. So of course, there's a lot of resorption of calcium, and it goes everywhere. You see, in these patients, everything is calcium. Now, these non-collagenous proteins that I show you here, these non-collagenous proteins here, osteoclast, osteopnectin, MMP, the osteopontin, osteoprotein, MGP, the metric glutamic derived protein, they have a pathophysiology that is very much about athero, increased cell adhesion, chemotactic, increased plasminogen activation inhibitor, increased metalloproteinase colocalized. So these osteogenic proteins, they have a metabolic activity that promotes atherosclerosis. This is the problem. And this is the relationship between the square root of plaque area, this is the size of the plaque, and this is the calcium. And the size of the plaque correlates with the amount of calcium. So the more calcium you have, the larger the plaque is. That doesn't mean it's stenotic. Doesn't correlate with stenosis. Very good. By Dr. Sharma, this is a slide of his. We classify by angiography and specifically by fluoroscopy, but by angiography, non, mild, moderate, and severe. You see what he called the tram track. So it's like a train track. The two sides, like they used to call the angiography of the poor. And it is, severe can be up to 30%. It's about 30% of the plaque that is severe calcium, moderate. So it's very common. You see here, see? So, all of the following statements are true except dystrophic calcification is mediated by non-collagenous proteins expressed in macrophages. Severe calcium is associated with increased mortality after PCI. Coronary calcification is associated with the severity of coronary stenosis. Coronary calcification is mostly present in ruptured plaques, which is the wrong statement. I told you. You cannot, it's a 50-50. Very good. Now, this one is also interesting. Dr. Moreno, they told me that ruptured plaques don't have calcium. Wrong. Ruptured plaque has a lot of calcium. The problem is that it's actually at the base of the plaque. The calcium is depth, and the rupture is being in the surface place. Okay, which is true except tunica media drive oxygen from the lumen by diffusion. When I talk about tunica media, I don't want to underestimate that sentence. Tunica media is the only purpose why we have vessels. That's the only purpose. Why? Because the tunica media will regulate volemia. It will dilate when you are exercising or when you have fever or thyrotoxicosis or anemia, and it will constrict when you are dehydrated, when you're bleeding. So the whole volemia is regulated by the tunica media. So it's a tremendously important piece of the vessel wall that you should know. It's composed by 28 plus minus 4 elastic lamellas, 28 plus minus 4, from the rodent to the whale. All the mammals will have 28 plus minus 4. What is an elastic lamella? Is two lines of elastin and one line of smooth muscle cells. Very good. Okay, so the question here, this is an important question. I'm sorry I gave you the answer, but the tunica media drives oxygen from the lumen. But yes, the tunica media drive oxygen by the lumen, but it has to be less than 500 microns, the distance between the lumen and the tunica media. Hypoxia evolves when the distance from the lumen to the media is greater. I just told you. The molecular process of angiogenesis is driven by hypoxia inducible factor 1 alpha. Yes. Neovessels are characterized by structural tunica media and pericytes. No. Neovessels don't have tunica media or pericytes. Neovessels evolved from adventitia vasa, but progenitors say yes, that's correct. Now, what are you looking at here? Almost close, no? To timing. What are we looking here? A heel plaque. What is a heel plaque? It's a plaque that has significant numbers of plaque rupture. 1, 2, 3, up to 4 plaque ruptures. Why that happened? Natural history of atherosclerosis. Out of 100 rupture plaques, only 1 will be symptomatic. That's the way plaque progress. What is the incidence of heel plaques in chronic stable angina? Very high. Over 75% of plaques, when you analyze them, are heel plaques in chronic stable angina. Last question. All of the following statements regarding advanced athero are true except type 4 lesions have a lipid core, but still do not have a well-formed fibrous cap. The thin cap fibroateroma is characterized by cap thickness less than 65 microns, macrophages, and a large lipid core. Extravasation of red blood cells within the plaques increase lipid core expansion. I hope you're understanding the question, no? Extravasation of red blood cell within plaques, inside the plaque, increase lipid core expansion. Plaque rupture is mostly frequently symptomatic, leading to acute coronary events, which is the wrong statement. Yeah, I just told you. So all of the other ones are true. Board question, this one, the thin cap fibroateroma, the asciticized, and why extravasation of red blood cells increase lipid core expansion? Anybody knows? Because the red cell membrane has 40% more cholesterol than any other membrane of the body. When you have intraplaque hemorrhage, the erythrocytes is destroyed, the membrane is ruptured, the hemoglobin becomes extracorpuscular, and they have double sword. The extracorpuscular hemoglobin induces a Fenton reaction, which is oxidation, and blocks nitric oxide, and the cell membrane gives a lot of lipid to the necrotic core. Before I go, any questions? Yes, go ahead.
Is there any significance or there's data on the size of the plaque rupture, like the diameter of the plaque rupture? Which size of the plaque rupture would lead to an occlusive event?
Yeah, where the plaque rupture ruptures?
Like the size of the diameter?
Yeah, there's a paper. Yeah, there's a paper by Dr. Vermani. It's in JAMA. And she quantified where the plaque rupture actually occur. And it occurred 58% at the shoulders of the plaque, because the thinnest part, and 42% at the center. Nevertheless, in patients that die showing snow or during exercise, the plaque rupture is at the center. Very good question. Any other question? Other than that, I wish you luck. Enjoy.
Hello, everyone. I'm not sure how I'm going to do it after Dr. Meron's speech. Let it be written that I have only 30 minutes. So we're going to review some basic definition units of what's RAD, radiation absorbed dose, what's REM, what's gray, what's severe. How do you convert from one to another? Thank you. Then we discuss radiation safety, radiation protection principle, ALARA principle, how do you measure your radiation exposure, pregnancy policy and fetal monitoring, how to reduce the dose to the patient, that's extremely important, how to prevent skin injury, patient skin injuries, how to prevent, reduce the dose to the staff, and new generation of shielding equipment is available in the market that could help you to reduce the exposures tremendously. And under what condition you could work in a fluoro room without a lead apron. Is it possible? Yes. How? I will show you. And then we review some of the Joint Commission. NCRP stands for National Commission on Radiation Protection. ICRP is International Commission on Radiation Protection. And these are publications that might be very helpful to you. Radiation absorbed dose, essentially we say radiation carries energy. You cannot see it, but carries energy. Comes and deposit the energy to the mass. So the unit of deposit energy to the mass, they call it rad. But each type of radiation has different amount of damage. They call it quality factor, right? Alpha particle is 20 times more dangerous than gamma or X-ray. So you multiply rad by quality factor and you get REM. What's the other unit for REM is sievert. How do you go from sievert to REM is a factor of 100. So 1 sievert is 100 REM, 1 REM is, 1 milli is a factor of 1,000, right? So remember, it's not big deal, it's always you have to remember factor of 100. Typical exposure that people they get, if you get a chest x-ray is about 10 millirem, if you get dental is about 200 to 300, a CT gives you about 2,000 to 3,000 millirem. Average person in a hospital, nurse, doctor, they get about 70, 80 millirem per year. And a flight from New York to Philippines, you get 13 millirem. Now, what's the average dose to different type of job? If you work in a waste burial site, you get 1.2 REM or 1,240 millirem. But if you work in a broad medical institution, you get about 70 millirem. A pilot gets 700 millirem. So question for you is, the pilot doesn't even touch radioactive material. He's not even close to fluoro. How does he get 10 times more than you? Anyone? What is about the job of the pilot that gets more 10 times radiation than a doctor in a hospital? The higher you go, the background radiation, it gets higher and higher. Now, they've done 20 years of studies, and the NCRPU 93, which published 1987, says average American gets 360 millirem per year, which is about 1 millirem per day. Then they repeated 20 years more studies, and 2009 they published NCRP 160. And NCRP 160 comes up with double the amount. Average American gets 620 millirem per year from background. So what the change is, and you could see the changes mostly are here. Trying to see if I could use this. Oops. You could see most of them is CT, interventional fluoroscopy, and everything. That caused the average American to get 2 times more radiation than 30 years ago. In any fluoroscopy room, you could see this is the X-ray, and the radiation hits the patient and goes to II. But then 90 degree is scatters. Am I right or wrong? On the bed, you get about 3,000 millirem per minute, not per hour, not per week. Per minute, you get 3,000 millirem per minute. If you go 1 meter, 3 feet away, by a factor of 1,000 goes down. 3 milligram per minute. 3,000 become 3. And then the same way, if you go 6 feet or 8 feet, it just becomes background. Do you follow me? How important is distance from the patient? So, how much radiation you are allowed to get per year? This might come in your exam if you're taking the board. 5,000 whole body, 50,000 any organ, 15,000 to the eye, 50,000 to skin, and your lifetime, you take your age, you multiply 1,000, that becomes your limit. So if you are 25-year-old, or how much you are allowed to have up to 25-year-old? 25,000 milligram. Do you follow me? So you ask yourself a question, how could you know where I work and what I did? Your radiation exposure follows you wherever you go. You follow me? So if I was in Yale University, when I came here, they moved my radiation exposure and they added to my lifetime. How do we measure it? These badges. Have you ever seen these badges, right? These badges has tremendous amount of information, which, what's the name, what department, what hospital, most important thing, what period you have to use. So please, if you're getting these badges, change it every month. Don't use one for 6 months and then the rest of them is not used. Why? Suddenly you see a huge reading and then you have to explain it to the regulatory agency. So change the dosimeter at the end of each month. Must return it on time. Do not share. I use it Tuesday, you use it Wednesday. No. Each person is going to have his own badge. Do not take it home. Do not take it to another hospital and store it in an area that is not radioactive or it's not radiation. Because there was a case that about 20 years ago in one of the hospitals, we saw everybody getting tremendous amount of radiation. So we went, we watched them 2-3 days and nothing was wrong. Everything was normal. But the manager of the department was collecting badges and putting in a bag on the shelf. But next to the shelf was a detector who had radioactive source in it. So all the badges, they were being radiated by a source. Do you follow me? So you have to store it somewhere that there is no radioactive material. If you love your job and you get pregnant, that's not a problem. You could declare it. Declaration of pregnancy is not mandatory, it's voluntary. But once you declare it, the institution is obligated to measure your fetus. How? They're going to give you extra batch for the fetus. Now, the fetus cannot get more than 500 in entire gestation period or 50 milligram in 1 month. And they watch it very carefully. In this hospital, I have 19 to 20 people on the average that they declare their pregnancy. Nuclear medicine, nuclear cardiology, radiation oncology, we have many, many departments. At the end of the year, you have to get Form 5. Form 5 is your exposure last year. This is your right. Everywhere you work, radiation safety officer has to give you Form 5. ALARO stands for as low as reasonably achievable. So in the exam, they might change reasonably to something else with R. And people, they don't know that, they make mistakes. So reasonably is very important. How do you implement ALARO? So we pick up 2 levels, ALARO level 1, ALARO level 2. If your exposure gets to 10% of annual limit in 3 months, then you get notified. They call it ALARO level 1. If your exposure gets to 30% of annual limit in 3 months, then you get investigated. Do you follow me? So most of these doctors that they work in fluoroscopy area with the heavy load of patient, they usually get ALARO level 2. There are 2 ways of measuring exposure. One is to give 1 badges outside the lead apron. The other method is to give 2 badges, 1 inside the apron, 1 outside the apron. It depends on the institution. In this hospital, we give only 1 badge outside the apron. Why? Because when you look at the EDE1 calculation, which is two badges compared to EDE2, you see that this is what do you call it, a little bit high calculated or estimated. So they have changed to EDE2 to EDE122. Essentially, you get the color badge reading. Instead of dividing by 3, you divided 5.6 is accurate, very accurate. We've done many measurements. Many doctors, they have 2 badges, 1 badges, and we published it a long time ago. So my recommendation is to you to have 1 badge outside the apron and use EDE 122 calculation, and you'll be fine. This is a study done in health physics that you could see they use like between 215 to 225. It's 116,000 people they were involved, and only 17% had a meaningful, measurable result. So they came to this conclusion that using 1 badge is much better than the 2 badges, and they recommended to make sure the 2 badges, they don't get switched. When they get switched, your exposure reading becomes meaningless. Have you ever seen these LED eyeglasses, anyone? So if it's really LED, it reduced by 99% exposure to your eye. But if someone's selling it to you for $10, $20 in internet, your alarm should go up. Something is wrong, right? So yes, there are plenty of fake glasses in the market, and they look identical. But when you put under the fluoro, you could see which one has lead, which one has no lead. So if you're buying a cheap one, I guarantee you there is no lead in it. If someone asks you how much radiation typically people who use fluoro they're getting, this is an excellent summary of all these fluoro users. You see, these are different procedure. This is per procedure, how much radiation they got. And this is annual, how much they got per year. So this slide is one of the most important slides that you might use it again and again, because it's not one person, it's not one institution, it's many. And they estimated based on 1,000 procedures per year. ICRP, which is International Commission on Radiological Protection, in 2011 said that, oh, by the way, we thought that cataract threshold is 2 gray. Now we think it's 0.5 gray, right? So they brought the threshold, and based on astronaut, airline pilot, all kinds of published paper. ICRP again in 2011 published that annual radiation to your eye right now in the United States is 15,000 per year. They recommended to have 2,000 per year, average over a 5 year, but not exceeding 5,000 in any year. That was proposed about 10, 15 years ago. And United States and China, they did not go for it. Some of the European countries, they went for it and they implemented. So, for example, this paper published by Chinese studies, but published in Health Physics, if I remember, and you could see that they took 3,000 interventional radiology between 2017 and 19, and they saw only 33 cases, they were above 2,000 milligram, and 0 cases were above 15,000. Yes, it's true. I have never seen any of you more than 15,000 in this institution, ever. So, therefore, in the United States, we decided to stay $15,000 to the eye. Joint Commission also in 2011 came up and it says, hey, we don't know how much radiation you give to this patient. You have to record it. You have to save it. Then they came back and they said, not only you have to record it, it has to be retrievable. And you have to save it in PACS unit. So if I have a patient and the patient come back 6 months or a year from now, he has the right to say, how much radiation you gave me last 6 months ago. Do you follow me? So this is by Joint Commission. NCRP 102 says only people who have lead apron and badges could work in fluoroscopy room. So now, this is the regulation. INA is distributing some multiple choice questions that might help you if you want to take the exam. The answer to these multiple choice question is in the back. So you could test yourself whenever you want to. And if you don't need it, pass it on to people who need it. But we made 50 copies, I think is enough. If she forget any of you, please, we make sure you get it.
Leaded gloves,
Sorry?
leaded gloves, is that available? Leaded gloves,
Lead gloves?
that's what's written there.
You talking about this?
And the second line. Second bullet.
Oh, lead apron? Lead gloves? Oh, in my opinion, they have tried many, many times. And have you ever tried it? You cannot work with it.
Never heard of it, that first time to hear about it.
Not only that, your hand limit is much, much higher than your eye limit. So people, they tried and they say it's waste of time. You could try it, but I think you will see after 2-3 times, it's just not practical. Do you follow me? For different issues, maybe nuclear medicine, you have to hold the higher activity sources, I understand it. Basic fundamental of radiation protection is time, distance, shielding. Which one of these is most important to you? Time, distance, or shielding? Which one? Distance. Why? Distance is an inverse square function. Time is a linear function. This happened 2000. 4-year-old man had a geography. After 4 to 6 weeks, you could see the burning. Then after 16 weeks, it's almost disappeared. Then it came back again after 18 months. This is the same picture as this one, but they had to do skin graft to fix the problem. Another picture, just to give you a little bit of what's going on. This person had a stent replacement in 2007. Then he was going to Thailand. He experienced chest X-ray, and in 2018 returned to East Asia and 5 hours of fluoroscopy. So you could see a few months later he developed all this burning on the skin. And this green area is the necrosis of the patient. The white stuff is the cream because it was so painful of the skin. So, question to you is, how do you do that? How do you prevent skin injury to the patient? Essentially, what dermatology recommend to you? Dermatology says 0 to 2 gray to the skin, you don't see any effect. 2 to 5 gray, you may observe some reddening of the skin. 5 to 10 gray, you ask the patient to check the skin by themselves, or a wife, or someone in the family, right? 10 to 15 gray, you must see the patient. And above 15 gray is essential to follow up. This is one of the slides that I got from a dermatologist. If you look at as a function of time and the amount of dose to the skin of the patient, you see majority of the problem is between 5 to 15 gray to the skin, right? So if you stay below 5, you'll be fine. We've done a lot of studies, and we see 20% of dose to the patient when you, the operator, do not look at the screen. Essentially, you're wasting all these dose, and you not getting anything for it. What do we recommend? NCRP 168 recommend if you fluoroscopy 30 minutes of fluoro time, not procedure time. If you give 30 minutes of fluoro time, then every 15 minutes, someone has to warn you, hey doc, be careful. Do you follow me? Now, you could use these limits. In Mount Sinai, we use 5 gray and 7.5 gray. If the skin gets 5 gray, we inform the patient, please look at your skin at home if there is any reddening, right? If it's more than 7.5, then we inform the patient and we follow up with the patient in 3 weeks. And this is the result. In 2025, you saw that the number of the above 5 gray reduced tremendously. How to use the fluoro machine is essential for you. So you have to know how to use the fluoro machine. It's like driving a stick shift car, right? You have to learn once in your lifetime. Essentially, if you want to use a fluoro, you want, especially for angulation, you want to stay on the side of II, not the tube, right? I summarized all of this for you. Please make sure you understand all of this. Why? Greed, increase patient dose. Increase pulse rate, increase patient dose. X-ray tube side, increase it. So all of these have effect on the patient dose. If it has effect on patient dose, essentially it's going to affect your dose, right? Because the patient becomes the source of all the radiation. So this slide is essential. Keep it, memorize it, and practice it. Have you seen a fluoroscopy operator on back pain? There are so many publications. Essentially, 42% of you have cervical problem. And they have done a lot of the third of them, they reported that they missed work because they couldn't go to work. So, they've been a lot of effort in the last, I would say 4 or 5 years, 3-4 years, that we have to help you. So last year, all of these societies, they got together and they published this. They call it white paper. It says conventional radiation protection is no longer sufficient. You guys need help. The use of enhanced shielding is now moral imperative and should be done. So they are asking you, they are asking for help. Asking who? The other society that are expert in radiation safety, like Health Physics Society, right? And those are the ones that they want further standardization in radiation safety and reduce the dose. So what they're recommending is essentially this new generation of shielding. This has been in the market for a long time. This is very new, radiation. This goes above the patient and this goes below the patient. We also have eggs. You see all these lead around the bed. These panels, black panels, scatter the radiation back. You follow me? So there are many of them, rampart, these panels, these, what do they call them? It's like a wall of lead, moves around. It's up to you which one makes your life easier. But what we did in Mount Sinai last year, we chose this one for 2 weeks, and we did a lot of studies. We did 2 weeks of procedure in operating room, and this was 1 millimeter of lead equivalent. This and it's one meter wide. So 2-3 people essentially they could stay behind it. You follow me? And then we also had these lead under it, these panels around it. Why we choose this one? Because it's protect the whole room, not just one person. Do you follow me? And the result was fantastic. These are the result of the 15 cases that we did. And we colored the red one because the vascular surgery complaining about their exposures. So you could see that the reduction is almost 96% reduction if you use it effectively. Remember, if you want to be lead-free without a lead apron, you could do it, but you need to be disciplined. You need to make sure that all these enhanced radiation shielding are implemented properly. And I guarantee you, this is the beginning. 30 years ago, I was working in the cyclotron. You know what the cyclotron is, anyone? It's produced radiation to inject for nuclear medicine, right? So you get tremendous radiation to work in that place. But essentially, they came back and they created cyclotron, self-shielded cyclotron. Now people, they work in it beautifully. And I guarantee you, the same thing for you. It's just a matter of time. 4 or 5 years from now, probably they design self-shielded fluoroscopy, right? It's like an MRI. You go in it, you do the procedure, you get out. So, but between now and then, you might want to use this new generation of shielding to reduce your exposure to minimum. So, if you have any question, I think I'm done. Now I leave 1 minute and 20 seconds to answer any question you have. Hold on. I'm getting old.
Okay, I'm using leaded glasses and a hat, wrapped like a hat, a leaded hat.
Yes.
One attending said there's no evidence that protecting from cancer and protecting the eyes.
That is correct. The question, let me repeat the question. The question is that if the lead glasses and the lead head, covering the head, would reduce a cancer. The statistic is so fluctuating that you really cannot make a case for it. One of the hospital asked me to help, and there has been so many cases that someone gets a cancer and the first thing they're gonna blame it is radiation. My recommendation is you do your best and you move forward.
Cataract is the same. No evidence of cataract prevention from leaded glasses.
I recommend highly to use lead eyeglasses, 100%. However, remember, if you're getting right now less than 15,000 without the lead eyeglasses, I don't want you to lose sleep over it. Do you see what I mean? Radiation is not a chocolate cookie. You don't want to just say, oh, let's have some more. No. You have to reduce it as much as you can. At the same time, you have to have some common sense. This is too much. This is not that bad. You follow me? For example, they said, oh, 2 gray of threshold for cataract now is 0.5 gray. If that was the case, most of Dr. Sharma should have cataract years ago. Right? So it's all statistic. I feel comfortable. To be honest with you, everything is in your hand. You are the one that control how much radiation you're producing, right? You put your foot on the pedal, you produce radiation, no one else. So if you master it, you help a lot of people. Not only patients, but everybody in the room. Any other question? Good. It was a pleasure to see you. Now we have Dr. Dangus right here. Thank you so much. Good to see you, sir.
Thank you, Jacob. Great job.
I tried to finish it.
Great job. Great job. Jacob, great job always. I never have any Q&A about radiation because he does such a great job. Also, I'm concerned he will wait and see my Q&A and may have comments on what I thought is a correct answer. So the Q&A will have no radiation. Thank you. Yeah. Well, just to follow up the question I said before, no evidence means you have to do more studies. That's what it means. No evidence is not evidence of absence. Means we have to do more in order to understand it better. But we all remember the photographs of left-sided brain tumors of some angioplasty specialists. So there is a possibility, but we have to work on it and find more about it. All right, let's break up these sessions of lectures, and we'll do some Q&A. The way it works is that you're going to be ready when you're raising the hand according to the option you want. If you respond fast, we're going to do more questions. If you just watch and don't raise a hand, then this means I don't know, you don't know. So we spend more time in one question when I'm doing fewer questions in the allotted time. All right? And the same slide appears in duplication. One of it has all the options, and then I click again. The next slide will show the highlighted option. So let's see how we do. Let's test drive the situation. All right. Factors affecting outcomes on left main PCI include all of the following except which one? The calculated syntax, the supportive measures such as a balloon pump or other device, the presence of disease involving the bifurcation, or the instability of the patient. So, who says number one? Who says number two? Who says number three? And who says number four? Bingo! Most of you got it right. You listened to my talk yesterday, perhaps. Some of you were here, that the support devices are not very clear for the high-risk PCI, what they do. Okay, second question. We're doing great. The patient has a stress test and has to have moderate ischemia in the RCA territory due to moderate symptoms, class 2 to 3 on medical therapy. Coronary angiogram is done. The angiogram shows hazy 50% stenosis in the mid-RCA. What is the best step? Do nothing because the stress test was probably a false positive. Consider stenting the lesion because of a 50% stenosis is expected to be ischemia causing. Consider performing FFR assessment, or consider performing an intravascular ultrasound. Who says A? Who says B? Who says C? And who says D? All right, nearly everybody gets this right. You listen to Dr. Sharma's talk as well, not only my talk. Very good. Let's go to question 3. Same patient, FFR shows a value of 0.8. You decide that the value of 0.80 is non-significant and decide not to proceed with stent. The value is significant, and stenting will prevent future MI in this patient when compared to medical therapy. The value is significant, and stenting will prolong the longevity of this patient in comparison to medical therapy. The value is significant, and stenting will decrease the patient's chances of a repeat revascularization when compared to medical therapy. So who says A? And who says B? Who says C? And who says D? All right, very good, good job. 0.8 is a positive FFR. Okay, excellent. So that you know from test-taking approaches, when you are in the board examination and many answers have the same body, most likely the correct answer is among those that have the same body. So you see options B, C, and D here start with the same thing. The value is significant and stenting will prevent future, then changes. So C is the same, D is the same. Remember, from test-taking point of view, chances are the correct answer is among those who have the same body. Narrows down your options. Let's go to 4. Now patients present 5 years later with recurrent angina, class 3, on optimal medical therapy. Stress test again shows ischemia in the RCA territory. There is a concern that the previous placed stent is reoccluded and will perform an angiography. The stent is patent, but about a 90% lesion in large OM1 is found. What could be the next step? Do nothing. The stress test did not show ischemia in the OM territory. Stent the lesion because patient is symptomatic on maximal medical therapy. Consider performing FFR or consider performing IVAS. Okay, who says A? Who says B? C? And D? All right. The positive stress test, the territory may not match sometimes. But nonetheless, the patient is on optimal medical therapy, has class 3 angina, not a severe angina. That makes this case okay to proceed with the stent, is reasonable. If the patient had only mild angina, that might be a different story. Question 5. Now we move to finally another patient, 62-year-old male with history of hypertension, hyperlipidemia, type 2 diabetes, occasional dyspnea when running up the stairs at work, but generally no other symptoms. Echo shows normal systolic function without evidence of significant valve disease. 12 leading EKG are remarkable and shows normal sinus rhythm with a heart rate of 55. Medical therapy is diltiazem, aspirin, and atorvastatin. The patient's cardiologist is worried that the patient's symptoms are angina equivalent and adds ranolazine. 1 month later, the patient follows up and still notes similar symptoms. Cardiologist performed a stress test with imaging that shows moderate anterior and inferior ischemia. So which of the following is correct about this complex patient? Regardless of the anatomy, probably inappropriate to stent this patient, therefore a beta blocker should be added to the medical therapy before considering any angiography. The patient is on maximal medical therapy for angina. According to the non-invasive testing, the patient has a 1 to 3% annual mortality. A and C are both correct statements. So who is with A? Who is with B? Who is with C? And who is with D? Many people do not. The simplest question. The patient was on diltiazem, and we added ranolazine. That's a second anti-angular medication. So if you have 2 anti-angular medications, you are on maximal medical therapy. Sometimes the correct answer is the simplest answer. All right. Patient is referred for cardiac catheterization. Coronary angiogram demonstrates a 70% discrete proximal LAD stenosis. The left circumflex artery and branches show mild diffuse disease. Right coronary artery has a discrete 80% proximal stenosis. Because of the high stress, the patient is evaluated for revascularization. Which of the following is correct? A, should be referred for PCI because syntax score is low. Patient should be referred for bypass. The Freedom trial only included patients with reversal disease. All the results of the Freedom trial appear irrelevant only to those patients with high syntax score. So who is with A? Who is with B? Who is with C? And who is with D? I think everybody needs to go brush up a little bit on reading on the Freedom trial. We didn't have any responses here. The correct answer is that the double vessel disease with diabetes, remember, or you forgot, the patient was diabetic, qualifies for the inclusion of the Freedom trial, that the initial referral for bypass is to be considered in this patient. Freedom trial included mostly 3 vessel disease, but also 2 vessel disease. And the results were consistent throughout all syntax scores. All right, 68-year-old male with history of hypertension and hyperlipidemia undergoes angiography for evaluation of angina and a positive stress test. Coronary angiography demonstrates obstructive lesions in LAD, LCX, and RCA. Syntax score was 32. Which of the following statements are correct? The patient will likely enjoy freedom for revascularization 1 year after CABG than if the patient had PCI. The patient will not derive a mortality benefit 5 years after CABG than if the patient had PCI. At 5 years, this patient will most likely benefit from CABG than a patient with similar syntax score but with significant left main disease. All the statements are correct. A, who is with A? B, who is with B? C, who is with C? And who is for D? Again, people need to be a little bit more positive, but yes, all correct. Is a freedom for revascularization is correct. That is not related to mortality. Very good, correct. And at 5 years, the left main cohort actually does better than the pure triple vessel disease cohort with similar syntax score. Very good. So, few more quick questions now. Which coronary distribution is most associated with cardiogenic shock? Who is with anterior? Who is with inferior? Who is with lateral? Who is with posterior? Okay, after a few tough questions, I give you a good one to get you going again, all right? So, all of the following are true regarding hemodynamic support, except which one? Patients with cardiogenic shock, there is no evidence that routine use of balloon pump reduces 30-day mortality. Patients with cardiogenic shock, the tandem heart and impella provide superior support as compared to balloon pump and have significant mortality advantage. Patients undergoing high-risk PCI, impella versus IBP allows more complete vascularization but does not reduce the incidence of irreversible events. A hemodynamic support device is recommended for patients with cardiogenic shock after STEMI who do not quickly stabilize with pharmacological therapy. So which is a wrong statement? 1. Who is for 1? Who is for 2? Who is for 3? Who is for 4? A little shaky here. Yeah. All right. The correct answer is number 2, which includes that not a lot of mortality data comparing to balloon pump. Okay? Excellent. Shock trial found which one? Revascularization therapy was associated with 50% reduction in mortality in all patients. Revascularization therapy was associated with 50% reduction in mortality in younger and older patients, but smaller numbers of older patients prevented this from being significant. Early vascularization was associated with 20% reduction in mortality in all patients and a smaller, non-significant reduction in mortality in elderly patients. Or early vascularization therapy was associated with a 20% reduction in mortality in all patients, but a higher mortality in elderly patients. So let's remember the shock trial. Who's for 1? Who's for 2? Who's for 3? Who's for 4? Remember what I told you yesterday? The elderly patients over 75 years of age, initial medical stabilization is a way to go per the guidelines, because exactly in that group the revascularization did not really work safely. Okay? Very good. In patients treated with revascularization therapy, in the shock trial, mortality rates were similar in patients with PCI and CABG, or were lower in patients with diabetes mellitus who were treated with CABG. Mortality rates were higher in patients treated with BCI, or mortality rates were lower in patients treated with PCI. Again, remember, this was a 25 years ago study of bare metal stents and bypass and all that. Number 1. Number 2. Few. Number 3. Nobody. Number 4. Number 1. Similar. That's why, as you know that no surgeon operates in cardiogenic shock. Gone. Why? Why bother? Or why muck around? They have to do a big surgery, there's a high mortality, even in the archaic PCI, the results were sort of similar. So, that's not really, remember, we do not send a patient to surgery with shock. All right. George, you next? Excellent. Maybe this is the last question then. A 64-year-old man notes a sharp chest pain that lasts for seconds and not related to exertion. In fact, he says he walks every day for exercise. The physical examinations are remarkable, except for slight overweight. EKG is unremarkable. He does not recall having been treated or evaluated for any heart condition. Which of the following would be appropriate first test in the evaluation of this patient? Does not need evaluation because he's low risk. She. Cardiac catheterization, lipid profile, or echocardiogram. Who's with A? Who with B? Who's with C? Terrific. On a good note, we did 12 questions. Excellent. And I'm pleased to give you back on track. Dr. Sween is here to carry on the show. Thank you, Joe.
Very good.
I think we got, most of you got 10 out of 12. That was pretty good, okay, as a group. Keep going.
Good. Okay, guys, welcome. For those of you who don't know, my name is Joe Sweeney. I'm on the faculty here over up in the cath lab. I've been tasked to talk to you guys about the antiplatelet therapy in PCI and ACS as it pertains to boards. I'm coming up for my third board renewal here in the next 2 years, so I will be in your boat. But the questions are fairly straightforward with antiplatelet therapy. The key references now have changed a bit. So now we have the 2025 guidelines for ACS, which is at this point now a year out, probably fair game. And then the 2021 guidelines for Revasc. And then number 3, what I've always used is the ACC CathSAP, which I think is a great resource if you guys can do that. So with that, these are the new guidelines. I'm sure you all have downloaded this and reviewed it. It really does outline some of the importance of the most recent clinical evidence in treating patients with ACS, and there's a good section on antiplatelet therapy. It incorporates recommendations from 3 of the key guidelines, and it does replace the 2016 focused update on dual antiplatelet therapy in patients with CAD. Again, this is focusing on antiplatelet therapy, not all the other stuff that goes on with these pretty thick guidelines. So when you look at it at a glance, if you look on the right side here, these are the new recommendations. Basically, it's shortening DAP duration. It's preferable for the more potent antiplatelets versus clopidogrel and ACS, and it goes with timing. So there's some significant changes which we'll go through on the subsequent questions. But I kind of summarized it here. In my view, DAP for patients with the ACS default is 12 months, and they're not at a high bleeding risk. And there's our strategies to reduce that bleeding risk. Obviously, a PPI, transitioning to ticagrelor monotherapy after 1 month of a PCI. And if an oral anticoagulant is needed, after 1 to 4 weeks, you can drop the aspirin and just keep them on the P2Y12. And clopidogrel is preferred over the more potent ones. Ticagrelor or prasugrel recommended in preference over clopidogrel if undergoing a PCI for ACS. And then if you're doing an invasive strategy within 24 hours or greater than 24 hours, upstream treatment with clopidogrel or ticagrelor, not prasugrel, is recommended. That's kind of my focus down, 1-page summary of the 2025 guidelines as it pertains to antiplatelet therapy. This is a nice pictorial. We use this pretty regularly in our lab. Again, ACS default strategy, 12 months. If you have a number of bleeding reduction therapy strategies, you can do 1 month DAPT and then stop the aspirin. You can do triple therapy if they have atrial fibrillation, but then stop the aspirin after 1 to 4 weeks. You can then, if you're really high bleeding risk, you're going to basically stay with just a P2Y12 receptor antagonist after 1 month and drop the aspirin. So my goal here is to kind of do questions, and we kind of back and forth with questions and answers, and it kind of touches on a lot of this. Pharmacology is big on the boards. It will be in a clinical vignette, but it's not too hard. Don't get lost in reading a huge paragraph and then they ask you an unrelated question. I always got caught in that as well. But you guys are very good test takers, so I assume you know how to take it. All right, so 78-year-old female with diabetes, hypertension, high cholesterol, prior tobacco use, and PAD. Underlying non-ischemic cardiomyopathy with a low EF. She came with chest pain and positive troponin with an ACS. She had new onset AFib on her EKG. Her hemoglobin's 9, platelet count of 235, and a creatinine of 2.1. She's taken urgently to the lab and found to have a critical prox LAD, underwent a PCI with a contemporary generation DES. So the optimal antiplatelet regimen after a PCI with a DES for this patient includes aspirin 81, clopidogrel 75, and apixaban 5 BID for 12 months. Aspirin 81 for 4 weeks, clopidogrel 75, apixaban 5 milligrams for 12 months BID. Aspirin 81, clopidogrel 75, warfarin with an INR 2.3. Aspirin 81 for 1 to 4, clopidogrel 75 daily, and apixaban 5 BID for 12 months. D. Whoever said D. So remember, you can drop the aspirin after 1 to 4 weeks. And apixaban will be for lifelong, not just 12 months. I have to fix that. Okay, so how do we define high bleeding risk? So this is the ARC criteria, the Academic Consortium and Research Consortium. And in this patient, she had a number of criteria. She was and age greater than 75. She had underlying renal disease, she had anemia, and she was on oral anticoagulant. So, or she needed to be on oral anticoagulant. So she has a number of the risk factors that we look at. And looking at the strategy we just talked about, she would be over here, probably in the middle, if not on the high right. Triple therapy for probably 1 to 4 weeks, and then drop the aspirin. And then just do a single antiplatelet with a P2Y12 receptor antagonist and an oral anticoagulant. So I think she'd probably be right down here. Okay. Our guidelines support this. It's class 1, level of evidence B. ACS requiring oral anticoagulant. Aspirin should be stopped after 1 to 4 weeks of triple therapy with continued use of a P2Y12 oral anticoagulant. Okay, question 2. Which of the following, so then we're going back to our BARC criteria, which of the following is not a major criteria for the Academic Research Consortium high bleeding risk, or ARC-HBR? A major criteria: active cancer within 12 months, moderate severe baseline thrombocytopenia, ischemic stroke within 6 months, or hemoglobin less than 11. Who said B? You're right. So all the others are major. And if you're not familiar with it, these are the major and minor criteria. It's something that, do you have to memorize it? Probably not. I probably would just look at the minor criteria and know those. And understanding that when you have one major criteria, it puts you at risk for a BARC 3 or 5 bleeding risk greater than 4% at 1 year, or an intracerebral hemorrhage greater than 1% at 1 year. And if you have any of the minor, it's 3 to 5 BARC, less than 4% risk. So, and the risk, the high bleeding risk is you can have 1 major or 2 minor. She actually had 3 majors in this one. So, okay, all the following are true regarding ticagrelor, except ticagrelor inhibits the cellular uptake of adenosine via sodium-dependent ENT1 receptor. It's metabolized to adenosine. It significantly increases coronary blood flow. Adenosine inhibits platelet activation vis-a-vis the A2AR receptor and 2BR receptor, whose genes are upregulated with an ischemic injury. And there's an increase in serum creatinine in ticagrelor patients compared to clopidogrel patients in Plato, or F, all the above. So, except, right? So B. So this is a tricky one. So ticagrelor is not metabolized to adenosine, okay? Remember the side effect of ticagrelor, 12 to 14% in Plato got this dyspnea. And it's because of what happens is ticagrelor, the byproduct of ticagrelor, blocks the uptake or reuptake of adenosine, so you have more adenosine buildup. Doesn't metabolize to adenosine. So with that higher adenosine comes side effects. Interestingly, if you remember in Plato, there was a cardiovascular mortality benefit in ticagrelor. And some of the thought process is because of this higher upregulation or increased or decreased reuptake of adenosine. You have more adenosine hanging around. So as a result, you have vasodilatation, increased endothelial cell migration, decreased reperfusion injury, increased platelet inhibition, reduction in inflammation, a reduction in GFR, and increase in dyspnea. So all those side effects, the side effect dyspnea relating to adenosine may actually have some of the beneficial properties of ticagrelor that we always hear about. All right, number 4, which of the following glycoprotein 2B3A inhibitors has the shortest half-life but the longest duration? So 2B3A inhibitors are class 3, guys, so you probably don't have to worry about them. I don't think even in the market anymore. But the board loves 2B3A inhibitors. I don't know if they're going to ask questions on 2B3A because it's not available anymore. In the sense that abciximab is not available, eptifibatide is, but we don't have it. We don't use it. Sometimes we do, but not mostly. All right, so what is the answer to this? They love this question. Shortest half-life, longest duration. Why is this important? So what's the answer? Excellent. Why is that important clinically? Well, it's important because when you have to reverse antiplatelet therapy in somebody that's bleeding that got abciximab, what are you going to do? You're going to stop the drip? Nope. You're going to give platelets. That's what they want you to know. With abciximab, because it has a short half-life, but it's bound to the platelet for a long time, it has a long half-life, you have to replace the platelets. So you give platelets. Versus the small molecules, they're so short, they don't bind for a long time, you can just wait it out. You just let the drip wear off, and they go away. That's the clinical vignette that they'll give you, if they ask. But going back to the current guidelines, it's a class 3 in patients with ACS with the use of 2B3A. So that's pretty impressive, to a class 3. If you have a large burden, large thrombus burden, it's a 2A, but upfront, de novo, PCI, run-of-the-mill ACS, you don't need to give it. All right, number 5, which of the following mechanisms leads to inhibition of platelet function following treatment with a P2Y12 receptor inhibitor such as clopidogrel? It reduces cyclic AMP, increases the VASP enzyme, vasodilator stimulated phosphoprotein. It inhibits the phospholipase C, inhibits adenylate cyclase, and inhibits protein kinase C. This is getting in the weeds, I get it. But it's kind of it's important to understand the way we test for platelet reactivity, although we don't do it anymore and the indications are not there anymore in the guidelines. But the VASP assay is actually one of the assays that is used. And the reason why is cyclic AMP, when it's upregulated, inhibits the platelet phosphorylation, inhibiting platelet activation. Just a mechanistic question. All right, number 6, which of the following best describes the reason prasugrel provides more potent and inconsistent platelet aggregation inhibition as compared to clopidogrel? It's absorbed over broader gastric pH and is therefore less affected by PPIs. The active metabolites formed by a single oxidative step. The effect of foods such as grapefruit juice is less on prasugrel, or all the above. So B. So the metabolite is formed by a single oxidative step. So when you look at prasugrel versus clopidogrel, when you take clopidogrel, immediately in the gut it undergoes hydrolysis, and that basically gets rid of 85% of that active drug, that prodrug. You're left with 15% through which it undergoes 2 oxidative steps to the active metabolite. It's very inefficient, versus prasugrel is more efficient. It undergoes just 1 oxidative step, and you're left with much more active metabolite. And as a result of that, you have more consistent antiplatelet therapy or activity, and prolonged antiplatelet effect and more rapid uptake. And this was the trial imprinted in all of your heads, the TIMI 38, that showed a reduction, a 20 or 19% relative risk reduction in primary endpoints in patients with ACS compared to clopidogrel, but it did come with a cost, and that cost was increased bleeding compared to clopidogrel. So just be a little bit careful. Don't give it to your light patients, less than 60 kilograms, or a prior stroke, or elderly patients. Be careful. Number 7, prasugrel is a 3rd-generation thienopyridine. Which of the following statements regarding prasugrel is false? It's a 3rd-generation thiopyridine. It has a more potent, consistent, rapid inhibition of P2Y12. In a pre-specified subgroup analysis, treatment with prasugrel seemed to be less effective in subjects with diabetes compared to clopidogrel. It does not seem to be prone to alterations in pharmacokinetics or pharmacodynamics or clinical efficacy on the basis of a genotype. And in the Triton 38 as a whole, those patients greater than 75, less than 60 kilograms, or prior TIA benefited more with clopidogrel versus prasugrel. So which one is false? Yeah, who said B? Excellent. So this was actually a nice trial that looked at a subgroup analysis in those patients with diabetes compared to those patients without diabetes. There's significant separation of your curves. The patients with diabetes definitely benefited in more potent antiplatelet therapy in ACS. So that's why we choose it. All right, number 8. In the platelet inhibition or Plato trial, testing ticagrelor as compared to clopidogrel among patients with ACS, how did ticagrelor affect the rates of mortality and non-CABG major bleeding? Decrease, 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 increase, unchanged, increased, unchanged, 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 decreased. B. So decreased mortality with an increased non-CABG bleeding. Okay? This was the Plato trial. Again, everybody here knows this trial. 18,000 patients, 16% relative risk reduction in the primary endpoint versus clopidogrel, and driven largely by cardiovascular mortality benefit. But here's what the question was getting to. Non-CABG major bleeding versus ticagrelor versus clopidogrel, it was higher. I'm sorry, the TIMI criteria versus the study criteria in both groups was higher. Number 9, proton pump inhibitors such as omeprazole have been shown to reduce the pharmacokinetic and pharmacodynamic effects of clopidogrel by modulating the effects of which of the following? So proton pump inhibitors, as we all know, we're not worried about it clinically. In vitro, it does have an effect, but there was an article I just read somewhere that this is being revisited. As you all know, the Cogent trial, published back in 2010, said it did not make a difference. But how does it work? So does omeprazole reduce it by binding to the GP2B3A receptor expression, the P450, 2C19, cytochrome P453A4, or intestinal glycoprotein transport? Excellent. Good job. So more mechanistic than probably they'll ask, but now you know. All right, number 10. Which of the following antiplatelet agents interact directly with platelet surface membrane receptors? Membrane receptor. I think this was actually a question on my boards, believe it or not. All right. Which one binds membrane receptor? Clopidogrel, prasugrel, aspirin, vorapaxar, A and B, A, B, or D? A, B, and D. Okay? When you look at all the agents available in 2026, clopidogrel, prasugrel, ticagrelor, cangrelor bind to P2Y12 surface receptor. Aspirin binds to a COX enzyme. Vorapaxar also binds to the PAR receptor, which is a surface receptor. So, okay, here's some more clinical ones. So 76-year-old with chest pain, abnormal stress test, had a mid-LAD stent with a drug-eluting stent. 1 week after, developed shortness of breath. You concluded this is a result of the well-documented side effect of ticagrelor and discussed the option for antiplatelet de-escalation therapy. So which de-escalation regimen is the most appropriate? So she's on ticagrelor and aspirin. It happened a week after. 1 week after getting loaded with ticagrelor. Are you going to stop ticagrelor, start clopidogrel 75, 12 hours after the last dose? Stop ticagrelor, start 300 clopidogrel, 12 hours. Stop ticagrelor, start 600 clopidogrel after 12 hours. Or stop ticagrelor, start clopidogrel 75 once daily, 24 hours after. Excellent job, guys. So in reality, the 300 versus 600 didn't make much of a difference, but you don't want to use 75. Your platelet reactivity is much higher compared to the loading, so you have to load it within 24 hours. Okay, 66 chest pain, abnormal stress test, mid-LAD stent with a drug-eluting stent, got aspirin and prasugrel. She got loaded with prasugrel 2 months after she developed bleeding, epistaxis. De-escalation regimen is the most appropriate for this patient. Stop prasugrel, start clopidogrel 75 once daily, 12 hours after the last prasugrel. Stop prasugrel, start 300 12 hours after last dose. Stop prasugrel, start 600 clopidogrel loading dose. Or stop prasugrel and start clopidogrel 75 once 24 hours after last dose. Kind of all over the place, huh? D. All right, so if you guys don't have this, take a picture of it. This is very, very important. It's in the guidelines or in the consensus document. This is a really nice consensus document that takes you through both the acute phase and late phase, defined as 1 month. So in the acute early phase, if you're going from prasugrel to clopidogrel, you're going to load with 600 milligrams, and then you're going to give 24 hours after the last prasugrel dose. So the general scenario is they're on prasugrel, but it's late after a month. You're just going to give 75 milligrams 24 hours after the last dose. You do not need to reload. The other thing we always see is going from ticagrelor to clopidogrel because they get the shortness of breath. You have to load clopidogrel. It's a different mechanism. So don't just give 75 milligrams. This is a very important concept, both for the boards and clinically. 13, which of the following statements is false regarding treatment of unstable angina or non-STEMI? The proportion of ACS patients worldwide who are managed medically without revasc is 40 to 60%. Which one's false? And early invasive strategies indicated an initially stabilized unstable angina patient who have elevated risk for clinical events. Unstable angina patients treated conservatively with clopidogrel, prasugrel, significantly reduce the frequency of death from cardiovascular causes, MI, or stroke. So read that C again. Patients treated conservatively compared to clopidogrel, prasugrel significantly reduced the frequency of death from cardiovascular causes. Is that true? That's completely false, and that's an important one. You don't give patients that you're treating conservatively prasugrel. And that was the Trilogy ACS trial. Those patients that did not go to the cath lab had a higher risk of, actually, there was no difference in clinical outcomes. The p-value was non-significant, but much higher bleeding risk. So be very careful treating these patients conservatively. Again, prasugrel is really reserved for patients going to the cath lab. All right, I think this is my last question. Champion Phoenix. This is one of the other options we have. In IV ADP receptor blockade with cangrelor, IV cangrelor, had the following effect on stent thrombosis and severe bleeding, respectively compared to clopidogrel. So I'm sure all of you by now have had experience with IV cangrelor. So regarding stent thrombosis, does it increase stent thrombosis and decrease bleeding? Increase, no change. Decrease, increase. Decrease, no change. Decrease, decrease. D. Decrease with no change. So this is the new, not so much the new kid on the block anymore. It's all available. It's really used in our lab for patients that acute MI, heavy thrombus burden. The off-label use is for patients getting bridged for non-cardiac surgery. But the beauty of ticagrelor is its short half-life. So, and this is another slide from the newer guidelines looking at transitioning, kind of the thing I showed you with the crossover data, but they put it in the newer guidelines. Oh, last one. You receive a call from a physician in the ER who heard about a new medication called ticagrelor and wonders how this drug is administered, as well as its antiplatelet effect and mechanism. Which of the following best describes the administration and activity of ticagrelor? It's oral, it's irreversible, and it directly acts on the P2Y12 receptor. It's oral, it's reversible, directly acts on the P2Y12. Oral, reversible, indirect P2Y12. IV, irreversible, indirect acting P2Y12. Good job. Good luck. You guys will do great. No, you mean after Turner syndrome? Yeah, no, you give her that.
Oh, stay on there. Because
we should start. All right, guys. All right, so hopefully everybody will start trickling in from lunch. Hopefully the lunch was good. And by the time you sleep, I'll be done with my lecture, so it's the other attending's problem, right? Okay. So we're just going to talk a little bit about PAD intervention. I know you guys are starting IC or in your third year, so you'll deal with a little of endovascular stuff. So I'm just going to give you a basic overview of how PAD is and how endovascular interventions work. And then as and how you get into practice, you'll have a more detailed idea. So just to give brief talking over points, as you know, peripheral arterial disease has a significance clinically as well as epidemiologically in the atherosclerotic world, especially in the US. Major component of your atherosclerotic disease. Half of the patients who actually have PAD are asymptomatic. The other half, out of which 3/4 who are symptomatic, are untreated. So it's barely 1/4 of the total entire population that actually comes into the picture for management perspective. This is an older data, but just to give you a trend of how much the disease has been progressing significantly. And based on the prevalence of PAD in the general population, based on the ENHANCE study, the Partners trial, almost 1/3, 30% of the patients who are more than 70 years old or have a history of diabetes and smoking have a prevalence of PAD. So it's a significant problem which is there in the community, which is relatively underdiagnosed as compared to CAD, which everybody is focused on, and has a mortality. Just to give you an idea of how the PAD prevalence increases and how you'll see in your practice as well, older generation, more men as compared to women have significant prevalence of PAD as they get older. Also, amongst the different races, if you break down, blacks and non-white Hispanics carry the major burden of PAD as compared to other population as well. Everybody's, I'm sure, seen this Venn diagram where there's a crossover from PAD, CVD, and CAD. Again, re-emphasizing the point that how PAD is an essential component of your practice. And like I'm sure you've heard of this, you are cardiovascular disease fellows. You're not just cardiology fellows. So the vascular component does have a weight to it, not just the name to it as well. Important risk factors for your exam as well, in addition to your clinical practice: smoking, 6 times higher relative risk; diabetes, hypertension, hypercholesterolemia, all significant risk factors in the development of PAD. But adding together, if you add smoking and diabetes, then of course the risk also significantly increases. So something to keep in mind when you're diagnosing these patients with PAD. An important aspect of why even asymptomatic PAD is important is if you look at this all-cause mortality, which is what everybody as a cardiologist is concerned about, and all the medications, therapeutics, and devices work towards is decreasing the mortality. If you have no PAD, then there is no critical significance as compared to somebody who has PAD. But if you are asymptomatic or symptomatic, your relative risk of mortality is 2.2 to 2.8. Something to keep in mind as in how you treat the disease. If you follow these patients all along the way, the survival, which is an essential component of everybody's living, you can see that patients who have severe symptomatic PAD have a poor survival. Almost 25% of them survive at the end of 10 to 12 years. So another important comorbid factor in patients who are presenting it. That's why it's considered as an equivalent to coronary artery disease as well. Just to give you an idea of how diabetes plays a part of it and cardiovascular mortality, if you have PAD and diabetes both, your survival is the worst as compared to if you're not a diabetic, do not have PAD, then your survival is much better. Again, adding to the whole idea of why peripheral arterial disease is an important component of your practice. The good thing is most of the patients who present with PAD are claudicants, 73% of them, which are essentially stable. Rarely 6 to 15% of the patients eventually end up into critical limb ischemia, and only 4% go to amputation. So the progression is not as bad as I would think, but again, early intervention, early diagnosis, preventive mechanisms, and advanced therapies have really helped in controlling these diseases down the lane. Presentation from your clinical perspective as a fellow, asymptomatic is the most common presentation. They have the risk factors, they have the test, but they're asymptomatic. That's great. You can have classic claudication, which I don't have to tell you, but sometimes you can also have these atypical leg pains, which are not consistent with it, but always good to look into it. But sometimes if you venture in this field more in a more depth or detailed perspective, you deal with patients who present with critical limb ischemia, which is defined as ischemic rest pain, non-healing wound, gangrene, dependent rubor, or sometimes ulcer as well. So those are the common presentations of patients who present with critical limb ischemia. And then, of course, acute limb ischemia. Everybody knows about the 5 and the 6, actually the 6 Ps now. An important perspective from your exam as well is to know these two classifications, which is called the Fontaine classification and the Rutherford. Rutherford is mostly used nowadays as compared to Fontaine classification, and it's pretty much based on how much you can actually walk. So before we start looking into the disease process, a comprehensive vascular examination is an important component of your practice, which includes not only managing blood pressure, but also palpation for your abdominal aneurysm, auscultation for any bruise which you might have in carotid, taking just blood pressure in both the arms. It sounds very simple, but it could be technically quote unquote time consuming, because I understand you don't have much time, and most of the times the blood pressure is taken by a PA, NP, or an AA, depending on how your practice is set up. But something important to consider if you have patients who have a high risk of PAD, to rule out all this stuff. Examination of the feet and the legs is again an important component, and then stratifying your scaling of your pulses is important, not clinically, but also just to go from there. Again, important points for your consideration is leg pain with differential diagnosis. You could have spinal canal stenosis. You could have peripheral neuropathy. Just plain old nerve pain because of your herniated impinging sciatic nerve. Osteoarthritis, very common presentation. There's a concept called venous claudication, patient who has deep or superficial venous insufficiency, but they actually are in such an advanced stage that they say, hey, I walk 4 or 5 blocks, my legs start to really hurt up, they cramp, they swell up, but that's more because of the venous disease, not because of the arterial disease as well. So something to consider as a differential diagnosis in patients who are presenting with PAD. Baker cyst, of, analogous to your DVT. You can have compartment syndrome, muscle spasms, and of course, restless leg syndrome, another important diagnosis which is ruled out by having a good neurological examination. For your exam, always good to know a basic difference between claudication and pseudoclaudication. This is just a brief overview breakdown to give you a consistency. But again, there is obviously deviations between one versus the other, and it's not a true presentation how it goes. So how do we diagnose these patients who present with PAD? They come into your office, you do your physical exam. Of course, history is important, like we talked about, the risk factors, more importantly, the 5 of them. But of course, important physical examination is great. If you're building a practice, if you're trying to expand, if you're trying to screen, this is a nice questionnaire. It's called an Edinburgh Claudication Questionnaire, which has basic 6 questionnaires trying to give you an idea or directionality to say, hey, is the patient has a risk of PAD or not? It has a high sensitivity and specificity as well. One important testing that you can do in the office, cheap, easy to be done, also good exam question, is all about your ABI. So ankle brachial index, sounds very easy, done very easily. It's pretty much how you measure the lower extremity systolic pressure, the highest, divided with the denominator being the highest brachial artery systolic pressure. And that's where the whole concept of doing bilateral brachial blood pressures in your office comes into the picture. So again, high sensitivity and specificity for a PAD, it actually establishes the diagnosis of peripheral arterial disease just purely by doing this simple non-invasive testing. Patients who are at high risk, like I talked about, more than 70 years old, more than 50 with diabetes or smoking or symptoms presenting, those are good candidates for ABI. Again, like I said, we right ankle pressure. If it's a right-sided ABI, we do a right dorsalis pedis pressure or posterior tibial pressure, whichever is the highest. That becomes your numerator, and whichever brachial pressure is highest, whether the left or the right, that becomes a denominator, and then we come up with the fractions or the numbers. Same thing happens on the left side. This is your normal breakdown. ABI between 1 to 1.29 is normal. 0.91 to 0.99 is borderline, maybe not. You could do more testing. Anything less than 0.9 now starts to become classified as mild to moderate severe. If it's less than 0.4, then it accounts as severe peripheral arterial disease, more into the border of what we talked about, critical limb ischemia, meaning now the patient is having pain at rest. So having symptoms with an abnormal ABI is pretty much corroborative that you have significant severe peripheral arterial disease. Anywhere between 0.4 to 0.9 will depend on the claudication, mild, moderate, severe, depending on how it goes. Again, like give you an idea, 0.4 to 0.9 is mainly claudication presentation. Anything less than that gets to the idea of critical limb ischemia as well. Just to give you an idea why ABI is important, it sounds very simple, it sounds very easy, it's just some fraction numbers, who cares? There's actually a significant data to suggest that as and how your ABI decreases, your cardiovascular mortality as well as all-cause mortality goes up. So it is a number which has a substance, which has a data to it, and has a clinical value as well as a long-term value. So you can see, and the issue is, the other side of the spectrum is if it goes more than 1.4, we have the same problem. So between 1 to 1.3, which we call as normal, is essentially normal because the mortality increases on both ends of the picture. But like any testing, we have limitations to this. You can have incompressible arteries, as you know, our patient with dialysis, elderly patients, significant medial calcification. So in those cases, ABI doesn't work out well. Resting ABI can be normal. It's like having a stress test. You do an echo, it's normal. You do a dobutamine stress echo, now suddenly the ischemia starts to come out. Same thing happens with ABI. If you have a setup, then resting ABI is the best way to actually see exertional ABI is the best way to see whether the ABI really drops or not. And then of course, you can have non-compressible arteries as well. So in those cases, there are other modalities. You can do toe brachial indexes, you can do ultrasounds, which gives us more of an anatomical description, less of a physiological. ABI gives more physiological. You can also do MRA, CTAs to really define your anatomy or your presentation. We talked about the survival mode of patients who are presenting, especially the survival goes down, the MI, the intervention, the amputation rate goes up as well. So the goals of therapy of treating PAD is identifying it, preventing it, modifying it, and of course treating if it comes to it. So everybody knows about it. It sounds very simple, but certain basic characteristics will help you prevent a patient from undergoing or progressing to worsening disease and possible intervention. Smoking cessation, everybody knows, reduces CV morbidity, mortality, interventional cardiology symptoms, CLI, amputation, improves the graft patency. Antiplatelet therapy, again, proven, it's important. Everybody knows about the Capri trial, the sub-study. The benefit of the Capri trial was driven by the PAD arm, where it actually showed that Plavix works or clopidogrel works better than aspirin, with a relative risk reduction in these patients who present with PAD. So the PAD arm is what showed the benefit in the Capri study, further consolidating that antiplatelet therapy works. Everybody knows about using beta blocker, not contraindicated, managing your diabetes better. Of course, having an LDL less than 100, now 70 is eligible. The problem is the compliance with the patients. The prevalence is high. The usage of all these medical therapy in the treatment of PAD has been significantly low, but now increasing as and how it comes to it. Use of ACE inhibitors based on your as well as statins based on your walking distance. Statins are proven beneficial. Everybody knows about the multi-organ, multicellular effect of statins. But again, to reinstate the point that higher the dose of statins, more is the pain-free walking time, especially in these claudican patients. An important medication which we underutilize is not being used because of our scare. Patient is already on aspirin, Plavix. Do I want to put silastazol, what we call a spletol, in, add more issues to it? But it is one of those medications which has multiple effects at the cellular level. It has antiplatelet activity, antithrombotic. Is it vasodilatory? The commonest problem is tachycardia. Around 8 to 12% of the patients will present with palpitations as a side effect. And the other thing is because of his vasodilatory effect and increased blood flow is contraindicated in CHF, NYHA class 3 and class 4 heart failure. So heart failure patients, you have to be cognizant of the fact of not using it. But otherwise, it has a lot of beneficial effects. And it's actually proven that higher dose, which is 100 milligrams, the top curve works the best if the patient can tolerate it, as compared to 50 milligram as compared to a placebo. So for a claudicant, the most important determinant is how far longer I can walk without pain. And that's where the pain-free walking distance comes into the picture. And that's an important marker in these newer trials for intermittent claudication. So silastazol is known to prove it. One important medication, which I'm sure everybody is now incorporated into their practice, is the rivaroxaban, which is Xarelto, low dose. I'm sure you know about the COMPASS trial. Again, a sub-analysis of the COMPASS trial showed that your major adverse limb events, major adverse cardiovascular events, everything was significantly decreased in the Xarelto arm with aspirin as compared to aspirin alone, giving you the advantage. And then there was a more guided specific trial by Bonacca for his Xarelto use called the Voyager PAD trial, again showing significant benefit in patients who received the rivaroxaban 2.5 milligrams daily as compared to patients who did not receive it. Safety endpoints were met, did well, decreased major bleeding. So eventually the beneficial outfit was much better in these cases. So another medication to consider, again, I understand dual antiplatelet therapy, patient with atrial fibrillation. Now I want you to add some Pletal. Now I want you to add some Xarelto. So it becomes tricky, but it's more of a medical decision or more of an educated decision with family to decide, okay, can we transition from aspirin Plavix to only Plavix and then add some of these extra medications if the patient is known PAD that has more beneficial effect. If it's a high risk, it's a different story. But if you're documented patients who has PAD, it's good to transition them over to another therapeutic strategy in addition to their risk factor modification. One important therapy which will come in an exam is patient who has claudication. The treatment of choice is surgery, endovascular intervention. They'll give you the whole scenario, and first they'll say conservative therapy with exercise supervised therapy. So the answer is always, as we know, the most conservative part in all the exams. So exercise supervised therapy, for you guys to know, it essentially involves 3 to 5 sessions. I don't know if regular people even exercise as much as they want the patients to do it. It's their practicality is another question. But the duration, they want to do 35 to 50 minutes of exercise, 3 to 5 sessions a week for more than 6 months. And actually, it's proven that your walking distance increases by 100 to 150%. So it actually works. It's a great thing to start with in patients who are primarily presenting with claudication in addition to risk factor modification. But the problem is, number one is time, energy, effort, and then the issue is you don't get reimbursed for it. So those are the factors, but that's always an answer to consider when it comes in an exam of exercise supervised therapy. Again, just to give you a brief overview, pentoxifylline is contraindicated in patients with PAD, no more in use. So let's talk about what are the options for revascularization. We've tried everything, we've done everything. The patient has lifestyle limiting symptoms, whether it be claudication or the patient has progressed to critical limb ischemia or critical limb ischemia, non-healing ulcers. In those cases, active interaction or active assessment and reconstruction, either endovascularly or surgically, is highly recommended. So endovascular reconstruction, I don't know how many of you have scrubbed into some peripheral cases, whether it be iliac, SFA, or below the knee, but it involves a lot of modalities, a little bit more complex from the endovascular perspective. I'm not saying it's a higher acumen, but sometimes coronary can be easier, but this could be a little bit more complicated with more steps. But you could involve angioplasty, you could have atherectomy as adjunctive therapy, and then you involve stenting and drug-coated ballooning nowadays, which is a great treatment modality, first in the periphery and now, of course, translated into a lot of coronary issues as well. So this is a whole spectrum of endovascular intervention options available. You have PTAs, you have cutting balloons, scoring balloons, atherectomies, stenting, drug-eluting graft, drug-coated balloon, everything. But some of the important characteristics, that variables we need to consider when we decide on all this. What's the vessel size? What's the disease length? Degree of calcification, location, ability to tolerate antiplatelet therapy. You don't want to do a procedure just because you can do something. That doesn't mean the patient is good for that therapeutic option, because you have all these limiting factors: renal function, collaterals, runoff, diagnosis, access points. So a lot of things to consider before you jump on the table and say, this is what I'm going to do. A brief overview of the anatomy. I'm sure everybody knows about it, but again, aortoiliac, infrainguinal. So infrainguinal is considered as outflow. Inflow is usually the iliac disease, but there are 3 zones of revascularization important from management perspective, because at every level there is a different recommendation, different management, different guidelines. So that's why we stratify them into 3 different categories as well. PTAs essentially nowadays doesn't really work. We learned in the coronaries, plain old balloon angioplasty. We learned in the PTA, patency rate is horrible. So we have to have some adjunctive therapy and definitive therapy to give good clinical outcomes. These are some of the atherectomy devices, especially in patients who use highly calcified stuff. There are the types of atherectomy devices available in the market for you to learn and see, and hopefully you'll see it as you grow, the different kinds, because of different mechanism of action. There's directional atherectomy, there's orbital atherectomy, which goes around in orbit. Direction is you can direct it anterior, posterior, medial, lateral. Rotational atherectomy just goes on the wire. Orbital has a circumferential loop. You can use laser technology as laser atherectomy, and then of course lithotripsy, everybody knows about it. I'll give you just the names to throw in so you're educated enough that once you start doing your interventional fellowship or you're in your first year of a practice, that you understand what these different devices are, or at least basic mechanism. So we have a rotational atherectomy and orbital atherectomy. I'm sure you know rotablator and Diamondback. Diamondback is by, or 360 is by Abbott, rotablator is by Boston Scientific. The idea for these burrs, as you know, is to modify these plaques by having these diamond burrs. So you shave off, you call adjunctive therapy, you decrease the burden of disease, and then you can decide your definitive therapy, whether you want to do drug-coated balloon or drug-eluting balloon. A little bit different is your orbital atherectomy, where it runs on the orbit, so it's just more like differential cutting of the lesion as well. This we talked about is directional atherectomy. Main system is the Hawk system based on those trials, good patency rate. But the idea of this directional atherectomy is you can direct your catheter, the atherectomy catheter, to one direction only. So you have a little bit of control where this is what your blade comes out. This is your blade, which goes at around 10,000 RPM. You can direct it towards the plaque, and it essentially shaves off the plaque and collects in the basket right here. So another device for you to use and see would give you directionality. Again, different indications, different uses, but just to give you an idea how it works. We also have a combination where you have thrombectomy, where you can aspirate, as well as do atherectomy. It's called the Rotarex, mainly approved for instant restenosis or non-calcified stenosis as well. So you can actually see that it is, again, a burr, but it is based on this Bernoulli's theorem, where you create flush. You have a negative suction, where it sucks all the clot and the plaque out at the same time, thereby trying to avoid distal embolization and get the thrombus out as well as the plaque as well. More commonly used in instant restenosis for patients who have a combination of your plaque as well as thrombus combined. Intravascular lithotripsy, I'm sure everybody have had a hands on it, or at least seen. It's just basic concept of lithotripsy translated from your lithotripsy, the ureters, all the way into the peripheral and then into the coronary. There is enough convincing data from safety all the way to randomized trials, multinational randomized trials, which have shown effectiveness of IVL. Essentially involves a generator, generates ultrasound beams, 50 atmospheres of pressure, cracks the calcium. So this is less of what we call as plaque modification, more of increasing the elasticity of the vessel wall. So now you can go, and now the rigid wall is becoming more compliant. So that way now you can use your other balloon angioplasty, DCB or DES, by causing these micro dissections, thereby able to expand. I'm sure everybody from the coronary side is going to talk to you about how calcification is your biggest enemy, and underdeployed stents are the worst thing you can do. Under ballooning, under deploying is not a good therapy. So this is a great therapy in those subset of patients who actually have significant calcification, helps you with microfracture as well. And again, just to show you that the energy is all the way down, the advantage of this is they proved superior procedural success, decreased 77% dissection, which is the commonest problem is you end up stenting is because you dissect. And the reason you dissect is because you have a lot of calcification and you really use your balloons to crack it open. So the chances of decreasing dissection at lower pressure is much better in this lithotripsy arm. With technically they showed 0% embolization, perforation, thrombus, or no flow. So great, another device to use. And like I talked about, the primary patency, the secondary patency is right there. And this is just a model to show how it works hard on the hard and soft on the soft. You can actually hold the lithotripsy device and it doesn't touch you or doesn't affect or cause any trauma, while on the calcific gypsum model, it actually can break the model as well. And this is just a microvascular to show you. Before we end, just to give you a talk about stenting. Stenting is another big arm right now in peripheral, but with the drug-coated balloon technology being there, the use of stent has actually gone down. It's simple, it's quick, it's reasonable patency. The problem with any stenting, and as in how you do more endovascular stuff, you'll realize that longer the stents, more the chances of ISR, they come back even worse. So it becomes an issue as well. But overall, the stent results from the previous, which is the non-drug-coated stent, which was the resilience stent, shows great clinical success, great long-term primary patency and MACE as compared to plain old PTA as well. The one stent we should know about, or you should have interaction with, is what called the Supera stent. It's an interwoven self-expanded nitinol stent. So it's technically one wire, which you actually create a stent in the vessel while you're deploying. So it doesn't come free-formed. You have to really make a stent in the body. The good thing is it has excellent radial strength. It is very flexible, easily morphed. So you can see at the popliteal, at the femoral artery, or the hinge points, where there is, whether the knee or the hip, it gives you great patency. So it's king kink, crush, fracture resistant, and with great patency results as well. So you can see how normal stents would kink at the edge if you bend it. Supera stents conform, so it's called vascular mimetic stents. That's what we call it. So great trial results from it. They have a 3-year data, primary patency, secondary patency, freedom from target lesion revascularization was important. The problem with these stents is you have to deploy it nominal. So the deployment, because it's very operator dependent, you actually have a learning curve. So if you don't deploy nominal length, if you elongate, then the patency and everything goes down. That's the problem. Or if you compress too much, then again, it's an issue. So ideal nominal deployment is the best result as expected. But if you elongate, then you're actually causing more harm than anything else. So that's one learning curve you have to do. But there is, again, like I said, excellent trial results, whether it be severe calcification, whether the joints, 3-year data suggests that the Supera stent with the Superb trial has great patency results, whether it be severely calcified, long lesions, short lesions, everything as well. So this is just to give you an overview of how the patency is across the board. These are the stents, the Supera stent, the Zilver stent, which is the drug-eluting stent. These are the regular non-drug-eluting stents, and now you have the covered stents. So there is across the spectrum a lot of data available in order for us to decide on how these stents perform, how the endovascular intervention performs. Another important data to consider, especially the drug-eluting stent part, is the Zilver stent. All of them have paclitaxel. Now we have the Limus technology getting incorporated, and we have trials coming up with the Limus stenting. But initially, they all started with the drug-eluting stent part, and you can see Zilver was the first drug-eluting stent, paclitaxel-based, randomized between Zilver and PTX, and if you failed PTA, you did a provisional with the bare metal. So you compare your regular PTA with the drug-eluting stent, but if the PTA needs a stent, you also compare the drug-eluting with the bare metal stent. You can see across the graph as and how you follow these patients for 3 years. Excellent data. The red one is the primary patency effectiveness analysis. The primary patency of Zilver is phenomenal as compared to PTA. If you compare it against a bare metal stent, again, statistically significant, even though borderline, the curve is always there. So there's always a graph difference between two as well. And target lesion revascularization, everything shows great stuff. Another stent in the market, which you see about, is the Illuvia stent, another technology, same paclitaxel base, different concentration. They did a head-to-head trial in which actually showed they actually work better than Zilver PTX. There is some criticism of the trial, but it's a nice head-to-head comparison between two stents having the same paclitaxel in there, but performing a little bit different as well. So last thing before we end is drug-coated balloons. A major change in our management of endovascular techniques. We believe, especially at Sinai, but a lot of people in the endovascular community believe in what we call as nothing left behind. We don't want to stent unless we have to. If you can get away with the drug, that's great. So the good thing is there is no metal left, so the chances of in the future bypass or stenting is still there, because once you stent, then it becomes a big problem with instant restenosis. So in these cases, drug-coated balloons are there. I'm going to quickly go over, but there are 4 of them were in the trial. One is from Medtronic, one is from BD, one is from Spectranetics. This is just, and one is from, one more, whatever, 4 of them. So this is just the basic pathology behind it. There are 7 stents in Europe. The idea is to deliver the paclitaxel, which is what we which inhibits your muscle growth, inhibits the restenosis, increases the patency as compared to PT as well. So multiple trials again to show that how these drug-coated balloons have also improved your improved your outcomes, improved your primary patency, decrease your target region revascularization as compared to everything else. Last point is bioabsorbable stenting. I'm sure you guys probably near enough, but for me and Nitin probably know, the bioabsorbable stents initially came in the coronaries with the Absorb trial. Unfortunately, they did not do well because of technical issues, had a higher thrombosis rate, was pulled out from the trial didn't do well, but then they translated that trial back into the periphery, and they're like, below the knee, we don't have much options, patients have small vessels, we really are using coronary stents, which is off-label technically, so what can we do to enhance the patency? So in this game, they came up with the Esprit, which is below the knee drug-eluting resorbable scaffold for patients who have no options left. So if you're not a bypass candidate, this is another new option of stenting below the knee, which is a totally new spectrum there were. So it's a great randomized trial, multi-countries, US and outside, 2:1. See endpoints, primary patency, as well as safety. We want to make sure it's safe and primary patent. Now they technically have a 3-year data, which actually shows phenomenal results. So bioabsorbable stents did well. Their patency, limb salvage, everything at 1 year, 2 years, 3 years, everything went great. You can see that there was a difference between a regular PTA, which was our only option essentially from an endovascular perspective, to do greatly well. And then the secondary endpoints, binary stenosis, were all phenomenally well. And now we have a 3-year data, again, proving that the safety, efficacy, and the non-inferiority was there. And this was an NEGM article which was actually released by Ramon Barco and his team, showing the importance of these trials. So just 5 points to remember, especially from a PAD perspective, is it's a common disorder. Look for PAD by asking questions, performing ABI. Remember the Venn diagram, simple, easy. Encourage all the risk factor modifications. Smoking cessation is the hardest. Is the easiest to say, but the hardest to control, because I'm sure you see a lot of patients. People are ready to take any kind of medications, but the smoking is a big problem. Refer to a vascular specialist if you think it's not an issue, and always consider, if once you reach that state, endovascular approach first, if required, and if the patient warrants. All right, thank you so much. Any questions? Yes.
Sure. When would you prefer to use clopidogrel alone for PAD? And when will you prefer to use low-dose rivaroxaban and or low-dose rivaroxaban with aspirin?
So, that's a great question. So there's a lot of, remember, there's a lot of overlap between CAD and PAD. So most of the patients you'll see who have PAD also have CAD. So we obviously want to take the precedence of how the CAD is doing. So if from a coronary perspective, if the patient needs antiplatelet therapy, we recommend the patient, depending on the physician. Nowadays, the guidelines are changing. We do DAPT only anyway 6 months max. We drop the Plavix, keep the aspirin. If some people like, whatever it might be, what I mean to say is keep one antiplatelet, and then we add the rivaroxaban 2.5 for sure. So we have to have 2.5 BID of rivaroxaban with any antiplatelet you like. Plavix plus rivaroxaban works fine, or aspirin plus rivaroxaban. The trial is based on aspirin plus rivaroxaban. So if you add Plavix plus rivaroxaban, we are probably just extrapolating our data saying, okay, one antiplatelet with one anti-loaders, anti-thrombotic. The trial was aspirin and rivaroxaban. So if the patient, after his dual antiplatelet therapy, if had an intervention, if they drop the Plavix, we can do aspirin and rivaroxaban. That works great, should do well. If the cardiologist wants a Plavix, drop the aspirin, we can still do Plavix plus rivaroxaban and just monitor for bleeding. We haven't seen personally, anecdotally, I haven't seen a lot of bleeding with these low-dose rivaroxaban, but we always have to be cognizant about it.
What's the low dose, 2.5?
2.5 BID, twice a day.
I have one question. There is something, venous ablation is done very often for very minimal indication, but these peripheral arterial disease patients, vein grafts can be used. I'm told that the veins from the periphery can be used as graft, and also for the coronary artery.
Correct.
Isn't there any guideline or a restriction on these very excessive use of venous ablation, even on very young people, and not for a very significant indications?
Right. So that's a very good point. Again, so the venous ablation, the guidelines suggest your vessel has to be more than 0.5 centimeter dilated with a 500 millisecond reflux. So if you're truly doing a real patient who has venous disease, the vein is already dilated. So the vein already becomes redundant. It's not a good candidate for bypass as well because it's already varicose veins. If you're doing on a normal vein, then of course we're losing it. So graft size, which you can talk about, the grafts, you don't want like huge, gigantic grafts because then because the veins are already denaturing, whatever you want to call it. That's why they become varicose. Of course, the phenomena is because of the valves, but the vein itself are so tortuous and so dilated that they're not a good candidate if you're doing on a real patient. If you start doing on a smaller luminal patient, then it becomes a disservice that long-term wise, is it going to help or not? The other issue is most of the times the venous grafting is taken, the GSVs they take is from below the knee, but most of the venous reflux is above the knee venous reflux. So technically you can still do a GSV ablation of above the knee of those dilated veins, leave below the knee GSV because they don't have much reflux, and that could be harvested for your bypass, thereby serving both purposes. So I think it's more of where the patient lies, what's the degree of disease, what's the degree of presentation, and knowing something. I mean, if the patient has a lot of varicosity venous ulcer and who's 35, and you tell them, hey, you might have a bypass when you're 70, but right now you have an ulcer, so let's wait 35 years and not do anything, that's also a disservice. But at the same time, you're right, a 35-year-old person who has minimal symptoms and the vessel is borderline, and you say, I do a venous ablation and get it over with, that is again a disservice. So I think it's a clinical decision you have to make from your perspective of what the presentation is, what's the ultrasound result, and then make an educated decision. All right, perfect. Thank you.
So in this time of the World Cup, just make sure I get my extra injury time for my talk. No, I'm just kidding. So welcome everybody. Congrats to the graduating fellows, both general starting an IC fellowship and those finishing IC fellowship. I'm Nitin Barman. I'm going to talk about radial intervention. Got a lot of slides, and it's going to be mostly kind of question-based, so we'll try to go through them too quickly. No disclosures, so we'll jump right in. Use of transradial access for PCI in the United States, 10, 25, 45, or close to 60%. It might be good to just kind of in your mind think of what you think the answer is and see what areas you can get better at. Yeah, good. That's going to be turning out to There's this, we get data periodically when they get cumulative data. This is 2016 NCDR data. At that time, in 2040, that's 10 years ago, it was 25%. The VA CART program, those that have VAs understand this. You can look down in the bottom right, it was around 33%. Again, that was 2015. More recently, big data from NCDR, 6 million cases, 40% were performed by radial, but if you look across time up to 2022, it was 57%. And the increase was seen in all geographic regions. Just to show the outcomes, again, this is observed, not selected data. In-hospital mortality, access site complications were less. There was a fractional increase in stroke, which we'll talk about later. This is, again, unrandomized data. So 60%. What about for STEMI? 8 to 10, 15 to 20, approximately 50, 25 to 33. So again, it's a little bit tough to get your handle on this in real time. NCDR, again, published, this is, again, for 2016, it was up to 25%. A lot of data has been accrued since then, which we'll review, which shows the value, especially in those cases. To give some perspective, the US versus Europe, this is Validate Sweetheart, not a radial trial, but it was a bivalve versus heparin trial, but I bring it up to show it's a STEMI trial to show in this trial, which didn't mandate any access, 90% of patients in Europe were getting transradial for their STEMI. Currently, there was a kind of a line item published by Sky that was approximately 50%. Hopefully that's even more. Major bleeding post-PCI in ACS patients is associated with higher rates of which of the following? So this has nothing to do with radial, just if you bleed with your PCI, death, MI, stroke, death and MI, or all of the above. Maybe it's a little bit easy question so far. They'll get harder. Yeah. So this is just, again, older but still relevant cumulative data from several ACS trials. You can see the red bars, patients that bled had huge hazard ratios for all of these outcomes, death, MI, and stroke, 4, 5, 6 odd ratios. So it's not a good thing to bleed if you have PCI or especially ACS PCI. All of the following completed RCTs of transradial versus transfemoral access for ACS met their primary endpoint except. So Rival, STEMI radial, Rifle, Matrix, Safari, STEMI, or all of them met their primary endpoint. So I heard A out there that didn't. So the answer is completed, and it's important to read the questions. Completed RCTs, so the one that didn't. So it's all met except. Okay, we got A. All right, so keep it in your mind, but we'll see. So this is an opportunity to go through the trials, obviously. The Rival trial, pivotal trial, 7,000 patients, non-STEMI, STEMI, radial versus femoral. Primary outcome of NACE, so death, MI, stroke, and bleeding. And whoever said Rival, I think they're going to get that one right. No difference in the primary outcome, okay? But we're going to get into the weeds a little bit. It wasn't worse, and certainly it was numerically trended better, but there was no difference as defined. When we looked in that trial at the subgroups of STEMI, this was not, this is kind of hypothesis generating. We looked at the STEMI subgroup, it wasn't randomized this way. We did see significant reductions in the primary cumulative outcome, but especially in death as an individual component of that. Again, hypothesis generating, which then subsequently was borne out. STEMI radio was a STEMI trial in Czechoslovakia, 4 centers, 700 cases, radiofemoral, excellent follow-up. Their primary endpoint was just bleeding and access site comp. So unsurprisingly, this was a very positive trial, 7% versus 1.5%. They did look at MACE, and MACE and the components all individually trended to be better with radio, but not statistically significant. When they added bleeding to the MACE, i.e. NACE, of course, it was markedly positive, driven, of course, by the bleeding outcome. RIFLE was an Italian trial, 1,000 patients. What was interesting about this, all STEMI patients, what was interesting, they included everybody. They could be in shock, they could be on multiple pressors, they could have no pulse, radio pulse, and it kind of informs, I think, some of the results. Their primary outcome, 30-day NACE and non-cabbage bleeding, both of which were substantially included. So when you include bleeding into the outcome, it's generally going to be a positive trial, although we'll look at RIVAL, which wasn't. Interestingly, MACE was also substantially reduced, even though that wasn't the primary outcome. And when we looked at the MACE components, unlike other types of component outcomes, it was driven by the most important component, individual component of the composite outcome, which was death. Now, some people said, how could you have a 4% reduction in death? And there's a lot of kind of explanations, but this was randomized data, and this was what was found. Very experienced centers, but I think the key was there's a very sick population as well. So the bleeding rate, just to show this, the bleeding rate was all in access site related bleeding. So you would expect this with that difference, and not to have difference in non-access site bleeding. What about matrix? This was the one that really started to move the needle on this side of the ocean, and also we gathered a lot of data from this trial. Complicated design, radiofemoral, and then there was a bivalve heparin subrandomization, 8,500 patients, a MACE and NACE primary outcome. Interesting, the primary outcome of MACE, while P.03 seems significant, it was predefined as 0.025. So this technically the MACE wasn't, although it was 1.5% absolute risk reduction. When they added NACE, it was 2% reduction, and it was very significant, P.009. So also positive. What about Safari? Safari was a trial that a lot of non-trans radialists kind of quote as data that supports using either femoral radio. It was, a STEMI trial, and there was no difference. In fact, this trial had to be stopped. But if you look at the rates of these events, okay, this 30-day mortality was so low, and they had predicted 4%. So it was stopped for futility. It doesn't mean that there wasn't a benefit. It just means that the study population, it didn't seem like that was going to come to fruition. So completed randomized trials that did not meet is technically RIVAL. Well, why didn't RIVAL meet? Well, let's talk about that. In RIVAL, the primary outcome of 30-day NACE was not different between the groups. We saw that. However, major bleeding was significantly lower in the group randomized to transradial access. True or false? A little bit of quiet there. Okay. So we'll see. It's tricky. It's a trick question. And the answer is it's false, but it's how they define bleeding. They use TIMI non-cabbage bleeding, which is like near exsanguination. It's a very severe definition of bleeding, and there was no look at the rates, 0.5% in a very high-risk ACS population. When we looked at acuity bleeding, markedly reduced with transradial access, okay? So technically false, but probably not clinically false. In the matrix trial, benefit of MACE was seen regardless of center proportion of radio PCI, meaning the centers that did a lot or the centers that didn't do a lot all had benefit. True or false? Okay, can I give your answer? Well, if you look at it, really the benefit was seen in, statistically, on the higher experienced center proportion volumes. You can see the drops here on the right of the screen where the intermediate and low, they were not statistically different. So this was false. It was not seen, despite it was really only in the expert. And that informs kind of guidelines and thought process. It generally means that low volume centers should work to become high volume centers, and there's a process for that. What about female patients? Female patients experience a higher risk of severe bleeding and access site complications compared with male counterparts, but still derive significant reduction in these complications as well as ischemic. So higher rates, but still have a benefit. Seems kind of true. Well, again, matrix, we had a lot of sub-information from this, access versus and sex. Finding is a complicated slide. You can look here, women are red here, and men are blue, and then femoral is dashed, and radial is a solid bar. And you can kind of see these are the co-primary endpoints. The highest risk group is clearly women who receive femoral. There's a drop in all of those, meaning all of the dashed lines are higher than the solid lines, but the absolute rate in the red, which is females, was higher across the board. So this is a true statement. And this will get into kind of who should this be applied to, especially. In Matrix, the benefit of transradial intervention ACS patients in terms of reduced vascular complications, so just the vascular complications, was only seen when compared against transfemoral patients who did not get closure devices. Is that true or false? So meaning the closure device patients, they didn't have the same benefit versus radial patients. It is very false, correct. I heard that louder in the audience. So this was looking at that, and you can see here, the incidence, this is with and without, the blue and, is that arrow showing up? Yeah. With and without vascular closure devices was no difference, substantial reduction. And we already would have supposed this. We know vascular closure devices do not reduce access, quicker time to ambulate, quicker time to leave the hospital, but not a reduction in access complications. So that the benefit is seen regardless of VCD use. ACS patients' cumulative randomized data suggests significant reduction in mortality at the cost of a slightly higher incidence of CVA. True or false? Maybe some truths out there. Well, this is cumulative randomized data. So concomitant with Matrix, they updated a meta-analysis, they submitted an updated meta, 20,000 randomized ACS patients. No difference in stroke. Okay, now again, the NCDR data was unselected. It showed reduced mortality, reduced vascular, but it did show slightly higher stroke risk, but not in the randomized data. So it's probably very technique specific. False. Okay, I'm going to zip through these. It's a little bit dated here. So ACC/AHA guidelines 2021 for transradial access for PCI. So yeah, 1 level A. I got to give a little history. It's written here, and it's interesting. They put additional line items here that for ACS patients, it's preferred to reduce risk of death, vascular complications, and bleeding. For stable ischemic, it is to reduce bleeding and vascular complications, which is what the data says, but it's 1 and A for both. Interesting, there's a line item to use radial artery when feasible for patients with CKD. We'll talk about the matrix and AKI risk shortly. Some historical perspective, it was 2A in 2011, ACC/AHA. 2013, STEMI guidelines didn't even have it listed. It was just said use when feasible. 2014, non-ST elevations, no mention at all. And this is at a time where in 2015, just a year after, it was in ESC, it was a 1A. This is 10 years ago. And it took us 6+ years to get that into our guidelines. 2025 ACC/AHA guidelines, again, this has it as a 1A. This is more recent kind of chest pain guidelines. Anyway, so it's 1 and level A, so I think we put that matter to bed. The absolute reduction of in-hospital mortality in STEMI patients is derived from all of the following except a significant absolute reduction. TPA strepto, primary PCI versus lytics, door to balloon, transradial, transfemoral, or all of these result in significant decrease. So E, again, this is more like a question that was designed to allow me to talk about the other things. It gives it some scale. I mean, these are major paradigm shifts. Everyone here is too young to know the evolution of STEMI care precisely, but when we went from TPA from streptokinase, there was a 1+% drop in absolute mortality. Same PPPCI, PPCI versus lytics, substantial reduction in absolute mortality, 2%. Door to balloon, this is a little bit complicated, but if you go from 2 to 1 hour, you have a drop of over 50%. So this is really on the same scale. So really, this number should be in the 90% range as it is in Europe. Hopefully, we'll get there soon. Okay, I was talking to one of the fellows outside about this. Those most likely to benefit from transradial access are most likely to receive it. How could this be false? How could this question? It is false, and I'm just going to spill the beans on it. This is called the risk treatment paradox, as many of you must know, that those most likely to benefit are the least likely to get it. Well, this is just a slide of bleeding. We can calculate bleeding risk, a variety of different presentation, shock, female gender, body size, age, New York class, Heart Association class. You can get an asymptotic risk of bleeding, okay, prediction. Yet when you look at this, and this is 17,000 patients or similar trials I'll show in a second, this is 3 groups. Those predicted to have low, intermediate, or high risk of bleeding. And then there's radial femoral use in each of those. Femoral is in black here. So you can see the femoral use is increasing as the risk of predicted femoral bleeding increases, which does not make sense, obviously. And that's just subgroups. So that's a paradox. This was looked at a little bit more closely recently. This was 28,000 patients, 7 hospital Barnes Jewish system over 10 years. What did we learn from there? Similar thing, okay? The highest risk group for bleeding, AKI, or mortality, least probability of use of transradial intervention, okay? So very bothersome. This just shows kind of absolute number needed to treat. You just have to treat 30 patients to reduce a bleeding outcome, or 40 patients for an AKI, or 18 patients for a death outcome, this is actually saying the same thing here. So this is false. Unfortunately, and kind of curiously, it's false. Transradial versus transfemoral PCI has been shown to have higher MACE rates in which of the following complex subsets? Or are there some groups that should not be getting radial? You probably would have learned that and know that this group should be excluded, so you therefore probably know the answer is none of the above, but we're going to go over the data for CABG, left main, CTO, shock, heavy calcification, complex bifurcation. All of this has been studied. This is a trial some people like to quote, radial CABG, which showed substantially higher contrast volume time fluoroscopy for radial versus femoral, so a femoral win. But look here, 120 total patients. If you look at the methodology, and no offense to the fellows, the fellow was allowed to be the first operator for 3 minutes, so there would be likely increase in time. And the CABG anatomy was known more in the femoral group than of course it's going to take longer if you don't have the anatomy. So really kind of a flawed data to say this is, and it's a randomized study, but when the samples are small, you're going to get differences that are important like this. The L record story was 4 institutions in Greece, 150 patients, also not too large, but no difference between radial or femoral for bypass. What do we do in these scenarios? We get cumulative data. This is a meta-analysis, now granted just 1 RCT, 8 non-RCTs, but 2,800 patients, and what do we see? These tree plots show no difference in fluoro time or procedure time, no difference in procedure failure rate or contrast time, okay? But what do we see? Less access site complications, and slightly higher, so the crossover was slightly higher, and statistically higher, and at crossover. But crossover is an entity that you would be willing to accept, in exchange for a real outcome like access complication. So this is NCDR data, 1 million patients, all with cath PCI done in prior CABG. I show this to show in that, again, unselected mortality, bleeding, and vascular was less in CABG patients who got radial procedures, okay? Interestingly, the trend, it went from 1.4 to 18%. So it's pretty dynamic. And those that had higher TR rates for non-CABG patients obviously had higher TRA for CABG patients. What about left main? 17,000 patients. It's a little tough to do a randomized left main trial. 12 observational studies. Again, less access vascular complications, equal procedure, fluoro contrast, and procedural success. So you're getting all the efficacy with better safety. CTOs, I'm going to go a little bit faster through this. This is a recharge registry, 1,250 CTOs, 17 European centers, fully TR versus any version of TF. As you can see, the success rates were equal in all groups. They declined as the JCTO got worse, which is what you'd expect, but the differences were non-significant. This is progress CTO, 4,000 about CTOs, including US, which is important. Fully TR was 11% in 2012 and 67% in 2018. So these are, again, CTO centers, higher advanced, more likely to adopt progressive care like transradial intervention. This is kind of a complex slide. Statistically significant less TR access for higher is what we saw. No difference in the procedural outcomes. In fact, there was a trend towards kind of better outcomes, procedural success with radial, but again, there was statistically less used in the complex CTOs. This was the only randomized trial out there for CTO and transradial. It was 4 centers, 600 patients, a good trial. Mean JCTO was 2.1, so on the simpler side. What did they see? Well, you've heard this story before. Equal procedural success, actually equal crossover here, and less access site complications. What about for shock? This is post hoc analysis. Remember, culprit shock was not an access trial. 673 patients, 17% were TR. It would be 50-50 if it was for the access. But in the TR group, which again was not randomized to that, better 30-day and 1-year outcomes. Okay, statistically significant over here for renal replacement therapy and all-cause death in the short term. What about NCDR, which is again our source of kind of large volume unselected data? 35,000 patients, 25% TR, 75% TF, same findings. Improved bleeding, less mortality, less vascular complications, and dialysis. So what about for large bore? Like people always argue, okay, well, we need larger bore access. Okay, a lot of that has evolved because of the technology, but when you need large access, seven or eight French, there was a trial, color trial, again, 400 patients, planned complex intervention, CTO, left main, heavy calcification. And in the 7 French TR cath, again, we would very much expect this difference to be accentuated if you had a 7 French groin access with equal procedural success, slightly higher but non-significant crossover. So none of these have been shown as groups that don't benefit from transradial. Okay. What about RAO? RAO, which of the following have been proven except smaller sheath size, therapeutic anticoagulation, patent hemostasis, ipsilateral ulnar compression, post-procedural, avoidance of repeated NG distal. There's none of the above, so this is smart to say distal there. I'm going to go quickly. The larger the sheath, the more likely there is to be occlusion. That's 7 French. Our technology is advanced. Slender sheaths are the norm now. The outer diameter is less. The inner diameter is preserved. Therapeutic is an old slide. None versus intermediate versus therapeutic. Substantial drop in RAO. Patent hemostasis here. We know this for a long time. This substantially reduces as a reverse Barbeau. You occlude the ulnar while the device is on, but you still have your waveform. That means it's patent. This is patent hemostasis in the short and long-term substantial reductions. I mean, it's unquestionable. This is the Prophet 2 trial. Dr. Pancholi, Tejas Patel, they looked at ipsilateral ulnar compression, and interestingly, they saw at band removal, there was substantially less radial artery. This number's a little bit high, surprisingly high, but when they did ipsilateral ulnar, the rates dropped, and that persisted over time. What about rivaroxaban or NOAC with this? This is a small trial, 400 patients that got rivaroxaban for 7 days versus placebo prophylactically afterwards, and they had less RAO, although kind of modest results, and giving a rivaroxaban is not a trivial entity. So we do consider that patients that have a documented RAO at time 0. Repeated use, the diameters decrease with repeated use. What about the snuff box? So this is where a lot of people kind of got excited and stuff. You know, it's fine to do it. There's a lot of downsides to it. I don't think the upside's justified. 5 RCTs here, meta-analysis, 1,000 patients. Really no difference in the rate of successful cannulation. Radial artery occlusion was trended better, but it wasn't statistically better. But crossover was substantially higher. This was the discal radial, one of the largest of that, and really it basically showed no difference. Again, trending better for RAO, but no statistical difference, and a lot of higher time to access, more tools, and more crossover. So that's the technical right answer. Radiation exposure is higher in transradial procedures for ACS compared with transfemoral, regardless of operator experience. True or false? Is radiation exposure higher for transradial? It is true, unfortunately. But we want to talk about the relevance here. So yeah, so you can see the radiation exposure is higher in all groups, statistically significant in low volume centers. Again, from Matrix, we got a lot of data about radiation. And what we saw here, this is operator radiation, radial versus femoral, radial being in the blue. It was significantly different at the thorax, numerically so at the wrist and eye. So this is a true statement. But how important is it? It's important. Our health is important, of course, but we want to understand the kind of the amount of magnitude and risk and where other forms of risk come from. So even though while overall radiation exposure has decreased, the difference between radial and femoral radiation risk or exposure has remained constant. So both have declined, but declined equally such that the difference is equal. Is that true or false? It's a tricky thing to answer, but it turns out that it's false. This is a meta-analysis, kind of complex statistics. They used all these trials, and they looked over time, so this bubble plot, what the difference between radial and femoral radiation. You can clearly see there's a decline in the difference in radiation risk between radial and femoral. Okay, this is a function of learning how to do things better. This is an older consensus statement, transradial, ways to do things with less radiation. We used to fluoro up the arm all the time. We don't do that anymore. Most of you guys in practice, with a J-tip wire, you go without fluoro. You use fluorosave, okay? And this slide just shows this graph is that people that are low radiation femoral operators, they will be low radiation radial operators. And if you're a high femoral operator, you're going to be a high radiation radial operator. Your radiation hygiene is much more important than your access site, which is the point. So this is false. The learning curve, 50 to 100, 150, 200, 250. 50 to 100, excellent. You can see inflection points in terms of contrast, fluoro time. Inflection points really occur in about that 50 to 100. And that's just kind of common sense. This was an old slide or graphic from your intervention when they published the kind of initial radial guidelines of how to kind of accrue this in your practice. It's less relevant now. I think most training programs are doing this substantially. Right radial access has less fluoro time and contrast use, but it provides more operator comfort and provides more comfort. So less time, contrast, more comfort compared to left. True or false? True. Okay, you got to read them closely because this one, you got to think like, okay, left is definitely less comfortable, so it's going to win on comfort. But is it easier to do it from the right or left? And it actually is going to be false because of left versus right. And again, from radial, we saw this. Right radial is in this is radiation exposure. Right radial is in the orange here. And you're going to have more radiation exposure because of the time of the procedure, and it's higher in all areas where they were measuring compared to left, which is in the blue. This is a meta-analysis, and this is left versus right for fluoroscopy time. Much better for left. It approximates the femoral procedures. One less inflection point. There's not an innominate artery. Doesn't, issues with shorter patient heights, things like that become less relevant. So contrast use also favored left radial. Operator discomfort, you can clearly see left radial. And this is about getting a good system, and this is an older, because the slide is older, but left radials can be painful. Everyone's head in the room drops when there's a left radial, but if you do it properly, this is not as big a condition, but clearly right radial is comfortable. We're more familiar with that. So in the matrix trial, what about AKI? Was it greater in the group randomized to transfemoral femoral access? Do they have more AKI? True or false? Okay. You might not think, like, why would access site be related to this? But there's a lot of reasons that it's possible. But so this was the sub-study, and what they saw was that substantially statistically relevant lower risk of AKI in the radial compared to femoral, depending on, regardless of definition, 25% increase in creatinine or a 0.5 absolute increase. And most importantly, when they did the tree plot, they saw who was most likely to benefit from this AKI reduction. Well, those that were most at risk to develop AKI. A GFR less than 60 to start, older patients, advanced killed class, those that had Moran scores greater than 10. So again, a risk treatment paradox situation there, where those most likely to benefit, they may or may not be getting but they are most likely to have less AKI if they were at higher risk. So that's true. What about hospital costs? I'm wrapping it up here. Primarily by way of reduced length of stay are significantly reduced when compared. I think everyone's going to know that's true. This is 7,000 U.S. hospitals, an $800 average saving per case. Obviously, that was accentuated in the highest bleeding risk type patients. And when they looked at where that money saving came from, it was largely length of stay. So 0.4 days lower, shorter stay. So it's several hours on average. You might think, well, how could you have like 12 hours less? Well, some patients stayed for 2 days, and et cetera. So the average was 0.4. What about in England? This is BCIS, 300,000 patients with PCI. Same findings, 200 pounds, 250 pounds. So this is true. One last one here. Unless they've suffered a complications, patients prefer the same access for subsequent procedures. True or false? So even, let's say if you didn't have a complication, you would prefer the same access. I'm not sure I worded that great, but so it's false. It is false. So that's what we're getting at. It's more than just these numbers. There's a quality of life portion to this, so patient experience portion that may not be reflected in vascular access complications. So this just shows that quality of life has always been deemed better with transradial, a bunch of metrics that show substantially better quality of life TR versus TF. But this is an interesting slide. Back to Rival. They asked patients, do you prefer the same thing that you were randomized to? So the femoral patients were asked, yes, do you want the same femoral? And only 50% said yes. Obviously 50% didn't have complications, but only 50% preferred the same access, whereas 90%. So it was substantially better experience for patients as well, is what the point is. So it's false. And one last question. If you or a loved one And this should be the mom test. You guys are all going to go into practice. I would strongly urge you use this type of mentality when you're talking to patients. Like, is this okay? What's happening to this patient? Is it okay were it to be happening to your family member? What would you want? Would you want radiofemoral? I mean, it's a simple question. You just got to ask yourself that. And if you know, we'll leave it at that. Thank you. Happy to answer any questions. Good luck. Yeah, I didn't steal your time like Vishal. Where's Vishal?
No, that's fine. Thank you, Dr. Barun, for an excellent talk. Hi, my name is Amit Huda, and after transradial talk, we're going to talk something different about the coronary bypass graft intervention, which is not very usual in our day-to-day practice. So I have no relevant disclosures. So in next 30 minutes, we'll be talking about the mechanism of graft vessel disease and how they fail. We'll discuss about the optimal angiographic views to define the graft vessel disease. We'll be integrating procedural planning and decision making, so whether to do the graft vessel versus the native vessel PCI. And after this talk, I hope you will be able to select appropriate interventional technique and devices for a successful graft vessel intervention. And in the last, we'll be talking briefly about the common complications which you may encounter during this intervention and their management. So as you are aware, there are different type of grafts. So mostly venous and arterial, broadly, they categorize into two groups. And most of the time, we use saphenous venous graft for bypass and along with the internal mammary arteries from right or left. Sometimes they may be like free lima or rima also. Gastroepiloic used to be used in the past, but in my few years of career, I've just encountered one which was done long back, but nobody's using it anymore. And as you can see in this picture, the graft to the RCA is mostly on the lower side, like that's the first graft you may encounter when you are doing a coronary angiogram, followed by to the LAD, diagonal, and OM. And that's how sometimes when you're not aware about the anatomy, you may have to gradually look for it and use different catheters. So why graft interventions? SVG still remain the most frequently used conduit during bypass heart surgery, and still the use of arterial grafts have been very less, around 10% or so. And these venous grafts, they tend to fail even despite all the surgical advancement and the pharmacotherapy. That's why you may gonna encounter SVG failure in your practice. So when we look at the natural history of SVG conduits, the patency rate remains at 1 month 90%, and it's quite surprising, even 3 to 12% of those grafts, they occlude before even the patient leave the hospital. Sometimes they don't have any symptoms, so they just go unrecognized. And by 1 year, almost 20% grafts have gone. And by 10 years, only 50% of the grafts are still functioning. Lately, with the no-touch technique, where you excise some part of the tissue around the SVG to maintain the vasovasorum, the patency of SVG has been improved to even 90% up to 10 years. But that's until quite high skill on the surgical part. And the attrition rate, initial 5 to 7 years is 1 to 2% per year, and afterwards there is a significant, almost double the rate of attrition subsequent years. And why do the grafts fail? It's a complex and multifactorial process. In the first month, mostly it is thrombus formation. There may be a mechanical factors when they were doing this anastomosis, and there may be a damage to the endothelium while performing the surgery. In the first year, the predominant mechanism is intimal hyperplasia, and after the first year is mainly the accelerated atherosclerosis. As you can see in this picture, initial 1 to 2 years, and gradually after 5 years, they tend to develop more significant lesion and even the total occlusion also. As per the ACC guidelines, it's recommended to choose PCI over repeat CABG in patients with patent lemma. Because if there is a patent lemma, there is no point to send for surgery, because during redo CABG, they can potentially shear off that lemma and the patient can possibly collapse. So it's entail very complex surgical approach. In patients with previous CABG and refractory angina on optimal GDMT, which is attributable to LED disease, it's recommended to choose CABG over PCI because internal memory arteries has been shown to done very well over a period of time when they anastomose to LED. And in patients with previous CABG and complex CAD, it may be reasonable we can choose CABG over PCI provided internal memory artery can be used as a conduit because they have a good long-term patency rate. So if there is no LED disease or the graft to the LED is patent, then I think it's a very complex decision making, and most of the time you will be inclining toward a PCI either of native vessel or a graft vessel because redo CABG entail more risk in that subset. And native vessel PCI is always preferred over SVG PCI, and we're going to talk about it because it poses technical challenges as well as the long-term outcomes are not good. So regarding the percutaneous vein graft interventions, 13% of the patients who undergo CABG, they require repeat revascularization within 10 years. And 6% of all those PCIs we perform, they happen on the SVGs. And these patients are more comorbid and they are mostly not the candidate for redo CABG. And underlying pathophysiology is mostly diffuse friable disease, the degenerated grafts, and there may be soft atheroma in them. So why graft interventions are so different? They are very challenging. Mostly these patients are old and frail. They have multiple comorbid conditions. They have higher risk of CIN and PAD. So even sometimes the access may be challenged. And engagement and visualization is also tough. Like I mentioned in the initial part, most of the time surgeons don't put any marker on the aorta. So you may have to just fish for the graft, and sometimes you don't even have access to the surgical report. So sometimes it becomes quite challenging even to look for those grafts. That's where sometimes CT can be very helpful. If you are unable to see them on the conventional diagnostic angiogram, you may have to use the CT. And bypass actually accelerates the atherosclerosis even of native vessel. And these lesions, mostly in graft vessels, are very complex. And when you perform procedure on these grafts, it's usually taking a long time and high radiation exposure also. Then the most important thing in these grafts, because they are degenerated and there are friable atheromas in them, there is a very high risk of distal embolization and no flow, and risk of peri-procedural MI. That's where it's significantly different from a native vessel PCI. And we think okay, in this graft vessels, even if you do PCI and if perforation happens, there is no pericardium, so there is no risk of tamponade. No, it's not like that. So yes, the pericardium has been stripped off, but still, if the perforation happens and it's not tackled, there may be a collection, it's known as dry tamponade. So the collection will happen somewhere in mediastinum or the thorax cavity, and that can be potentially dangerous, and sometimes you have to obtain a CT to really define it. So regarding the SVG PCI, like I mentioned, the native vessel PCI has shown good long-term outcomes, so it's always preferable as compared to SVG PCI if it is possible. And redo CABG entails higher risk, and there's no point planning a redo CABG, especially when there is a patent lemma. SVG CTOs should not be touched because even if you open them, except in the ACS setting, that's different. If somebody is coming with STEMI, yes, and if it is a culprit lesion, then it's recommended you can open it. But except that, the CTO intervention on SVG has shown very poor outcomes. So there is no point in recanalizing them. That's why the guidelines have given them class 3 recommendation. And as you can see in this picture, like native versus SVG PCI, the native PCI has better long-term outcomes as compared to the graft vessel PCI. The recently published Proctor trial has shown a little bit different than what what the previous observational studies have shown. So in this one, they randomized PCI of native artery versus saphenous vein graft, and they followed these patients for 1 year, and both lesions were found to be technically feasible, but these were performed by exceptionally qualified interventionists because almost 80% of these patients were having CTOs of the native vessel. And you will be surprised to see the success rate was around 90% despite the CTO. So these were highly skillful CTO operators who performed procedure in this trial. And to our surprise, the SVG PCI has shown better outcome at 1 year as compared to the native vessel. So that was really like a lot of debate happened about it. And issue is, but you have to see the context of this trial. Most of the lesions in SVG which were chosen, like they were focal disease, they didn't enroll very complex, calcified, degenerated, severely degenerated SVG graft, where really the risk of no reflow and the long-term outcomes are bad. So it's not like exactly a comparable group like focal SVG versus a native vessel. I think we still have to take the results of this trial and we have to step back. So we can't, I don't think it's reasonable to change practice at this moment because there were so many caveats. And this is an algorithmic approach, like if you see a SVG failure and if the patient is a candidate for redo CABG, and that's where I stressed upon earlier also, if there is a lima to LAD feasible, which was not done initially, yes, then it will entail a good long-term outcome. Though if there is already a patent lima, then it's better you treat the native vessel or a graft vessel. So when you plan the intervention of these graft vessels, so these patients, like I mentioned, they are quite elderly, they have multiple comorbid conditions. So try to gather as much as information before planning intervention on them, like try to access the surgical report, if you have a prior cardiac catheterization, or the CT, to delineate the anatomy before, so you can be well prepared before taking these patients to the cath lab. And a good diagnostic angiogram is of paramount importance to see like where is the disease, and you have to define it and then plan accordingly. So sometime if you don't have access to the surgical report and patient is coming to you first time, you may have to look for the scar on the lower extremities. Sometimes the patient is quite well informed, so he may inform you that he had 3 or 4 grafts, so you can look for that. And then on, sometime it happens like patient said like he had some cardiac heart surgery and we took the patient and there were no sternal wires. So sometime it may be robotic CABG also when they put a lima and sometime to the diagonal. So those are the options you should keep in mind. And it happens sometimes despite the best effort, you are unable to opacify the grafts and or you may be unable to see all the grafts. So CT is very helpful, or else sometimes you have to do a pigtail aortogram to opacify if there is any additional graft is still remaining. And given the comorbid condition, these patients, you want to well hydrate before taking for a complex PCI of the graft. And as a practice, we always give some 2,000 of heparin when we do a bypass graft angiogram, because first of all, you are spending more time inside the body. Second thing, these are like degenerated grafts, so there is always a chance of thrombus formation. So in our institution, we always give 2,000 of heparin, and I think that's a great practice to avoid any risk of thrombus formation. And there is a chance of arrhythmia also if you keep injecting in a degenerated graft, and if you inject prior to like the contrast has cleared off, the chances of VFib also can be there. So always be careful when you take pictures of these grafts. Vascular access wise, the femoral access is definitely preferred, especially when there are internal memory grafts, because with radial it becomes challenging. Like if there is a graft on rima and lima, whichever access you take, left or right, yes, it's doable, but with a lot of technical challenge. And in that pursuit, you may create a higher chances of stroke for these patients. So femoral is definitely preferred when you have multiple IMA grafts. Left radial is doable when especially there is only lima graft. Yes, that will help you to engage the lima quite easily. And certain specialty catheters like Bartoli-Causet catheter can help you for a lima engagement via right radial also. But I would say for simplification, femoral is better, or left radial if there is only a lima graft. For PCI planning, there are like plethora of guides can be used. But usually for the right side grafts, JR or IM guide is preferred, what we use at our institution. But there are plenty of guides. Sometimes the SVG is quite origin is quite downward looking, then you can use a multi-purpose guide also. And on the left side grafts, for lima, usually internal memory guide is works really well, or sometimes the NOTOR guide, and which works for rima also. And for the SVG to OM diagonal or the free grafts from the aorta, IM guide or AL75 guide really works well. But yeah, depending on the availability at your institution, you can use different sorts of guide. But these are the preferred guides which usually engage it very nicely. So what are the technical strategies to avoid any major complication in this graft vessel PCI? One thing is, like, if the graft vessel is not calcified, there is a focal lesion, and you can do a direct stenting, that's a preferred approach. So because that, if you do a pre-dilatation, distal embolization definitely happens because these are degenerated ones. And if the stent is well opposed and well expanded, it's not recommended to do a post-dilatation also in this case. So it's better you deploy your stent and higher pressure, so it is well opposed and well expanded, because pre and post dilatation increase the risk of distal embolization. Then sizing wise, yes, consider using longer stents so that you can trap the atheroma behind the stent struts, and don't be very aggressive with the sizing, though these are venous grafts, but still they can rupture or perforate, is still possible. And do a gentle inflation, and like I mentioned, avoid post-dilatation. So with these strategies, most of the time, you will be able to avoid distal embolization or no reflow situation. So certain technical tips will come handy when you do intervention of these graft vessel PCI. You can avoid balloon predilatation, like I mentioned, and primary stenting is definitely a preferred option when it is feasible. But you may encounter the grafts which are like calcified or which are like non-dilatable. You seem like lesion is quite tough. Then it's okay to predilate. You can use a cutting balloon or some specialty balloon. And embolic protection device is it's better you use it when it is technically feasible. If there is a osteal disease, then first of all you have to dilate the ostium. Then there is no point placing a filter distally. So yeah, when there is a good margin, like kind of 5 to 10 millimeter proximal to your distal anastomotic site, the filter can be used, and it's recommended by the guidelines to use it to avoid the no reflow situation. And always be ready with your vasodilators, because definitely there may be some slow flow may happen during these interventions. So if you have your medications ready, you can avoid that one. And perform slow and prolonged stent and inflation at nominal pressure. That will avoid any major injury to the graft vessel. Then, like I mentioned, use the sizing based on your distal reference, and a longer stent length will be definitely better. And especially in these patients, you want to monitor your ACT. Certain times, like we don't monitor it, we think we are therapeutic. But if the intervention gets prolonged and you lose touch of that, these interventions are more prone for thrombus formation. So it's better you monitor your ACT maybe every 30 minutes and keep it on higher side, maybe 300 or above. And use your DAPT, and if possible, and if they are not very calcified, then it's better to avoid atherectomy to keep these lesions simple. Imaging is helpful, and yeah, that you can use to optimize your stent if required. Stent choice, like there have been a lot of studies and there are always conflicting results that whether to use a BMS versus drug-eluting stents, but both have been shown to be equally effective. ISR CABG showed that DS was better in all terms of all the primary endpoints, but the recently conducted DIVA trial showed other way around, that both BMS and DS has equally good outcomes in these vessels. So both choices are good. Now, because the standard of care is drug-eluting stent, I would say you just use a drug-eluting stent. There is no point going back to a bare metal stent in these patients. And like I mentioned, to briefly touch upon the embolic protection devices, they should be used when technically feasible as per the guidelines. And only 2 EPDs are currently commercially available. One is filter wire and another is Spider FX, and you size it according to the vessel dia where you want to place it. And currently across the US, only 21% of graft vessels interventions are utilizing this EPDs. So there is still quite a huge gap where you can still utilize them. But sometimes if it is direct stenting, then it's not a recommended approach. You put so much hassle to deliver it, and then you have to take it out in the end. So sometimes if it is easy lesion, direct stenting is possible. We tend to avoid EPDs. We just deploy the stent and come out. If there is a heavy thrombus burden, and sometimes especially in STEMI patients or ACS patients, you may have to use mechanical thrombectomy with your angiojet or penumbra catheter. That really helps. And laser is another option which you can use in these cases. Now, regarding the potential complications, yes, the patient can develop arrhythmias. There may be a risk of dissection or rupture. So it's not like the veins are distensible, they can still rupture. So you have to avoid excessive oversizing in these veins. Then the incidence of distal embolization is 10 to 20%, and no reflow in almost around up to 30%. And sometimes there is an inadequate dilatation for fibrosis, and what we have observed that these graft vessel stents, they restenoze 20 to 50%. So if possible, intervene on your native vessel if it is technically feasible. Regarding the no reflow, there are certain risk factors like increased plaque volume, the more degenerated SVG grafts, thrombus formation, and likely the etiology is there is a distal arterial spasm, there is a platelet aggregation, and there is a atheroemboli which is plugging this distal microvasculature. So to prevent this no reflow in this intervention, you have to use a liberal use of vasodilators, and based on institutional practice, there are all vasodilators have done really good job, like adenosine, nicardipine, nitroprusside, verapamil. Nitroglycerin has not been shown to be very effective, so that's not the preferred one. Then direct stenting will definitely avoid no reflow where it is possible, avoid pre and post dilatation, and don't be very aggressive with the sizing. And use of embolic protection device definitely reduces your chance of no reflow in this intervention. And especially when it is a complex lesion and you may have to use atherectomy or multiple balloon inflation, EPD is recommended, so that can save you from this potential complication. Now, coming back to arterial graft intervention, that's not very usual because most of the time you see SVG getting degenerated, and internal memory grafts, they do really good along with the radial. But still, you'll encounter certain of these patients where they may benefit from the intervention. So usually, the graft integrity continues for a long time, and they rarely undergo atherosclerosis. And if you have recognize a disease in the internal mammary artery, it's better you use the dedicated Lima guide, and the shorter guides is preferred, because if you have to deliver your device all the way to the native LAD, you need all the length, and the length of currently available coronary balloons is limited. So it's better you use a 80 or 90 centimeter guide. Then one peculiar thing about these grafts, like they are prone to spasm. So they contain active muscular media, so you have to use your calcium channel blocker or nitroglycerin to avoid that spasm. And similar to like vein intervention, you should avoid oversizing here also, because if you dissect, it will be catastrophic dissection. So like I mentioned, they have higher patency rate, there is a very low complication rate, and use dedicated IM guide. Left radial is a really good approach if you only have to intervene on Lima, and always make sure there's no disease in the subclavian. And then hydrophilic wires has been shown to be more effective to navigate that tortuosity or longer lesion length in these cases. And guide extension have been really supportive in our complex PCI, and similar, it adds to the same for the SVG and Lima also. But you have to be very careful. If you intervene on Lima and you're using a guide extension, you better use your balloon support, because it can potentially dissect the ostium of Lima or Rima. And if that happens, the patient will have a major MI on the cath, and that will be catastrophic. So avoid deep intubation, only use it when it is really required. And you will frequently encounter accordion effect when you are intervening on Lima intervention, which are known as pseudo lesion. I'm going to show you a picture. Once you wire, the vessel tends to develop like there are multiple stenosis, but it's just because the wire has straightened up those tortuosities. So always use vasodilators. And so this is the accordion effect, which you can see in the picture. Like once you place the wire, it just looks like there are so many multiple lesions have shown up, and after the guide wire removal, the vessel is back to normal. So don't tempt to stent any lesion you see after wiring, so always compare it with your baseline angiogram. This is just the same picture of like how it happens. Now I'll show you some case examples. So this is one of the vein graft. Here you see there is a previous stent in the proximal part of it, and you can appreciate a distal very focal lesion. So this lesion was like instant restenosis. So this we had to like do a cutting balloon, and we placed another stent. But if this focal lesion is native, direct stenting is definitely a good approach in this case. And this is after the stent placement, and it came out fine. And this is IM guide we are using in this SVG. And like you see in this another case, there are two focal stenosis and not much calcium. So yes, you can directly stent both of the lesion. In this case, operator uses spider filter because there were two lesions, and there was a plan to do some, I think, predilatation. So you can see the filter is sitting distal, but it has to be placed prior to the native vessel. You have to have few millimeter of gap, because if you are deploying into the native vessel, it's not going to help. Already there are branches, so distal embolization will still happen. And this is like I mentioned, they did a predilatation, and then they did the stent, which came out fine. And this is an example of an Lima anastomotic site where you can appreciate there is a focal disease, and here we did a cutting balloon followed by a stent, and post PCI looks great. This is REMA intervention. So REMA intervention you may not encounter that frequently. It's quite rare. Most of the surgeons, sometimes they don't even use it, and with good graft patency, usually they do really well. So if you have trouble engaging a REMA, then sometimes you may have to consider coming from the right radial artery. If your femoral is not helping, you tried your JR, you tried your Notor catheter, then you may have to go to the right radial. But sometimes with right radial also, if you you will appreciate the origin of this REMA is so tough. Even if you come from right radial, it's not helpful. So sometimes you may have to use different wires, and even one time when it was very tough, we had to use the pre-shaped curved microcatheter also. So here you can appreciate there is a lesion further down, and which was treated, and it came out fine. This is another REMA intervention. Here you see the J are not engaging, even with the knot or guide. It's not even like coaxial to that REMA. So in this case, what we tried, we stabilized our guide with a 5 wire all the way in the subclavian. Because every time when we were going up, the guide was falling down. So we stabilized our guide, keeping a wire into the subclavian. Now we gradually bring our guide back, keeping a coronary wire, and then you will appreciate soon, then we were able to wire once the guide was near the ostium of that REMA. So sometimes these tips and tricks can help you to engage, because sometimes it becomes very challenging. Despite you use a femoral or a radial approach, it's still challenging. So just to summarize, always favor a native vessel PCI, especially when your graft is degenerated and the native vessel PCI is feasible. And graft vessel intervention poses very high risk of distal embolization and no reflow. So always maintain a high ACT and keep your vasodilators handy, because in that time you need to use them. Consider use of embolic protection devices when technically feasible, especially in friable and degenerated SVG lesions. Tend to avoid post-dilatation, but if it is really required, sometimes you have to do it. And BMS and DS are equally effective, shown in various studies. But now the DS is the standard. Just use a drug-eluting stent in your graft intervention. And thank you for kind attention.
Any questions for?
One question on SVG interventions. Do you prophylactically use vasodilator?
Yeah, that's a very good approach. Like if you see, like when you engage your guide and there is already a like little sluggish flow, it's better. There's no downside. If the patient blood pressure allows, you better give it beforehand. There's no downside to it. It will definitely help you. Yeah, sure.
Embolic protection devices, what's the technical consideration? Just over the coronary wire, or?
Yeah, so we use over the coronary wire. Only thing, like I mentioned, there are certain scenarios. First of all, you use it in very degenerated SVG grafts, like where you entail like the procedure is going to take time and you have to do multiple pre or post dilatation, and so you better use it. And the second thing is certain anatomies are not conducive to it. Like if there is a osteal disease, then you have to still pre-dilate, then only your filter gonna deliver. So in that case, if it is just osteal disease, it's more simplified. You just take care of the osteal lesion instead of taking the hassle to take the filter all the way down. And sometimes the lesion is so distal, like if it is at the anastomotic site, then your filter is not going to be useful, because there is no landing zone for the filter. You cannot place it in the native vessel because already there are so many branches and distal embolization will happen. So you size your filter according to your distal reference of the SVG, and you deliver it on your coronary wire, do your intervention, and then even like when you're retrieving, and we have seen in our experience, always be very careful, do under fluoro guidance, because if you're not very careful, sometime when you are taking it out, retrieving it, it gets entangled with the distal edge of the stent and it can potentially crush the stent. That happens when it is biased and the stent is, these SVGs are quite roomy. Even if you do the best sizing, the stent is still, though well opposed, but it can still get deformed if you are applying too much pressure. So do under fluoro. Yeah, all to you, Dr. Sharma. I think you're next up. Thank you, everyone.
All right, very good. All right, ready for the final stretch?
and lot of question answers. Not lot of, all are what I'm going to have, all are the question answers in this. If somebody wants to go out, get a little coffee, whatever it is, but we soon will be starting. Actually, interventional cardiology used to be a very, I would say, bad branch at one point in the passing rate. You see that? 81%. It started in 1998. We took the first exam, 1998, and now actually has gotten better, is about 90% like any other branches. Second time taker is a little less, but first time taker is the 90+%, which is like most of the subspecialties. Now this is what you need to remember about the class indication. So class 1, class 2A, 2B, and C. And C actually now two of them, as one that there is harm and other one is not useful. So no benefit or harm. So these are the cases, usual what we do, and it will fit into one of the category. So this is what you need to remember. Particularly, let's say there was a one trial done and the recommended because of came out from treatment A is recommended, indicated preference to treatment B. And it should be because there was a benefit outweighed the risk. And then based on the level of evidence, A, B are randomized, A, high quality evidence, and of course the non-randomized data. So this becomes the second part of the recommendation, and this is what you need to be very, they will ask you questions sometimes that this is the trial, and do you put this as a class 1A or is a class B, and C is non-randomized limited data. So this is, and basically they are asking you the questions which will fall into the category of class 1 or 2A, not the 2B. 2B is always questionable, so not the 2A. 2B is a 2A. And level of evidence could be from A or B. And then also, examination will assess the candidate knowledge and clinical judgment in aspects of interventional cardiology, perform a high level of competence. And the key is, where do you get the data, particularly textbook and guidelines in last 6 to 12 months before. Not very old, not very recent. Think about more than 1 year ago, which was done. Okay, with that background, let's go quickly. What is the abnormal finding on this IVUS imaging? Dissection, malopposition, thrombosis, or neointimal hyperplasia, A, B, C, D. Huh? Okay, so this is the dissection you can see on the IVUS. Good. So that is how you see the dissection, malopposition, this is the stent. Then this is the neointimal hyperplasia, that's the stent. They'll show one or two other type, and thrombus. Thrombus basically seen better with the OCT, but you see with the IVUS also. Now, this is the OCT. Abnormal finding of this fatty plaque, calcification, dissection, or thrombosis. Calcification, very good. All this is delineated border is the calcium, which you can see here. So this is how you see the fatty plaque. The confluent borders, well delineated is calcification. This is your thrombus, and then you see the dissection. All right, so these are the clear. So now you make it IVUS or OCT, fibrous plaque, lipid plaque, and calcified plaque. And in the OCT, you can see here the fibrous plaque, there's a lot of fibrosis, and then lipid plaque, basically thin cap, thin cap atheroma. The cap thickness, cap thickness is less than 60 micron, and that is the thin cap atheroma. And then, of course, this is your calcium, calcified plaque in multiple areas. And there you can measure the thickness, arc, and the length. So all those things which makes to the OCT, remember the calcific lesion. So, okay, randomized trial of bifurcation lesion, PCI has shown 2-stent strategy superior to provisional 1-stent strategy, except which trial 2-stent was not shown, means 2-stent was good in most of the trial except one. DK crush 2, 3, Nordic bifurcation 4, or EBC1. EBC1, because EBC1 basically was stepwise provisional against systemic dual. Others were, all of them have a two-stent approach. So this was the DK crush 2, which was in the native, in the non-left main, you saw conventional versus DK crush. That was the provisional stenting versus DK crush in the D2 trial. DK crush 3 was in the left main, DK crush or culotte. And of course, DK crush was better. And then the Nordic bifurcation 4, it was the trial of provisional stenting versus 2-stent approach. And so all those trials actually, once done properly, 2-stent approach after the DK crush has become usual. EBC main was a stepwise progression, and there is actually event rate was lower, slightly trended towards lower, but it did not have statistical significance. It got the statistical significance only after 3 years. So 3 years of EBC main showed lower TLR in the stepwise provisional, but originally was no difference. Following are the appropriate suggested techniques of rota. Packing motion, ablation 180,000, continuous forward motion of the burr, ablation time 15 to 20 seconds. Not continuous forward motion. Which atherectomy we use a continuous forward motion? Orbital atherectomy. You go, come back, and it does the ablation both ways, going forward as well as coming back. So these are the techniques which we have shown. Now, after the main vessel stenting of the side branch was needed to have optimal angiographic results. In this scenario, which of the following technique is not recommended? So you have done the stent of the main vessel, now you have to stent the side branch. So what is not recommended? DK crush, reverse crush, tap, technique, and culotte. Yeah, DK crush. DK crush is supposed to be 2 stents already. So therefore, this is the culotte, this is your T-stenting, this is a DK or mini crush. And once you have, there could be tap, that your intentional protrusion into the main vessel, reverse crush, that now you are going to, we have done the stent here, now dissection, you bring it back, and at this level crush, or you do the culotte. And all have the plus and minus benefit. And all these will be available to you on your, with the downloadable cases. Proximal LED underwent successful PCI using DES and had a 9-month follow-up angiography following QC parameter. MLA pre 0.8, MSA post 2.5, MSA post at 9 months is 2.3. So what is the acute gain for the LED lesion? The acute gain is MSA post minus MSA MLA pre, right? So this will become 1.7. Then what will be the late loss? 0.2 post minus there, and the acute, and then net gain will be a 2.3 minus 0.8. So therefore, you see, this is the acute gain, late loss, so that you can define here, acute gain is your pre to post, late loss post to follow up, and from net gain is your pre to the follow up. So, okay, syntax 2 score, in addition to syntax score, incorporates the following characteristics except female gender, CVA, COPD, and LVEF. Yeah, so clearly the syntax has the age, creatinine clearance, LVEF, left main, sex, COPD, and PVD. CVA is not incorporated in the syntax score. And this is what they have come up, that you, based on the syntax 2 data, now you predict what should be the event rate. And has been shown syntax 2 now, because there are a lot of imaging, appropriate PCI, the results of syntax 2, although syntax 1, cabbage has a better outcome compared to PCI, but syntax 2 outcomes were similar. But that is a just equivalent, no randomization there. In SVG intervention, following have been suggested useful adjunct. We said clearly 2B3A is very clear-cut, no distal protection, both DS, BMS, vasodilator. So 2B3A is not the choice, and this actually has been made, is not recommended. 3B for chronic vein graft lesion, and 2B3A is not beneficial. And then they came up with the additional guidelines, chronic occlusion, don't go after, and this will happen that many times they'll show you either very degenerated graft pictures or occluded graft. And then question is, even there's a patent lima, and very long total crazy occlusion of your native RC and circumflex, the treatment there would be second bypass. So usually you don't, not a question, degenerate graft don't go after. So but rather than treatment will be second, the patient should go for redo bypass surgery. And now embolic protection is 2A, and patient PCI, the disease native artery is feasible, but you know this data has changed now, will change because the vein graft data is better than the native artery, and patient with a chronic total occlusion, you should not do the PCI of the CTO graft. Okay. Let's go to the RotaWire, Viper wire, Confianza, Pro wire, Miracle, and Gaia. So RotaWire has what guide wire tip for the RotaWire? Right? 0.009 guide wire tip. Viper wire has, what is the Viper wire? Is the body 0.012, sorry, not Rota guide tip, no, body. Rota body is 0.009, tip is always 0.014, that is spring tip. Of those, both of them Viper. And Viper is 0.012, right? So now you have the other one, Gaia Next, Miracle Bro, and Confianza. Okay, Confianza will fit into which one? It's 0.009 guide wire tip. Miracle Bro is your, will be of your guide wire body of, guide wire tip, and the Gaia Next will be the guide wire tip. So let's go to the answers here. A, RotaWire, guide wire body. Viper wire is a guide wire body. Confianza is guide wire tip. E, Miracle Brother is 0.01 guide wire tip. And Gaia Next is C, which is 0.012 guide wire tip. Miracle Brother. We use, and these are the, we have all the guide wires with their characteristics have shown here. Then, what is the statement regarding PCI via radial approach versus femoral? Radial or femoral approach is class 1 in patients with acute coronary syndrome to reduce death and vascular complication. Benefit of radial over femoral approach, PCI is more at high radial centers and operators. Then radial versus femoral approach is class 1 in ischemic heart disease, stable ischemic heart disease patient to reduce vascular complication bleeding. And radial versus femoral approach is class 1 in stable ischemic heart disease patients to reduce death. So question is, which is false? Right? Or D is not true, it's a false. So clearly that class 1 is in acute coronary syndrome, you reduce both mortality and vascular complication. But in your stable disease, you only decrease the vascular complication, not the mortality. Okay. Meta-analysis of the DS versus CABG in left main CAD has shown the following except similar 5-year, 10-year mortality, higher MI in PCI versus CABG group, higher revascularization in PCI versus CABG group, and significantly higher CVA in CABG versus PCI group. This is the meta-analysis paper which came in Lancet from Brownwald, is answering that question because there is CVA is significantly higher or not. You can see that MI is higher, death is non-significant. 5 years is basically it's a 0.2 per year, so 1% higher at 10 years, 5 years, at 10 years, so 2% higher, and they were not significant. What was significant basically was revascularization is higher in the PCI and MI. And stroke, although was better in the PCI group, but did not make statistical significance. Now, a step to advance rotabar to distal RCA with severe calcification and extensive tortuosity have failed. What is the next step? Use 7 for a guideliner distally and then rota 1.25 or 1.5. Use 7 French guideliner distally and IVL catheter. Use your body wire technique and high pressure balloon dilatation with or without guideliner. Use your excimer laser with guideliner and all of the above. All of the above. Those are what you are going to do in this particular case. Now, stent strut thickness with a corresponding stent. As you know, what is the thinnest strut? Is Orsiro, so 60 micron. And other one basically will go with your, shown all the stent designs you need to remember. Zions is 81 and Synergy is your 74. But once you get a Megatron, bigger Synergy, large vessel and so becomes 89 and 79. Okay. ACCHA revascularization guideline of 2022, following lesion scenario is no longer the class 1 indication for CABG. Multivessel CAD EF less than 35, EF less than more than 50, left main CAD with high complexity, LM CAD with high complexity and suitable for CABG. Remember that was a big controversy that now multivessel CAD with EF more than 50% is no longer class 1 because they added PCI can be done in these patients as a 2A and 2B, and therefore this was a big noise when these guidelines came. So this group used to be in the old guidelines as a class 1 indication for CABG, but no longer. This is what you need to remember. And this is basically showing that multivessel or left main disease that is based on the ejection fraction, whether normal ejection fraction or abnormal ejection fraction, it becomes, CABG became, the low EF, CABG is class 1, EF 35 to 50% is 2A. And recommended for patient previous CABG. You have CABG before, we talked about that. Patient with the previous CABG with a patent lima to LAD who need repeat revascularization. If PCI is feasible, it is reasonable to choose PCI is 2A. Now, in patient previous CABG and refractory angina on guideline medical therapy that is attributable to LAD disease, it is reasonable to choose CABG over PCI when lima can be used as a conduit. And then last guideline was in patient with previous CABG and complex CAD, it may be reasonable to choose CABG over PCI when IMA can be used as a conduit. So basically they are saying that if you're complex CAD and your internal memory is not used before, it's better to go for the redo CABG. Okay, now cases there were device failure in the calcific lesion in the non-rota group, in the Rotexas and prepare calcium. Means what was the crossover? Less than 10, 10 to 20, 20, 25 or 25. Both trials actually had 16%. You see, here, 16% that you have to, 1 in 7, you can say that rota, or the non-rota group has to cross over. So about 16%. Okay. OCT-derived calcium scoring system includes the following except calcium arc, calcium thickness, calcium length, and calcium nodule. Nodule is not part of it, and this is basically puts the calcium score of 0 to 4. Okay. OC-derived feature of the vulnerable plaque, except fibrous cap thickness, a large lipid pool, activated macrophage pool near, or fibrous cap thickness of 85. So basically 85 is not the, and you can see the macrophages and 85. Good. And this is basically our histology, histology, IVUS, optical coherence. These are the findings of your thin cap fibroatheroma. Okay. Now, which of the following trials is the appropriate randomization technique? FFR versus IFR trial, PCI versus OMT in ischemic cardiomyopathy, FFR guided versus IVUS guided PCI, bivalvular versus heparin during PCI, FFR guided versus angio guided. So, revived BCI is what? B. PCI versus OMT in ischemic cardiomyopathy, and there was no benefit. Then the flavor trial. The flavor trial basically was IFR. No, flavor is not FFR versus FFR guided versus angio guided PCI. Bright 4, your bivalvular versus heparin. Defined flare, FFR versus IFR. Flower MI is the one. The flower MI is the one. FFR guided versus angio guided PCI. FFR versus IFR trial was your defined flare. And FFR guided versus IVUS guided PCI. Remember this. This is your flavor trial. Okay? Remember these trials, and they basically showed no difference in most of them, although IFR trial, after 5 years, outcome were inferior in the defined flare with the IFR compared to FFR. This is the BCIS, revived BCIS trial, basically no benefit. The flavor trial, comparing FFR guided versus IVUS guided, again no difference. Bright 4, bivalvular, high dose, infusion versus heparin. And then lastly, the defined flare, IFR versus FFR, that there was no difference at 1 year, and so. Flower MI, patient was FFR guided PCI versus angio guided PCI. Again, there was no difference overall and follow-up. Good. Now, coronary angiography performed in a 48-year-old woman after abnormal stress test showed multivessel coronary artery disease. Which of the following is not an important factor in selecting PCI versus CABG? Diabetes, syntax score, suitability of the target vessel, and age of the patient. Age of the patient, right? I mean, patient or the functional, we decide, of course, until they're very old, patient can go for CABG easily. And we know that patient with a diabetic status, it is the bad outcome was PCI with diabetes, and And of course, if you're non-diabetic, outcome was identical. But this is the cabbage diabetes, this is the PCI diabetes outcome in all the trials of the PCI and cabbage. Then we have syntax trial, which at 5 years, once your high syntax score, you see the advantage of the cabbage in mortality. CVA was no longer different, MI and revascularization. So at 5 years, clearly in 5-year trial of the syntax, the PCI was inferior, higher mortality. Second, once you go to the lower group, the difference becomes less significant, which we'll see. And in the syntax score less than 22, which is the low score, intermediate is 23 to 32. Now, which of the following is not a finding from the long-term follow-up from the syntax trial? TVR continues to worsen in the PCI arm beyond 1 to 2 years. CVA was statistically higher in the cabbage patient versus PCI in all syntax groups. Cardiac mortality was lower in cabbage patients with syntax score more than 22, and MI is increased in PCI patients with syntax score more than 32. So they're saying which one is not the finding. So basically will be cardiac mortality was lower in cabbage patients with the syntax score 22. It was only in 33, not with a 22. That's what they want to know. Repeat revascularization continue to increase. This is the low score, 0 to 22. You see the death, and the MI is still kind of a little higher, but not important. In the intermediate score, no difference in mortality, but yes, a higher MI and higher TLR. And the high score we already showed before. Then, patient had CT of the RCA with collaterals. Left coronary tree shows that 60% stenosis in the mid-LAD. That was not obstructive by FFR. So LADFR good. Which of the following is not an important consideration in selecting PCI in this patient? Experience of the operator, persistent symptoms, significant dysfunction of the inferior and lateral wall, and large ischemic demonstration of the stress testing. C, right? Significant dysfunction. That means infarcted. So that it doesn't matter. So that you don't do. So basically have been shown PCI of the CTO in patient, it used to be 2B, with appropriate clinical indication and suitable anatomy, is reasonable when performed by the operators with appropriate experience and to improve symptoms. The point is, the overall, because so many trials have been negative, so they are showing that medical therapy treatment of non-CTO lesion, the benefit of PCI of a CTO to improve symptoms remains uncertain. Has to be really patient with ischemia. Okay, freedom trial. Compare PCI with cabbage with multi-vessel disease, and about 18% were two-vessel disease, including LAD. And what did it show? Comparable mortality in the two group. It means including the following except. Once the except word comes, you need to see what is wrong. Simple. Okay, comparable mortality in the two groups. Higher myocardial infarction in the PCI group, higher repeat revascularization in the PCI group, higher stroke rate in the cabbage group, and higher primary endpoint of MACE in PCI group. Comparable mortality in the two groups? No, because higher mortality in the PCI group, which you remember, 5% again mortality in the PCI cabbage, higher MI, and then we have lower CVA compared to cabbage as shown here. And that led to the guidelines that in 2021, although they have changed now, may not come to you yet, the patient with the diabetes and multivessel disease with the involvement of the LAD who are appropriate candidate for cabbage with Lima is recommended preference to PCI to reduce mortality and repeat revascularization. So you have to remember these terminology, and they'll show you the case scenario of the freedom trial. And that will actually, what you need to pay attention to it, and answer there is, patient with a multivessel disease, cabbage is indicated to decrease mortality, MI, and repeat revascularization. Now, then 2A is patient with diabetes who have multivessel CAD, amenable to PCI and indication for revascularization, poor candidate for surgery. PCI can be used. So basically patients who are high comorbid condition, so not surgical candidate. Then lastly, this is 2A. The patient with diabetes who have left main stenosis and lower intermediate complexity CAD in the rest of the coronary anatomy, PCI may be considered as an alternate to cabbage to reduce major adverse cardiac outcome. So key is that patient with a low syntax score can be suitable candidate. The case kind of we showed yesterday, the patient low syntax score could be appropriate for the PCI compared to cabbage. Okay, now Multivessel PCI is planned on 68-year-old woman with diabetes, renal insufficiency, diffuse disease vessel. Procedure safety may be enhanced by the following: thienopyridine, statin, N-acetylcysteine, and 2B3 and IV cangrelor. Clearly, N-acetylcysteine, no good. ACT trial is finally put the lid on this trial. This use of N-acetylcysteine did not show any benefit. So therefore, administration of N-acetylcysteine is not useful. This will not be harmful. So this will be 3A, but not useful group, not the harmful. And best practice of they say that you do risk of the contrast, adequate pre-procedure hydration, record the volume of contrast and minimize the use of high intensity statin, use radial artery, if feasible. Do not administer N-acetylcysteine, do not give prophylactic renal replacement therapy, and then delay CABG in stable patients after angiography beyond 24 hours when clinically stable. Because you have given the diload and next day you get a go for CABG will be a trouble. 24, question, patient plan for 67-year-old man with end-stage renal disease, left main triple vessel, syntax score is 30, systolic pressure is markedly decreased. Compared with support using IABP, the use of Impala device would be associated with. So this was the PROTECT trial. Multivessel disease, ejection fraction 30, whether PROTECT versus means balloon pump versus Impala. Lower mortality, lower MI, lower repeat revascularization, higher stroke rate, and lower angiographic failure. Lower repeat revascularization. So that basically was shown. Balloon pump and so comparison, syntax score was 30, and repeat revascularization, because with Impala, we did as much as possible multivessel disease, and therefore this is recommended as a class 2B. There's still nothing to 2A, class 2B, because there was a, by having Impala, you are able to do more complete jobs, so less repeat. Okay. For every 100 patient with primary angioplasty, thrombolytic therapy, rather than primary angioplasty when performed without significant delay, approximately how many lives be? Good. So basically 2 to 3, because these were the trials, multiple trial paper, 6.5 versus 4.4, so it's a 2.1 difference. And then question is, number needed to save one life. What you do? 100 divided by 2.1, which will be your 48. Then, that you already did. Now, number needed to treat, then they come to the second one, what is the risk relative ratio, which is the absolute difference divided by occurrence in non-treatment arm. So basically difference was 2.1, right? And divided by non-treatment arm was your 6.5. So that will be 32%. So these all definitions have been put. Now, patient PCI and bivalvulotin with creatinine clearance less than 30. What is the recommendation? Guaranteed. This question comes every year. Bolus should be reduced, infusion should be reduced, infusion should be reduced to 0.25, infusion should be remain 1.75. So bolus, no. Okay? Now question is, what do you decrease the infusion to? So infusion is reduced to 1 milligram per kilogram. Okay? Usual is 1.75. When gets 0.25? Patient with hemodialysis. On hemodialysis become 0.25. Okay. 30, patient, randomized study of the indicated 13.5% event rate with treatment A versus 16% event rate with placebo. Then another study in a similar patient population indicated 14.5% event rate with treatment B compared to 16%. It still remained 1.5. Then say which of the following is true? Absolute risk reduction is 2.5 with A and 1.5 with B, right? Clear? Means A is superior to B? No, right? That's, yes, but not true. Treatment B is superior to placebo while A is not. This means B is superior to A. Number of patients needed to treat B in order to prevent one event that would have occurred with placebo is 67, right? That's the correct. The number of patients needed to treat in B is 11, and so answer is C. Then 64-year-old male, aspirin, statin, nitrates, beta blocker, stable angina, successful controlled diabetes, so diabetes without medication. Patient has coronary angiography, showed 80% LED lesion, 40% circ, 40% RCA, EF is good. Which of the following option is correct? So is this patient is a freedom patient? Answer is no. Freedom was multi-vessel disease or two-vessel including LED. Second, freedom was not the disease, no, the patient had to be on the medication, not the diet alone. So diet control diabetes was not included in the freedom. Patients have to be on the treatment, diabetic treatment, and then they have insulin requiring versus non-insulin requiring. So question here, surgical therapy offers a survival advantage. Both PCI and surgery offer a survival advantage. Hypertension control is not necessary. According to Barry and Freedom trial, surgery should offer a survival advantage over PCI or none of the above. What is the right answer? None of the above. None of the statements are correct. Right? None of the above. So this goes to improve survival, and I have put this together, multi-vessel and so. Okay. This is, you have to match preconditioning, true ischemia, stunning, and hibernation. They will always ask this question. Decrease in blood flow, decrease myocardial energy. Decrease in blood flow, normal blood flow and normal decrease in blood flow followed by normal or high the coronary blood flow, and the metabolism is normal, lasting hours or days. Severely decrease coronary blood flow, increasingly decrease your the metabolism, and then multiple short attacks, decreasing coronary blood flow followed by complete reperfusion. So preconditioning is what? Multiple short attacks, right? True ischemia. Decrease, yes. Stunning. And the hibernation, basically 1. 1, 2, 3, 4. Very good. This one, I think you can go based on what we have said already, defining what would be your so acute gain, late loss, I already have said. Now, the patient, 59-year-old, and then other thing is also that do not worry, with the complex PCI case they show, and you need to use a two-stent technique, that's okay, because many trials have shown two-stent technique, particularly the crush technique. Second, you have difficulty in PCI, that don't abort the case. You go to the new device, whether you need to guideline or additional wire or so and so forth. So this patient presented with a 59-year-old, diabetic, anomalous right coronary, extremely difficult, required multiple catheter. Test injection to locate, but RCA was free of significant disease. It's anomalous, lot of dye was given. Multiple catheters, test injections were required to measure left coronary artery, which had minimal disease and a severe stenosis at a calcified LED diagonal bifurcation. So patient does have one vessel LED diagonal bifurcation, which LED diagonals are large diameter of myocardium, LV gram was normal. The plan for this patient would what? Proceed with the crush, proceed with the intervention, proceed with the intervention of the LED and the diagonal, postpone the intervention, treat the patient medically. D, because you have so difficulty, it's not a 99% lesion, do it later. Let the patient recover, otherwise you'll develop the acute kidney injury. Okay, patient present with stable angina is referred for cath. History of DES about 5 years ago. Angiography showed 50% narrowing. OCT performed and shows a lesion. Which of the following true? But let's say what the lesion is showing. What is the lesion finding in this one? Huh? Neoatherosclerosis. Remember, there is a atheroma, there is a calcium. And this, the stents are outside. This is the stent, struts. So this is the patient. Now they say is likely an extension of the underlying atherosclerosis plaque. Then it's formed by virtue of stent thrombosis. The most commonly occurs in the first year after stent implantation, more commonly occurs after DES versus BMS, and most commonly cause of the stent fracture. This occurs, neoatherosclerosis occurs late, about 4 or 5 years, which is the case, and it occurs more in the DES versus BMS. These are the various neoatherosclerosis, stent under expansion, and neointimal hyperplasia. Examples have shown here. Then 36, patient exercise echo. Patient had developed mild chest pain and Bruce protocol, both the exercise ECG and stress echo, no evidence of ischemia. But exercise test is interpreted as equivocal and then demonstrate 40% calcific left main disease. Using IVUS, the minimal lumen diameter is determined to be 7.2. Select the best management of this case. Cabbage, balloon, PCI, reassurance, and no and rotational atherectomy. Clearly reassurance because the patient had no clear, some chest pain symptoms, but negative stress test, and your IVUS showed anything more than 5.5, some makes it 6 millimeter square. That management is, this patient is no revascularization and so. And now we know the imaging has become class 1 indication, particularly for patients with left main, true bifurcation, and long lesions. In stable syndrome, same way. Complex lesion, intracoronary imaging of the true bifurcation and long lesion, both stable as well as an acute coronary syndrome. Now, one way or other, this question will come of the stent thrombosis that occurs between 36 to 48 hours after a procedure defined as hyperacute, acute, late, subacute, and very late. So hyperacute is while happening during procedure. And acute, 24 hours, right? Subacute, your 24 to 48 hours, and then up to 30 days is the late, and then very late is after 1 year. Therefore, timings became 30 days acute, subacute, 30 days to 1 year you're late, very late after 1 year. Then you have to remember this. Definite is patient's acute coronary syndrome with angiographic or pathology confirmation thrombus. The angiogram done, you have thrombus. Second, probable, unexplained death within 30 days or MI involving target vessel territory. But you did not do the angiogram. If you do angiogram, you would have made it definite if thrombosis. But otherwise, you see that there was a unexplained death in 30 days or involvement of the infarct vessel, but without angiographic confirmation. Now, any death occurred, patient with a stent, DES, patient died 6 months later. What will you call it? Possible stent thrombosis. So these are the, remember these, timing and this, 100% one question will come to answer that for this. Patient present with chest pain, troponin 0.4, found to have multivessel CAD of distal left main, which is 60%. There is a distal 60% LAD, mid RCS 60%, but no evident disease in the circumflex. What should be done next? CABG, FFR measurement of the left main to LAD, FFR of the left main to circumflex, medical therapy, stenting of the LAD stenosis, measurement of left main stenosis with FFR. So basically what they are trying to say is this patient has a multivessel disease, looks like, and you want to see, is there a left main disease? Significant, it's not clear cut here. So what you do? FFR into the circumflex. If you go to the LAD, additional lesion of the LAD will confound your FFR, combination of left main. So in this case, you will go with the FFR of the circumflex and see. Okay, which one it is, Medina? Right, it's A, 111. Very good. No, sorry, no, none. 011, right? Nothing here and both, 011. Okay, following mechanism may lead to images shown. What is happening here? Yes, which could be positive arterial remodeling, decrease in plaque due to dissolution, stent under expansion, ABC are correct, none of the statements is correct, right? So it could be ABC, all 1, 2, 3 are correct. And this is basically positive arterial remodeling, dissolution of the plaque, under expansion, how we define, I have made it here. Now, these are the pressure tracings, 1, 2, 3, 4, and 5, right? Catheter kinking. This is your catheter kinking, right? Dampening. This is your the normal aortic waveform, right there. Normal ventricular waveform, right there. Ventricularization. This is your ventricularization. Okay, good. Then, patient admitted with progressive angina, have a LAD and diagonal lesion, 2.7 millimeter diagonal takeoff, almost 90 degree. Operators are considered a two-stent approach and wish to perform lesion preparation with guide wires in both vessels. Which of the following would not allow the operator to maintain two guide wires during lesion preparation? Rota, laser, cutting balloon, intravascular lithotripsy. Yeah, only rota, not laser. You can do a laser, but not the rotational atherectomy. Okay? Then, following statement is true for BVS versus DS trials at 3 years. BVS the lower MI. I don't think they will ask this question because we know that BVS was higher latest than thrombosis compared to DS. That's why it got out of the market, as you can see here in the trial. Now, this is questionable. We may ask many times. Predictor of successful quick CTO recanalization based on JCTO score. Previously failed PCI, tapered stump, band more than 45, calcification, occlusion length more than 20 millimeter. Yeah, tapered, right? So you need an ambiguous cap. And these are the criteria of the JCTO score, which we have said here. Now, patient with Excel trial of the left main, MACE at 3 years, similar between CABG and PCI. CVI was significantly higher in CABG versus PCI. Higher mortality trend from 30 days to 3 years in PCI versus CABG. The TLR was higher in the PCI versus CABG. Stent thrombosis rate was lower then graft closure rate at 3. So what is XF means? What is wrong in this particular case? Answer is wrong. CVA was not significantly higher in the trial. As you can see here, stroke was 2.3 versus 2.9, did not make a statistical significance, but death rate, repeat revascularization, MI was identical, and stent thrombosis there, because they call a graft occlusion as a thrombosis there. But most important was not a higher stroke rate in the XL at 3 years. At 5 years, there was lower mortality. That's the key. Indeed, there was a trend here, and then at 5 years, this number became 11 versus 6.5. So clearly, there was a significantly lower mortality in the cabbage group compared to PCI in the XL trial at 5 years only. And you can say here 5-year estimate right there, MI, revascularization and stroke, and the death rate, and so on and so forth. Now, a randomized trial comparing IFR with FFR stable CAD showing the following results at 1 year. FFR had high mortality, IFR had higher revascularization, FFR group had lower revascularization, similar outcome between two strategies. IFR group had higher procedural side effects. Actually, procedural side effects are in FFR because of adenosine, right? Therefore, the answer is similar outcomes between two strategies they need to know, and this is what we know, defined flare, that both of them, IFR, FFR group at 1 year, IFR sweetheart, same way, identical outcome at 1 year in both the trials has been shown. Now, if you think about, only question was that use the patient, number of patients who then underwent revascularization in both the groups was about 6% lower in the IFR group compared to FFR group. So that was the total number, but overall outcomes were identical in both the groups as you have it. Now, patient available data, PCI is an acceptable alternative to cabbage in treatment of left main in following scenario except that which is wrong. Left main bifurcation, syntax score 25, left main with additional proximal LED disease, left main trifurcation with additional RCA disease, left main with additional LED and RCA lesion with syntax score 29, left main lesion with long-term survival less than 1 year due to cancer. So question they're saying that in which case your PCI is acceptable alternative, all should be good except one which is wrong. Yes. So clearly that once you have the trifurcation with additional RCI, it will be already 32 plus syntax score, and it is those should go for surgery. Patient guide wire has been advanced across the severe stenosis. However, several attempts to advance 1.5 balloon across the stenosis have been unsuccessful. Which of the following next step is least helpful? Least helpful, not more. Attempt to advance second guide wire, use of guide liner, use of laser ablation, use of a microcatheter to exchange for an extra support wire. Right? I mean, question is, your one wire is not going, how can your second wire go? It is not going to go. Then, class 3 angina, FFR of isolated 50% angiographic LED disease and found to be 0.65. No non-visit testing results were available. Operator elected to PCI the lesion rather than instituting medical therapy. What would the OC rating for this patient will be? 50%, no medication, no ischemia, no stress test, and FFR is 0.65. Rarely appropriate, inappropriate, maybe appropriate, appropriate, or insufficient information to decide. C, appropriate, and that is what the guidelines are. Basically, that once you got the FFR positive, this associated with it's appropriate. Then, following are the ideal clinical scenario for IV cannula use, except which one is wrong? MI, cardiac shock, patient with DS 1 month ago needs urgent spine surgery, patient with high-risk angio feature, stable pace CAD patient with 90% proximal ACC type B2 lesion. So condylar is good for as a bridge, patient going for surgery, or patient with a complex CAD. So E is a very simple case. You don't need the cangrelor for that. And this is basically where we are, that cangrelor is a 2B still, never a class 1. You need to remember that patient with undergoing PCI who are P2Y inhibitor naive, IV cangrelor may be reasonable to reduce periprocedural ischemic event. They still made it 2B, and so. And as you can see here, and other indications of the various P2Y12, I have made it there. And these are the indications. It's a good for elective bridge, non-cardiac surgery, patient required depth, MI, hemodynamic instability, poor absorption status, cardiogenic shock, ACS and ischemic heart disease with multiple high-risk angio features like bifurcation, thrombus, 3+ stents in calcium. MI, awaiting cardiac surgery, urgent non-cardiac surgery, hip fracture, GI surgery, and there you give, the dose is lower when you use at a bridge compared to what we are giving it otherwise to the high-risk PCI group, which is our bolus 4 microgram per kilogram, 30 and 4, infusion for at least 2 hours, and then if you continue 0.75 and so. And otherwise for do a bridge is only 0.75 milligram per kilogram without any bolus, which is used for 3 to 4 days in these patients. Now, patient develops sudden flow, slow flow after PCI with dissection. Next step is stent, nitroglycerin, nipride, verapamil, or TPA. Yeah, so key is nitroglycerin does not work with slow flow. Verapamil works for slow flow, but what is the dose? 50. It should be 200. Nipride is 50 microgram, and TPA will never give it. Okay. Then patient PCI, 70% lesion in the LAD. Patient was on heparin eptifibatide. When you are informed, ACD is 170. The correct next step is, this is basically in the original trial, that 25 microgram per kilogram you add additional dose. Now, make sure you remember this table. Question will come in one way or other. In terms of epsiximab, long platelet half-life, and there is no plasma half-life. So whatever epsiximab you give, it's no longer available anyway now, but the theoretical point of view, it is taken up by the platelets, so there is no free platelet drug. So how can you neutralize the bleeding? You give platelets. Compared to a small agent of tyrofibin eptifibatide, short half-life, plasma half-life is long, and much receptor, too much drug in the body, in the circulation. So you give platelet, these drugs will go again on the platelet, so no good. So if you need to take care of the tyrofibin eptifibatide, you do hemofiltration. But epsiximab can be taken care by giving a platelet transfusion. So this you need to remember clear. Now, 90-kilo patient was on enoxaparin for ACS with aspirin and clopidogrel. Last dose of the enoxaparin was 7 hours before PCI. Your best option is PCI without extra anticoagulation, give 2B3A, proceed with PCI, give 2B3A and heparin, add enoxaparin 30 milligram IV and proceed to PCI. So this one is because within 7. So 8 hours is the limit. Between 8 to 12 hours, you give 1/3 the dose, should have been 30 milligram. Remember, 90 was the bolus, given initially, so should have been 1/3 if they would have said. It is patient now 10 hours after, so you give 1/3 bolus. Arterial remodeling, what is true, because basically what has shown that our atherectomy and balloon angioplasty, what they do, they shrink the vessel. And stent maintains it, and that happens with the restenosis. So that's the question, that once you have the balloon or atherectomy, the vessel decreases, shrink. There's some intimal hyperplasia, but there is a more vessel negative remodeling. And no restenosis, of course, with the stent. And then what happens with the stent? All is the intimal hyperplasia. It does not recoil. So that's what you need to remember, the case type of they may show. So then, this is where commonly question comes. The patient had a PCI before and now calls to arrange for a diagnostic cath, and he sees which of the following statement is true. So asymptomatic patient with follow-up, we have many of the follow-up angiography we do, and they actually ask you, before you do it, that are you planning to do PCI based on some tests? So I answer there is asymptomatic, even severe stenosis is not an indication for PCI. So patient is 75% patient angiographic restenosis develop symptoms, stent restenosis rate is reduced by 60%, progression of asymptomatic restenosis is excellent. So that's the key. And then it is not indicated to decrease the event. Okay, 50-50-30. Then I told you 82-year-old female died in sleep, nursing home 18 months after implantation of the DES. So what it is? Right? 18 months, very late stent thrombosis in this particular case with the possible, not probable, possible, because just died in sleep. 57, bypass for 3 vessel disease, 12 hours after surgery, patient becomes short of breath, 3 millimeter ST elevation. Basically what they're saying is, patient who develop ST elevation post-PCR, post-CABG should come to the cath lab and we should take care of them. That simple is the one that now you do angiography for those cases. Then patient FFR on side branch or more than 50% angiographic residual narrowing after stent implantation, following true. We know that many times you have 50% angiographic, but your FFR is normal in large majority of these patients, and that basically shows that FFR value, and you do not do anything for those lesions. Then these are champion trial, basically of IV cangrelor, basically showing 20% reduction in MACE and no difference in the severe bleeding, which have been shown by all the champion trials which I have shown here. The bleeding, no difference, but decreased event. Pioneer AFib PCI trial, the undergoing PCI to rivaroxaban or warfarin with both groups receiving antiplatelet therapy for pre-specified duration. At 1 year following, what were the main findings? Stent thrombosis were similar. Irrespective of the depth, rivaroxaban dose, warfarin was associated with a higher rate of clinically significant bleeding. Frequency of major ischemic events, including death, tended to be higher with warfarin. Together, ticagrelor and prasugrel were more commonly used with clopidogrel as part of the used then clopidogrel. Rivaroxaban dose 20 milligram daily with clopidogrel 75 milligram daily. So answer is B. Irrespective of depth, rivaroxaban dose, warfarin was associated with higher bleeding. And you know the dose of rivaroxaban was in this Pioneer AFib, it was 15 milligram and 75 once you gave the clopidogrel. Now, patient has comes in, hypertension, tearing chest pain, clearly looks like patient has aortic dissection, creatinine is 3.9. What would you do? TE, no MRI. People say MRI, no. MRI is very difficult. Gadolinium still can cause the trouble, so clearly there. This is about the process of atherosclerosis in the malposition, and you will see there. Let's take this case. Yeah, this patient actually, this is good. Many of them are the long cases, like patient, a story like this patient has the patient with angina 7 years ago, and CABG was performed as emergency situation with the vein graft to RCA, and then vein graft to the first marginal and vein graft to LAD. Calcific subtotal left main trunk. The 3 year prior to current presentation, intermediate lesion of the SVG to LAD and SVG to RCA were seen on coronary angiogram but treated conservatively, while a PCI with DES was implanted in the SVG to marginal branch to treat critical lesion. Now, current angiogram shows that the SVG to first optical marginal is patent, SVG to RCA is occluded, and SVG to LAD had an extensive disease. Which of the following is most appropriate? SVG atherosclerosis remains the primary cause of graft failure. Sealing of intermediate lesion with DES implantation is safe, but it's not associated with significant reduction in cardiac event. Reoperation of CABG is preferred for patients with extensive disease, and IMA graft is available are the conduit of choice for the redo CABG. So question comes down to that when you do vein graft intervention, even the intermediate lesion of 40-50% data have shown should be stented, because otherwise you have a higher event rate on those patients that follow up. Okay, so in this particular case, everything is correct. Then the patient, elderly patient with stable angina, found to have an intermediate stenosis LAD FFR 0.7. PCI is successful performed. Risk of death, MI, urgent revascularization following PCI is best described as the following. So what happened to this patient where your FFR low, you put a stent. Similar to the risk of patient with FFR of more than 0.8, similar to the risk of patient with FFR less than 0.8 treated with optimal medical therapy. Her risk is minimal as her CAD has been resolved, higher than risk with optimal medical therapy due to risk of stent thrombosis, and unchanged. So basically what we do, once you're treated, it's just like when with FFR of your 0.8. And then remember what's shown, that risk of patient with FFR of less than 0.8. This is our FAME2 trial, which was aborted because patient with an FFR of less than 0.8 on medical therapy in 6 months had an event rate of 13% versus stent of 4%. So the trial was aborted after 6 months. So therefore, this is not the treatment there. Okay, so this is the patient, comes in, ER, dizziness, patient calm, 48 hours was refusing to seek medical attention, vital signs, tachycardia, hypotension, cold extremity, given IV fluid, did not improve the BEP. Patient started with norepinephrine, blood pressure got a little better, escalating doses required, troponin positive. You are called in for an emergency coronary angiography, apart from early revascularization, what else would you consider at this point that will significantly help this patient? So basically, hemodynamically unstable patient is not kind of getting cardiogenic shock, but not there yet. Because cardiogenic shock, they say persistent lower blood pressure less than 80 for 30 minutes. Okay, that you need to remember. 2B3A, intubate and sedate, proceed with emergency angiography and PCI, start dobutamine. After diagnostic angiogram, consider placing a hemodynamic support device before PCI. And that is what we do, and that's the answer. Okay, patient with heparin-induced thrombocytopenia, following agent could be used. Yep. Basically, the question is you can use both bivalent and ergotrovan. Following are predictors of calcific lesion, kidney disease, old age, diabetes, left main Hispanic race. Some Hispanic race have a less calcification. Long-term DAPT in the DAPT trial associated with the following, except basically not significantly lower mortality. Then Excel and Novel trial, we know difference basically was that MACE outcomes, one associated with higher CVA. Only one trial, Cabbage versus PCI, the Novel trial showed higher CVA compared to PCI, compared to Cabbage in these patients. Then Syntax 2 study concluded the following, which we talked about earlier, that outcomes of the PCI similar to Syntax Cabbage group. Now, COMPASS trial, aspirin rivaroxaban versus aspirin alone, stable CAD showed the following outcome except lower death rate, lower stroke rate, higher major bleeding with aspirin, rivaroxaban versus aspirin, higher intracranial ISTH criteria bleeding, and then higher fatal bleeding with aspirin, rivaroxaban, but answer there is E, the fleeting, in this combination was a higher bleeding occurred in those cases. DK Crush 5, distal left main, following except. What is not is the D. 2 stents were compared with 1 stent strategy in all cases. No, 45%. And remember the following except, which is wrong. Wrong is not the in all cases. It's basically, we know the 45% in the other group got the stent also. Antiplatelet therapy except. Okay, this is a question they will ask. Use the loading dose of clopidogrel when switching to ticagrelor. Use the loading dose of prasugrel when switching to ticagrelor. Always use the loading dose of prasugrel when switching to clopidogrel. Switching strategy is different in acute and late phase. Switching from IV cangrelor to clopidogrel should be done immediately after terminating the infusion. Clearly that is true, right? You wait almost half hour after terminating the infusion of cangrelor. But while infusion is going, you can use ticagrelor because of different pathologic mechanism. So question is, and of course switching strategy is different. Acute phase, you still give the same loading dose. In a chronic phase, you may just give lower loading dose like clopidogrel. You can give only 150 and so. So answer is, if you are going from our clopidogrel or prasugrel to ticagrelor, you have to give full loading dose. If you are already on clopidogrel before, your loading dose of prasugrel is 30 milligram, half. So that is the answer. Okay, FAME3 trial. PCA, what was the true about the FAME3 trial except? So it means which is wrong. Multivessel disease, PCA all lesions with FFR less than 0.8, Cabbage all lesions with FFR less than 0.8, PCA with left main lesions were excluded, Resolute DES used during PCI. What's the answer? C, Cabbage, FFR was used only for PCI group. Cabbage guys, surgeons didn't go after the FFR. They saw 50% lesion, they said we'll do bypass. We don't want FFR or so. So FFR was not used in the Cabbage patient. Okay. Randomized trial of CTO have the following results. Improve MACE, lower MI rate, improve LVEF, lower end diastolic vessel, end diastolic volume, and none of the above. None of the above. Okay? Every trial have been negative. Then, stable angina, coronary angiography, single RCS, 60%, FFR is measured 0.8. What would be best said about this patient? PCI is not indicated until medical therapy fails. PCI will decrease the need for subsequent urgent revascularization. PCI will reduce progression of disease. PCI will reduce mortality. B, right? Because this is your FAME2 trial patient. Medical therapy, 13% event at 6 months versus 4%. That following statement truly reflect the finding of correlation of angio, IVUS, OCT for detection of lesion calcification, and then basically they say that sometimes calcific lesion, similar stent expansion versus less calcified lesion is again wrong because severe calcium does not cause expansion, stent expansion. And then reflect the current data on the use of potent P2Y12 after ACS PCI. Perceived and higher stent thrombosis with clopidogrel, higher MACE rate with clopidogrel. There is higher stent thrombosis with the potent P2Y12. There is higher bleeding with the use of potent P2Y12. They are frequently used in post-ACS currently. So answer there is higher bleeding rate with use of potent. So what they are saying is the use of truly reflects the current data on the use that there is a higher bleeding rate with the agents. Okay, ACC guideline. Patient left main stenting in a patient with ostial left main disease. Syntax score is 15. Operative mortality 5. It's a class 1, class 2A, class 2B, class 3. Unprotected left main. Class of, the question will come down to that ostial left main disease has become a class 1 indication now. Past it used to be 2A. So I don't know whether this question will be asked because the 2024 guidelines has become class 1. Ostial is now a class 1 indication. So this is maybe an anomaly. We may not be asked that question. Shock trial with a cardiogenic shock, it basically showed early revascularization therapy associated with a 20% reduction, except with a higher mortality in elderly patient. Okay. Using a bifurcation stenosis, use a two-stent technique is reasonable in the following scenario, except which one is wrong? Parent side branch, both severe disease. Side branch, large significant vessel. Side branch is likely to become compromised after initial main branch stent and associated with ischemia. Side branch can be easily accessed after main vessel stenting. So which case we are saying use of a two-stent technique is reasonable in the following scenario, except. Right? I mean, if your side branch is easily accessed after main vessel stenting, there you can decide still. If cannot be accessed, then you go with the two-stent approach. Then does not reflect important use of the associated imaging technology prior to planned PCI. OCT and ostial left main, IVUS and stent diameter selection, IVUS and prediction of emboli, IVUS and stent optimization, basically OCT and ostial left main. They want to say ostial left main, OCT will not do anything, so take that out. Okay, so I think this one kind of has seen Excel trial, higher 5-year mortality, similar 10-year mortality, similar 5-year mortality, and higher CV at 5 years. Noble, clear, right? A similar 10-year mortality, pre-combat. Excel trial, a 5-year mortality, higher. And similar 5-year mortality in your Syntax trial. What is the inner lumen dimension of the commonly used 6 French catheter? You have to remember that 0.072. What can you note most appropriate strategy of the underexpanded DES? None of these except the shock wave. Okay, OCT, delineate, then IVUS, which is better, in particularly your calcium thickness, which we know. Okay, coming same question, stent thinness strut is C or 0. Biodegradable polymer, which one? Synergy, very good. Side branches, we talked about that which case, based on the dedication, that you are going to need the stent of the side branch when region length is more than 10 millimeter. The left main bifurcation, of course, it happens at the level of the circumflex, the most common. Then this is actually optimal management is nothing significant. So E, non-culprit vessel in acute, remember what they say, stress test is not needed nowadays, except that stress test is essentially needed, no. Now we know acute MI, multi-vessel disease, as you saw in my earlier presentation, culprit vessel, PCI, followed by you stage or same time, you do additional vessel PCI. No need to do any imaging test for that purpose. Coronary perforation for the CTO, which you need to remember that it can occur late. Very important, they need to say that it may develop hours following the interventional treatment. They want you to know, maybe they'll give you a scenario of that kind. So this is the patient, 3.5 creatinine of 3.5, 70% ostial RCA. Statement is false with regard to planned PCI with contrast nephropathy. As we know, calculating the estimated GFR via formula is most accurate way predicting the bad outcome. Patient with a calcific mid-RCA lesion, Advancing the stent, unfortunately, your guide catheter wire and balloon abruptly fall out of the vessel. You note that the stent seems to be left behind, halfway pushed into the lesion, and the patient becomes ischemic. Your best option is what? Call for surgery, attempt to place a wire through the stent followed by a low-profile balloon, attempt to snare a stent, pass a wire adjacent to the stent, and compress the stent against the vessel wall is the right way, because patient is ischemic. In a controlled situation, you can try to put a wire and put a small balloon. Patient is ischemic, then very clearly go balloon, wire side by side, put a balloon, and then stent. Rotational atherectomy, this you will know, that no randomized trial showed lower restenosis. And then factors associated with the coagulation not released from the activated platelets, which is the TPA. So this is the case, patient planning to have thyroid mass removed. Patient has medical history, right coronary approximately 8 years ago. 5 years ago, she had aortic valve replacement using St. Jude's prosthesis, and patient has been on a stress echocardiogram showed some anterolateral ischemia. His protamine, INR is 2.9. Which of the following plans should be implemented for her to undergo coronary angiography? Admit the patient to hospital, discontinue heparin, start bivalodin, discontinue warfarin 3 days before, and then measure the protime on the day of planned catheterization. Continue warfarin, use 5 French diagnostic catheter, administer fresh frozen plasma, admit the patient to hospital, discontinue warfarin, and begin enoxaparin. What we usually do, that we do 2 to 3 days, and then you admit the patient and do the PCI. This is usual. The natural anticoagulants include protein C, protein S, and TFPI. Make sure that you remember them. Natural anticoagulants in the body are protein C, protein S, and tissue factor pathway. This is basically a straightforward, simple case of the right coronary artery that looks like had a spasm. Now, this is good. This patient, treadmill test, recently has some main good exercise symptoms, 4 minute, develop 1.5 millimeter ST segment depression, recovers fast, no chest pain, nuclear imaging demonstrated impaired coronary flow reserve in the anterior anterolateral wall, left ventricle with mild dilatation of the post-stress imaging. So basically, when say coronary flow reserve, if we say it is less than 2, okay? 2 is the criteria. Because he is asymptomatic, you can recommend continued medical therapy. You order a cardiac MR perfusion study to confirm the myocardial ischemia. You schedule a coronary angiogram and revascularization. Question is, what should we do in this particular patient? And you see. Why? Because mild, but there was a cavity dilatation. That's the clue. They probably have a more significant disease. You need to do the cath. Okay. This is the patient. Patient prior MI came 2 years with a moderate exertion, no unstable angina. Coronary angiography demonstrated 20 millimeter long calcific, total occlusion of the mid RCA with bridge collaterals and Rantrop grade 2 collateralization of the distal vessel from the distal artery. Select the best management. The CTO of the RCA, this the patient has symptoms of stable angina and moderate exertion and no unstable features. Okay, that's what they're giving you already scenario. There has been a no stress test. Rotablation, pre-dilatation with the DES, local infusion fibrinolytic, none of the above. What are you going to do in this case? None of the above. Discharge the patient on medical therapy, no PCI. This basically is from our old relief of angina is better with cabbage. Cabbage and medical therapy trials may not have this question now. Another one is randomized trial of cabbage versus PCI in multiple. Please answer true or false. Majority of patients have preserved LV function is true. Triple vessel disease present in majority false. Repeat revascularization is PCI true. Majority of patients undergoing PCI were treated with the stents, false, because many of them were balloon at that time, and single vessel disease, no, it's only multi-vessel disease. Okay. Most common CTO, right coronary artery. This one again, ACCHA classification, which I said you need to remember, ABC. So the question is true regarding the influence of the lesion length on ACC. Lesion length of less than 10, type A. More than 2, type B1. More than 2 is type B2. Lesion 10 to 20 in length represent AHA ACC type C lesion. So question they're saying, which one is true? Yeah, so question is why we have to B1, B2. So they're saying B1, B2. Clearly that you're more than 20 millimeter, because your class C, anytime you got a more than 20, it became C. So lesion length 10 millimeter, ACCHA type A lesion, and this is the criteria. More importantly, you remember that type C, diffuse, excessive tortuosity, extremely angulated, inability to protect major side branch, and degenerative vein graft. These are the 5 features of type C, and they will ask you one way or other. This one was a simple question. Then another one, P2Y12, which is the specific platelet inhibition test, is light transmission aggregometry, LTA. Prasugrel compared to clopidogrel is basically all of the above. We know from the trials of Triton, they may not ask that question now. And we know that anytime they give you scenario of the prasugrel and the patient has just see the TIA or stroke, your answer will be that change prasugrel to clopidogrel. Remember that, a very important point. And so then this true, following is true about ticagrelor, is basically B, that clopidogrel inhibit platelet aggregation to a greater degree compared with ticagrelor. No, ticagrelor inhibit platelet inhibition more. The Plato trial will clearly showed the benefit. Triton TIMI 38, it basically was that incidence of stent thrombosis was similar in prasugrel and clopidogrel. No, stent thrombosis was higher in the clopidogrel group. Then should be given at least 12 months. Dual antiplatelet therapy, which we know A and D, 75 milligram, or prasugrel or ticagrelor you can use. And these are basically our guidelines are. The patient has radial assigned to examine excess site bleeding in a radial or femoral approach. Crossover occurred in 5% of the radial group, 2% in the femoral group. Which of the following is true of an intention to treat analysis? Patients are analyzed according to the access site, received intention to treat, not as per protocol. Remember there are 2. Per protocol comes into that, intention to treat that we gave into type A and type B. But 10% in the type A could not get that treatment. So that is intention to treat, but not per protocol. Per protocol was supposed to be that treatment. So therefore, in this case, that is superior to a per protocol analysis for maintaining the benefit of the randomization process. So that's what the question they're asking. A frequency of cardiogenic shock, which is okay. CTO, well collateralized, we have spoken about those patients. CTO PCI success rate approaches 90%. Patient multi-vessel CAD, dominant, which vessel is least likely to have a positive FFR? We know that, right? It's usually circumflex. 90% lesion, usually FFR is negative. And this question is, clinical event on the IVUS, the most common is your lumen area is less than 4 and plaque burden is more than 70. You need to remember this along with a thin cap fibroatheroma. These are all came from the prospect trial. Then, this is actually good. The patient has a risk factor, diabetes, PCI of the LAD are done. The final angiogram showed well expanded stent with TIMI 3 flow. The following morning, a routine troponin was done 1.5 nanogram, which is high. Patient remained asymptomatic and his cardiac examination was normal. His EKG showed non-specific STT wave changes, which were unchanged from the admitting EKG. Best course of action is for this patient. Now, patient has some asymptomatic troponin elevation. That's basically the case. So what you do, discharge the patient on medical therapy, bring the patient back to cath lab, transfer the patient to a CCU, continue to monitor the patient telemetry, or another set of troponin 6 to 8 hours. If trend, then you discharge. That's the answer. That you cannot send patient, we have elevated. Troponin is a trouble because peak occurs maybe late and remains high. But CKMB, that once you go, it starts going down, then you discharge the patient even if they are still elevated. So that's the answer is number E. This one is actually the various values which I have put it together, which is here. What they call positive predictive value and true positive, false positive. I have put all those numbers and go through this exercise. Then the patient, patient who has a question was that patient otherwise independent, looks like has some Alzheimer's disease. You want to make sure that patient is fully competent before you take to the cath lab. rationale shown. Delays in primary PCI with the highest mortality, door to balloon, symptom to balloon, and symptoms to door time. Symptoms to balloon time is the highest one, which we know have been various trials. Horizons AMI, supported by findings from Horizons AMI, stroke rate was similar, MACE similar, major bleeding is lower with bivalvulotin, acute stent thrombosis was similar between two groups, revascularization rates were similar in two groups. Anybody answer? D, acute stent thrombosis was higher with the bivalvulotin group compared to your heparin. So this patient basically showed that patient had a PCI and a tight lesion, 2.5, reluctant to place a BMS out of concern of restenosis. So you proceed with second generation DES, most appropriate antiplatelet therapy. What do you give? So question basically remain. This is the patient who is worried about taking the long-term medications, has some mild dementia. So what we do is a stable patient, clopidogrel could be given for 3 months. Answer could be best 3 or 6 months is okay. And these are the guidelines from there. This is another simple case which you'll see. No need for cath, particularly which have a decrease in their capacity. This is a patient about the bioabsorbable stent that patient should go to knee replacement because they have some lesions which negative stress test. Lesion there, negative stress test, patient can go for revascularization, which we know. So this is another patient with occluded vessel. So PCI need not to be done, which we have shown. I'm just going to go through some up to 150, then we stop. So then this is the patient. IVUS and FFR studies show an FFR of 0.86, 70% cross-sectional area, IVUS with minimal lumen diameter of 2.1 and minimal lumen area of 4.2. And then she is still asymptomatic and returns to your office wanting your opinion regarding revascularization. So IVUS data demonstrate a clear indication for PCI. FFR indicates a benefit for proceeding with PCI. Both the IVUS data and FFR data indicate a benefit with PCI, and both IVUS and FFR data indicate a likely good prognosis with continued medical therapy. What do you think? Both of them, because the key is that you have plaque less than 4, lumen more than 4, right? The 4 is the cutoff. So more than 4 here, don't worry about the MLD. It's the lumen area, 4.2, FFR 0.86, and this patient will do good on the medical therapy, which we have. This one is basically bivalvulotin is a safe adjunctive therapy, rationale, I have put it there, undergo coronary angiography. So okay, the patient with non-STEMI, patient has blood pressure good, ST segment depression, and excellent quality. He has long-standing diabetes, creatinine is 1.9. When should we go on undergo coronary angiography? Should never undergo coronary angiography, should undergo early invasive strategy within 72 hours. He should undergo immediate invasive strategy within 2 hours. He should undergo an early invasive strategy within 12 to 24 hours. And he should undergo an ischemia-guided therapy. So this case is a non-STEMI, right? And then patient has other diabetes. So therefore, it's a high-risk situation. So this case is that undergo early invasive angiography within 12 to 24 hours, not the immediate, which has not been shown to be beneficial. So this is actually, I think we can go further in this one. So this is basically the same. Patient has a TIA. So they're saying that you stop prasugrel and start ticagrelor or clopidogrel, whatever you wanted in this case. Then patient with a high rate of annual cardiovascular event, non-invasive testing is consistent with high risk features. So which one are the high risk features? In this particular case, EF less than 35%, and that actually those are the criteria which have been shown high risk. Then indication for invasive coronary angiography will be in this patient, 55-year-old who successfully resuscitated from ventricular fibrillation. That you want to know, that patient who is resuscitated should go for cardiac catheterization. Then this patient has a nuclear perfusion imaging, recently began exercising, health good, maintenance, developed 1.5 chest pain during nuclear imaging, demonstrated impaired coronary. We saw this case. This we had to remove already with the angiography in the case. Okay, this case about the radiation. So the radiation CAD, which you need to just remember that it is actually they're saying which of the following would be not be appropriate management: medical therapy, bypass surgery, PCI, and extracorporeal. So you need to do something. Your ECP is not going to work in this particular case. Periprocedural MI and biomarkers, you'll see here is the relationship clearly associated when more than 3 times with the follow-up higher event rate. Patient, diabetes, and then patient has a smoker, non-STEMI, PCI of the LAD, planned for radial access PCI. Which anticoagulation regime would minimize the risk of bleeding complication? Very important question. Which heparin, bivalodin, low molecular weight, fondaparinux, and none of the above? None of the above. Radial, every trial has shown. Once you get to the radial, irrespective of the antithrombotic therapy, was beneficial in every trial, has been shown. Okay? And then, this is, we already have spoken, saline is the most important for hydration. Then, other question comes out that patient artery open, in the stent era, all factors have been correlated with abrupt vessel closure, except you've done a good PCI. What are the predictors of abrupt vessel closure? Stent length, small vessel, poor distal runoff, excessive tortuosity, unstable angina. What's the answer? Predictor of abrupt vessel closure. You can say stent thrombosis or so. Will be excessive tortuosity is not, except means which is wrong. Excessive tortuosity may make your procedure unsuccessful with the balloon angioplasty, and so with the stent, tortuosity is no longer the risk factor. So this one is patient interpretation. Invasively, that what do you see in this case? Neointima, restenosis due to excessive formation of neointima, optimal results with a thin layer of neointima, single stent fracture, stent under expansion. There's clearly large layer of the neointima because stent are here. The neointima in this particular case is the cause of this trouble. Okay, the patient has STEMI, pulse is gained, unconscious, but has a EKG 2 mm ST segment elevation. Remember we talked about that patient resuscitated. What you need to do for these patients that they have to go to the hypothermia and primary PCI. So clearly the hypothermia, particularly you have out of hospital cardiac arrest, as we know we usually do hypothermia and then do the PCI or cath few days. So this is about the same antiplatelet assay being the D this question they ask because they are very interested. What we know usually for clopidogrel, you may not know this part. The following mechanism lead to inhibition of the platelet function following treatment with P2Y12 receptor inhibitors such as clopidogrel. So question is leads to inhibition. Reduction of cyclic, increased phosphorylation, inhibition of phospholipase, inhibition of adenyl cyclase, and inhibition of protein kinase. So basically is increased phosphorylation of vasodilator VASP as well as CMP, not decrease. Reduction is wrong. CMP and VASP both are increased, but here A is wrong because they're calling the decrease is no longer. 2-year outcome eruptive, so also eruptive versus non-eruptive atheroma, the nodule, calcific nodule on the OCT, what is incorrect means the same. Which one is incorrect is lower TLR in eruptive versus non-eruptive. No, higher TLR in the eruptive atheroma compared to non-eruptive. And these are the individual factors which we have put it together here. Okay, getting to the last one, UK BCI CHIP score, which correlated higher in hospital MACI. Age, PAD, COPD, CKD, usual rotational atherectomy. Which one is not part of it? Remember I showed you yesterday that graph of the BCH. COPD is not part of it. In this, clearly, these are the 7 patient factor, 6 your left the angiographic factor, and so. Okay, statement flavor trial, which we already see, lower MI rate with FFR versus IVUS, that is a false. They're all similar outcomes as in this flavor trial, comparing IVUS versus FF guided PCI, and you see the outcomes are similar. Complete trial of STEMI. Following statement is false. Primary endpoint, lower in complete versus culprit. Primary endpoints of death MI are lower in complete versus culprit. Immediate complete revascularization was superior to delayed revascularization. Lower ischemic revascularization complete versus culprit, and timing of delayed revascularization was up to 45 days. Yeah, clearly, the immediate complete revascularization as well as the delayed in this trial was identical. There was many other trials done, BioVas and Multistar, showed if the stage was bad. But in the complete trial, both stage or, done at the time versus immediate versus stage were identical outcomes. In the complete trial, as you can see, these are the individual outcomes, and number needed to treat, complete during initial hospitalization, and after initial hospitalization. As you can see, the benefit of complete was identical in both the groups, the initial or follow-up. Okay. Ischemia trial of stable disease, false statement, primary endpoint of death MI, similar, incidence of overall MI was similar, approximately 25% patient underwent invasive approach, angina frequency was lower in the invasive group, and incidence of spontaneous MI was similar between two strategies. So they are saying which one is false. The otherwise question could be following is about the ischemia trial or true accept. So it's the same thing, accept or false is the same way. So what is wrong? Ischemia trial, major trial, spontaneous MI after PCI was lower compared to, in the ischemia guided in the interventional group was lower compared to conservative group. So E. So randomized, remember, and about 1/3 of them, 25% require, even in the revascularization, 23% require in the control group require revascularization. The second question was, and the third question, overall outcomes were not different in the p-value point of view, but your procedural MI higher with the invasive, but spontaneous MI. Look at this one, p-value less than 0.01, significantly higher in the conservative versus invasive group. And then angina benefit was much higher with the interventional group. Okay. Yeah, this we have spoken. I think we had to just remove, I had to remove this question also, which we had already talked. This is, I'll take out there because this is where I have shown the slide now, everything else in this. Now, the following are the true statement about diagnosis of ANOCA and its treatment accept. CFR less than 2, IMR more than 25, that's a microvascular dysfunction. You need to remember. IMR more than 25, CFR less than 2, spasm 90%, myocardial bridge is rare cause of ANOCA, MVD, which is accept, means which is wrong. Best treated by beta blocker and celestazole, endothelial dysfunction is diagnosed by mild narrowing of the coronary vessel with 50% reduction. Answer is best treated by beta blocker and celestazole is wrong because many of them have spasm. These are the various pathway of the ANOCA, which I have put it together. All right, let's get to the last question. Following statements are true regarding type 2 MI versus type 1. The true accept, which one is wrong? 2 represent heterogeneous, 2 has lower in-hospital mortality, 2 patients undergo higher invasive coronary evaluation, 2 patients are older, and 2 patients have more non-cardiovascular comorbidity. So remember, 2 does not get that many angiogram, so C is wrong. And these are the type 1, type 2 criteria. I put it together, and their subsequent prognosis, and these patients, how we deal with them, and that basically is the secondary. With that, I think we just stop here. And there are other, I think a few more questions are there. One, this is the way we already have with the radiation. I think some of them just get a little overlap. I have to just take care of that. This is a calcific nodule, an eruptive, which can give rise to, this patient can have a more intraplaque hemorrhage, which is C. And then the other one is identify major criteria of the definition. Remember, we say the lesion length is associated with left main side branch stenosis of 70%. Those criteria you need to remember. Pot, because you have to do rightly before the bifurcation, otherwise can give rise to trouble. Pot balloon, too distal to the carina can cause more malapposition. Then various devices, whether your angiosculp scoring, use of these spiralized balloons has been compared to rotational atherectomy. Findings can be best summarized by the following statement, that procedural success is greater with the use of rotational atherectomy. That has been in all the trials, has been seen with this. Then guide support in ensuring that limiting exercise complication, femoral arterial access with radial, the use of rotational atherectomy, which of the following statement is true. So basically is that multivariate adjustment, transfusion, major bleeding remained higher in patients with femoral access compared to radial, which is well-known phenomena. Okay, lithotripsy, severe calcific, what does it do? Micro CT have shown circumferential transverse longitudinal calcium fractures. 158, osteal RCA. Now what you do in this case? Ejection fraction is 25%, PCI of the RCA lesion is planned with the atherectomy device. Which of the following statement is more accurate? You have osteal calcific RCA. You do a left ventricular support, mandatory, or you can use rota or OA. Use of orbital atherectomy ablation is contraindicated because osteal vessel disease. Use of lithotripsy, the osteal lesion associated with the increased risk of retrograde aortic dissection, and rota extra support provides more guide support during the osteal RCA rotational atherectomy procedures. Remember, the rota support, you use it in the osteal lesion. So they're saying most accurate will be this, because use of IVL is not associated with the retrograde dissection. Orbital we do not use in the osteal lesion because of Burke otherwise can flop around and cause more dissection. So that will be D. Okay, agent DCB used for treating ISR is coated with which drug? A, B, C, D. B, paclitaxel. Second, which will be approved because this is the only one approved right now. Second is the solution, solution DA, DCB, which is coated with sirolimus. But that they will not ask the question, and so. Following factors for the stent fracture. Long stent overlapping, tortuosity, and stenting of the LAD. Answer there is not the LAD. It is the everything else can give rise to stent fracture. Last is, I think, two more left. At the time, yeah, same basically is taking about that when you do the stage PCI, primary PCI proximal LAD and stage PCI of the other vessels are the best treatment which we do in these cases. The SCAD, STEMI and SCAD, basically showing that don't do PCI. SCAD case, they show you, don't do PCI on those patients. Very important, high trouble. So outcome patients with STEMI with SCAD are worse than those with a plaque rupture. You need to know, has been shown. Then, this patient has been aspirin, and patient has, so patient got 3 months. Patient has been on aspirin ticagrelor. However, patient complains of reflux, epigastric pain, bloody bowel movement. What is the most appropriate step in this patient? Hold ticagrelor. C. Based on which trial? Right? I mean, multiple trials have shown that after 1 to 3 months, you can stop aspirin and continue only ticagrelor. Okay. This one, this patient has, according to modified criteria, lesion of the circumflex. Lesion of the circumflex is this, A, B1, B2, or C? It's C. C is so long. So more than 20 millimeter is C. So because of the 20 millimeters, I said you have to remember that, and so. So this is the case. They say that you have done the good angiogram, everything looks good, but your IFR is 0.61. I was performed, so no evidence of stent as dissection, under expansion, malopposition, otherwise looks good. So what is the most likely factor contributing to residual ischemia in this patient, and how could this be evaluated? So this patient, FFR, IFR has been done, so now what can you do? So there is something going on in this case, and that will be some focal lesion. There is not a malopposition, no dissection, and clearly that you have seen, no under expansion. So there will be a focal lesion, small, that you need to derive by both IVUS and FFR will be required. And then I think this is the last one, time of the primary PCI. Also, that once you have a CTO, at the time of STEMI, presence of CTO, your culprit vessel and presence of CTO impart poor prognosis with higher mortality at follow-up. Need to remember that. Multiple studies have shown. But treatment of PCI, the PCI of the CTO does not show any difference in terms of long-term outcome. So here will be B, so with acute and long-term mortality. And that completes our presentation. And these I showed you 162. And I can tell you when you take the exam, you will get at least 30 to 40 questions of these will come. But you have to answer total 180 questions. There are exam is 180 questions, but 35 to 40 will come from these which I have shown you today. All right? Okay. Go, enjoy. I think there is some evening some food there, and get ready for early morning. Because we have 9 cases tomorrow, complex cases.